course in ethics from Canada, and later on, I think probably he has devoted his entire career to the advancement of ethics. He is also involved with Sangat. Sangat is a voluntary organization or NGO which is working for a community which is underprivileged and which cannot be provided for, especially children with difficulties. And most of his research nowadays, he's got a lot of publication. You open Lancet, NEJM, you will have his publications. Many of multi-center clinical trials. So we'll forget about all that. His impactful lesson has been community work and guidelines which come out of that work. For us as researchers, if you go out in the community and then do the research, then you know that it is applicable to that community. Right. So generalization can be easily made to that community. That's the work Dr. Anant is doing as of now. And let us welcome him to this session on ethics in precision medicine. Whether you have questions or not, I will have a lot of questions for Anant. Welcome, Anant, and for your interesting
issues. I'm not certainly speaking on pharmacogenomics, but I'll try and maybe speak to certain issues it's come through. Certain issues which are relevant from a broader perspective of trying to understand where we might struggle with some of the issues around applications and development, etc. And I hope this will be more of a discussion. So while I'll go through my slides, I'd like to welcome any thoughts, comments from those of you who are also practitioners. But I wanted to start off this morning by asking, for most of you, when was the first time you probably thought of precision medicine? Maybe while growing up. Something which you read or something that you experienced, or any thoughts around what might be the first time we might have thought of precision medicine, especially in this country? CML, okay.
We were studying CML in PG.
CML in PG, okay. All right, okay, so that's postgraduate education. What about school, growing up? No? Okay. So let me try and see. How do I advance the slides, Shubha? Okay, this is when I tend to think that we first thought of precision medicine through mythology, right? You had a case where Lakshman was mortally wounded in the Ramayana, and then the personal physician of Ravan was kidnapped by Hanuman, brought over, and asked how can we save Lakshman now that he's mortally wounded. And so he said you need a particular kind of jadi booty, which is a Sanjeevani booty, which is only available in the Himalayas. And there is a limited time in which you have to get it, otherwise we will not be able to save Lakshman, right? And so, of course, Hanuman being Hanuman, volunteered, went in record time, but could not identify the Sanjeevani booty among the multiple medications which were there on that mountain. So he got the entire mountain, right? All of us have read this. So maybe this was one form of precision medicine, if we might call it, where in mythology we talk about these issues. So I hope that what we'll do in the talk is to explore some of the moral sort of precepts of the evolution of precision medicine, its applications, etc. And that's where ethics comes in, when you're trying to reflect a second order reflection on what might be the moral aspects of the application of the technologies. But I think also from yesterday we've already seen a lot of people expressing fears, concerns about what would precision medicine mean for our practice, for our patients, for our own education, for the way we do our research, etc. And this is something which I think is important whenever we're talking about any technology application, right? So Stephen Hawking, the celebrated scientist, spoke about this as well, that our future in many ways is a struggle, right? Between the growing power of technology and our wisdom or not to be able to leverage it or to be able to use it. And that's something we need to think about. Now, important to remember this distinction between practice and research, because all of us mostly do clinical practice or do lab-based work, etc. That's an important facet. Sometimes our practice is very individual, patient-focused, right? Now, so imagine a patient who's not responding to any therapy, is probably very critical, almost terminal. You then decide to import medication, which is rescue medication, which might not have efficacy data yet available, but there is some promise to it. So you request the government through the DCGI, you get the permission to import. But in that case, it's only very specific to that patient, right? That is not really generalizable application because you've not done really an extensive study to be able to know whether that works or not, especially at the population level, and would that hence be something you would adopt into practice. Research, on the other hand, unlike practice, has to deal with generalizable knowledge, right? So anything that you devise in research, it will only be applicable if it is generalizable, and hence there are a whole set of things that you need to ensure for that. And there are certain benchmarks which we speak about. So there should be social and scientific value. You just cannot wake up in the morning and say that I want to do X kind of research. That's where you have the roles of technical committees, ethics committees, wanting to ensure that whatever you're trying to do has some value which you're going to use. It should be scientifically valid. It has to be based in science, right? There has to be something which has been done prior to it, which leads up to the development of that technology or intervention. So science needs to be important. How you choose who you're going to be working with, especially as your trial participants or study participants, is important. You need to ensure that you're not unnecessarily putting people at risk and that there is certain benefit of that intervention development. You need to have independent review. That's where the ethics committee comes in. This institute has one, for example. You need to take consent from your participants. You need to ensure that there is respect for these participants, and this is usually work which is done collaboratively, right? So it's not something which individuals can do. You need a lab setup, you need a clinical setup, you need an institutional backing. Sometimes you work with multiple institutions to get involved. Now, in precision medicine, as we've been discussing yesterday, I know we've used terms like personalized medicine, precision medicine. Some components of precision medicine will also involve the use of technologies such as artificial intelligence, machine learning. And at least in the AIML space, there have been two sets of guidelines which have been released, one international, one national. The international one coming from WHO and the national one coming from ICMR, and they speak to certain aspects which I think would be useful for us to discuss also in the context of precision medicine more broadly. One is, whenever we are discussing the development of these kinds of interventions, we need to ensure that human autonomy is protected, and I'll come to what that means, right? You also need to ensure that the focus remains human safety and well-being and public interest, the broader public interest. This work should be done transparently with explainability and intelligibility, which means that whatever we are doing, it needs to be documented adequately so that someone else who wants to look at the whole procedure of how that development happened is able to understand that, right? It needs to be something you are able to explain, and it should also be something which is scientifically explainable, right? So that becomes important. You need to foster responsibility and accountability because technologies can also be misused, and they can also be used for exploitation, and we don't want that. You need to ensure that it is developed as well as implemented in an inclusive way with equity at its heart, and is responsive and sustainable, right? Because you don't just want to do projects which involve AI/ML, you want to do something which helps influence the nature of how we deliver services. And this is something which is also reflected hence in the ICMR guidelines, which talk about autonomy, collaboration, risk minimization, accessibility, equity, validity, accountability, things that we already covered. Now, why is autonomy important, right? Now, we typically talk about autonomy in the concept of it as one of the principles in ethics, and that being important because you want to ensure that whatever you do it with participants or patients, you ensure that they are agreeing to it. That's where informed consent also comes in. But one of the challenges with the use of technologies, whether that be AI, ML, or other technologies, genomics technologies, omics technologies in medicine, is that the person could somehow be undermined by the application of the technology because the focus becomes more on the system and the way the technology is implemented, and the human which needs to be at the heart of it might not remain so, right? So that's a risk. And the decision making, which typically a clinician has, or a lab-based professional has, is being transferred to a machine, right? And that is, of course, an area for caution because we want to ensure that some element of control is maintained by humans. And that is something which is always considered a red flag, and that's been also a cause for concern around adoption. This is where I think the advent of more modifications to the development of these technologies, an example being human in the loop model, HITL model in AI technologies, where humans are actively involved in the oversight of the development as well as the implementation. And sometimes when there is a disparity, for example, you're running a study where you have the AI-based algorithm making a decision and you have a clinician making the decision. What if both those pathways lead to different decisions, right? The clinician says we should go with therapy A, the AI-based application says you should be going with therapy B. Now, if you are the patient at the heart of it, who's being discussed, who needs to be given that therapy, they will be very confused, right? Because they are told that the AI-based algorithm is saying go with therapy A, and then the clinician is saying therapy B. We need to protect against that because that would, of course, cause mistrust. It will also cause some kind of issues in terms of our relationships with patients. So that's something that we need to be careful about, right? So whenever we're talking about new technologies, including the omics technologies, precision medicine, we need to ensure that we keep at heart concerns around risks, privacy and confidentiality, efficacy, whatever technology are you planning to use, is it really working or not? What is the cost of that technology, right? Because you could be looking at technologies which cost millions of dollars, right? Billions of rupees. Is that something which is really relevant for the kind of patients you see, for example, in your clinics, who might be coming from low-income communities? Access, who has access to these technologies? Is it only available in the Harvards of the world, the Oxfords of the world, maybe in the Apollos of India, but not necessarily something which is available in public sector institutions? So is it really equitable and is it relevant to context? So we need to hence think about, when we are looking at an ethics analysis of precision medicine, then some of the things we need to think about are, for example, can we really promise privacy and confidentiality, right? With the large amount of data sets which are being available, it's increasingly difficult to promise, for example, anonymity, right? With SNPs, analysis capacities increasing, literally any trace of your data which is available somewhere could be used to identify you, right? So are we really able to promise full-scale anonymization? It's probably getting more and more difficult. As we look at individual biomarkers or genomic analysis, because you could do that at birth, you could do that during the course of illness, you could do that at any point of time. How do you benchmark that? Of course, you're benchmarking it against large biobanks, against large data sets which are available. Now, of course, where are these data sets is also important. Are these data sets which are, for example, based on European ancestry, or are they really based on also a broad-based Indian population with enough subgroups across the country, right? And what are the individual clinician responsibilities to be able to interpret this and provide information? So this is where the important question hence becomes, are we ready as medical health providers, as clinicians, in terms of our own literacy around the technology, around understanding how it is deployed, how it is implemented, how to make it decipherable to our patients when we are discussing it, right? So are we able to interpret and communicate? Are our patients ready, right? Are they really able to understand, or they will again leave it to you and say, आप बताएं क्या करना है ना? अगर आपने ये technology deploy की है तो इसका क्या मतलब है, मेरे लिए इसका क्या relevance है, right? And are our institutions ready as well, right? So are they ready in the sense, because ultimately the governance mechanisms need to be at the level of the regulators, the institutions, and are they ready as well, right? So 3 levels. And that's because if we just buy decisions which are made by machines at face value, we might, again, take the wrong clinical decision, right? We might knock off the body because it says an above knee amputation, and left the family, we'll just leave the actual pathological sample, right? So that's something to think about as well. So hence this interplay of evidence, and what kind of evidence is it? Is it appropriate? That leading to guidelines or guidance in terms of how that evidence is implemented. Do patient preferences play a role in that becomes important? And then finally, implementation of that guidance, especially at the clinical level. Is it responsive to local needs? For example, if you're working in Madhya Pradesh, what are the kind of important issues? Is it sickle cell disease? Is it rare diseases? Is it nutrition based? Is it tuberculosis, for example, right? What are the kind of things that we would want to deploy the omics technologies if we are dealing with that, rather than doing esoteric research which doesn't have relevance to our local context? Now, part of the challenge in science and medicine is that we shy away from negative results, right? And let me tell you that in precision medicine, before we actually get to something which is clinically useful, there is going to be likely a whole series of failures. And there have already been a lot of failures where we think about a hypothesis, we try to implement it when we're trying to deploy that technology, but we don't really get anything meaningful out of it, right? Now, but you and I might not know because journals are not ready to publish that data, right? So negative trials are extremely difficult to publish. But if we were able to get that information, I feel that we would be perhaps more nuanced in our understanding of these technologies and what works, what potentially doesn't work, and where maybe we should be doing further work. In the absence of that information, we might end up repeating the same mistakes which have already been researched, right? And that kind of Me Too research, even in the space of precision medicine or omics technologies, would perhaps not be in any kind of public or scientific or medical interest, right? So that's one thing for us to think about. The other thing is conflicts of interest, right? We also need to understand that precision medicine also has a lot of private money coming into it. And that brings in its own unique sets of financial conflicts of interest. Precision medicine is also very much in vogue, which means that a lot of people want to work in that domain. You want to publish. If you publish, you have a chance of getting into a high impact journal. Of course, you get into a high impact journal that has implications for your career. But that by itself also will bring some conflicts of interest in terms of, are we really completely confident in the data when we publish it? Are we clear that there have been no secondary factors which have influenced the results or outcomes as they are being published? And that is something which, for us as scientists who are supposed to be skeptical, right? Remember, it's not questioning the person, it's questioning the science, which you do, for example, in journal clubs becomes important. The other problem, of course, is where is the evidence coming from? If the evidence comes from only specific populations, which, for example, the data set which is there, let's say an AI data set, but the AI data set is based on radiological images which were taken in Sweden, because they digitized everything 10 years ago and they put it out in the public domain. So that's what is being used as the benchmark for developing an AI technology which will be deployed in rural Sihor. Would that really work? Because the patient population from which those images came from is a Swedish population, but you're going to deploy it on a rural Sehor population. So that kind of context and questioning, where is this technology developed and does it really have data from the kind of patients that we want to work with, becomes important, right? And that's where the certainty part of it becomes something that we should be thinking about. This is also because, of course, the kind of data which will come in all the way from the individual level to the population level is literally, we're talking about terabytes and terabytes of data, right? So are we really ready to even deal with it? In one of our research studies, we were trying to understand the adoption of the NCD portal. You will know that there is an NCD portal which operates at primary health centers in most parts of India. Now, the limit which was set by the system was 50 gigabytes of data for a month for a district. When they actually deployed the system, they realized that 50 gigabytes of data is literally used up in a couple of days in one facility in a district, right? So the system was just not ready to be able to handle that kind of data, because it's one thing to collect the data. Where do you store that data? How do you ensure that it is safely being stored? How do you leverage that data? Because data should not be collected just for the purpose of there is a process required. Ultimately you have to have accountability of what you do with that data. So that also becomes important. Are we really ready to work with these kinds of large data sets which are being available? And also important to remember that in our practice historically, we also have had some of these issues of continuing to use treatments where the evidence indicates that it doesn't work. For example, with depression patients, there was a time where insulin therapy was used, right? And that was considered outdated very quickly. In COVID, we had a whole range of therapies which were used, some of which clearly from large studies, randomized control trials, some of which were also conducted in AIIMS Bhopal. We knew that these did not work, right? So this editorial in the BMJ talks about the fact that sometimes we rely a lot on clinical acumen, and that is important. But yet evidence also has to be at the heart of the kind of practice that we do. And also in the race to provide precision treatment, right? If you look at oncology as an example, because precision oncology is one of the first areas where precision medicine has gained traction. This Lancet cover page and the accompanying articles speak about the fact that sometimes we become so targeted in our approach that beyond the confine of that clinical trial in which you're doing that, you're getting that data, it's really not generalizable to a broader population, right? Because these can't be implemented in a real world setting. So this is where the divide between what is considered efficacy data and what is considered as effectiveness data comes in also. Because if the testing is being done in a very idealized population, its generalizability to our real world normal population, or the kind of patients that you see, might be difficult, right? So that's where the novel therapeutics versus what is practical is something for us to think about. Another important aspect is data colonialism, right? Because of course we keep talking about data and data generation, but where is this data being collected? Who is sponsoring this research? Where is this data then going to? Who has the capacity? Remember, I was talking about the terabytes of data. Now, there are large institutions globally, most of them in the global north, who have spent billions of dollars in capacity. They have large buildings, probably the size of this building, which is just to house data and analyze it. They have staffs going into hundreds of people who are doing that analysis. So tomorrow, if we take data from AIIMS Bhopal, all the medical records that we have, we put it up online and say we want to de-identify all of this data and put it out as a public resource. Someone from that institution can very quickly download that data, analyze it, and publish in a few months, right? Where we would be still struggling with being able to understand how do I take this as a clinician who's sitting in a busy OPD, right? When I'm seeing literally 100 patients in a OPD, sometimes 400, 500 patients. Where do I find the time to use this data, right? So that larger issue of who gets to use the data and who gets to, again, benefit from it, both at an individual career level, institutional level, and but also at the public application level becomes important. And this is where power issues of why are institutions from the global north very interested in the kind of data that we can generate, whether that be in the space of TB, nutrition, rare diseases, genomics, because that is the kind of diversity of patient population they don't have access to, which we can provide, right? So as researchers, you need to be cognizant about that why is it that someone is writing to me from a fancy institution in the global north, right? Are they truly looking at a collaborative relationship that they want to develop with my institution and me, or are they after the data? Are they after my patient population? And when we realize that, that is when you can start negotiating a more equitable relationship. Otherwise, what we are lining up for is exploitation, right? And there are various terms for this. For example, parachute research. People come in, collect the data and leave with no longer term investment, involvement in building capacity locally and in working in that context, right? And also, a lot of data sets, as we were already discussing, are exclusionary. They leave out sometimes women, they will leave out ethnic minorities, elderly people, because they are in the exclusion criteria, they're not in the inclusion criteria, rural communities, disadvantaged groups, etc. Right? So who's developing these approaches, whose data is being used, and where is it going to be deployed finally, is an important question all of us should be asking. And that's where I think sort of elements of transparent data use become important. Uh, what is the data which is available? Will it be anonymized? Is it secure? Could this data be commercialized? Could it be sold? What will it be used for? Will my consent be taken if it's going to be commercialized? What are the benefits and who's going to be benefiting from it, and who will be using the data is something that you can start asking. Linked to that, of course, is once a therapy is developed or a precision medicine approach is developed, who has the capacity to be able to deploy it and access it, right? And that's a broader issue around cost. If this is going to be a very expensive development, then maybe only those who have ability to pay, unless it is made a part of the public system, will have the capacity to do it. The other problem, and I think all of you have seen this happen also now in India, is companies which are using genomics and doing direct to consumer testing. You will get emails saying it's Raksha Bandhan coming up, so send us a blood sample and we will do your genomic analysis and your brother's genomic analysis. 30% off for Raksha Bandhan, right? I will not name companies, but there are enough out there. Or they will say genome patri, right? So earlier there was matching of horoscopes before marriage. Now you have genome, which maybe has a utility, but do we really know what they are matching? Is it evidence based and stuff like that? But there are people obviously who are willing to pay, and literally this causes thousands of rupees, right? So are we also lining up to the fact that there could be some exploitation happening? And also, what about the potential misuse? Because already there are a lot of insurance companies which will not give you policies, for example, right? In today's world, most of us try to take health insurance because we don't know. We know that healthcare expenditure can be catastrophic if you have a serious illness, and your employer is not able to provide for that treatment coverage. Then literally you could lose out on all of your money and go into debt, right? And we have evidence from large studies indicating that healthcare expenditure is one of the leading causes of rural indebtedness in India, why people get poor. What if insurance companies say that we first want to do a genomic workup, right? Give us a sample, we'll do a genomic workup, we'll try to understand what are you susceptible to, where is the family history, what kind of potential health conditions could you be developing, and if you are high risk for something, we will not give you a policy, right? So that could lead to more exclusion, or your employer could ask for that, right? Before you are taken up as a faculty member at AIIMS Bhopal, part of your medical initial induction checkup could be a genomic analysis, and they would say, no, sorry, you look like someone who might not be very healthy for long. So as an institution, as a government institution, we don't want to take that risk, right? And would that, of course, disadvantage individuals, and what does that really mean for them? So something for us to think about. It's also important from a perspective of where is the data coming from, right? Now, if you look at HIV as a good example, almost half of the global population of people living with HIV are women. But the majority of clinical trials which have happened in HIV, whether you're doing prevention or therapeutic trials, are gay men. Now, the extrapolation of data from these trials to other population subgroups, for example, women, is just not the right approach to developing treatment, right? Because there are physiological differences, there are differences in the way they might respond to medication. And we've seen this happen, that you might develop therapies and they don't work as well in a different population subgroup. So if we really want to develop something which is targeted at a broader population group and representative of the kind of patient population that we see, then you would want that there is adequate representation in the research so that you're able to, again, with confidence say that this population subgroup was included in the development phase. We saw this during COVID as well. We worked with disadvantaged communities, marginalized communities, for example, persons with disability with multiple chronic morbidities. When they had to take a decision around should I take the COVID vaccine, one of their worries was I take these 3 or 4 kinds of medications, I already have a physical disability. What impact will the vaccine have on my existing medication or condition? Was there any data available? No, because the kind of people who were included in the COVID vaccine trials had a very rigid inclusion and exclusion criteria, and most of these individuals would be excluded. So if you had no data, it would become very difficult for a clinician also. If they came to you as a clinician and said, doctor, should I take this vaccine? And you would try to do a PubMed search or a Google Scholar search, you would find no evidence. And what would you tell your patient then? Right? Because of course they are already in a very precarious health condition. They're probably highly susceptible to COVID complications, but you have no way of saying that there could not be an interaction with what you're getting. Folks who were transitioning, doing gender transition, taking hormonal therapy is another example where a lot of these kinds of issues came up, right? So again, something to think about. So just last week, Madhukar Pai and Shea Ebimbola published this editorial in Nature, where they talked about the fact that science should save all, not just some. And this speaks to this larger issue of democratizing science, democratizing newer forms of therapies, and where these kinds of innovations beyond the discussion in this lecture theater, when we really talk about real world applications, are not just for those who can pay, not just for those who live in the global north, but they are really available for everyone, right? And that's the kind of responsibility which institutions like AIIMS Bhopal, which is an institute of national importance, a public sector institution, needs to think about, right? And maybe that's at the heart of the kind of work which needs to happen at this institution. Also important to remember, right, while we are all very, very positive about the role of technology, innovations, we need to also remember that in the race to identify the gene, the genome, look at the biomarkers, we should not forget the broader social determinants of health. Most of the patients who come to us are still living in an environment where there is financial penury, there is issues around poverty, poor nutrition, the role of the environment, impact of climate change, heat stress, monsoon related displacement, etc. And all of that also influences their health, right? So we cannot reduce their health to just the genes, right? And which I'm sure none of you does. We all talk about the genotype and phenotype, but it's important that again, in the allure of technology, we don't forget the broader social determinants at all levels, individual, community, and population. Another important thing which I know a lot of clinicians worry about is liability, right? Because these are newer technologies. We deploy them. If there is a risk or a harm, are you liable, right? Can you be, for example, prosecuted? Can you be taken to civil court if something goes wrong? What is the role of the institution? How does it protect you against that possibility? What are the kind of mechanisms that we have? If there is harm, even if unintended, do we need to compensate? Right? We talk about that in the sphere of clinical trials, but clinical practice as well, right? Especially when you're doing precision medicine. This needs to be thought through, and maybe if we had more transparency in the way these technologies are being developed and deployed, some of that can be potentially answered. The other important one, and I know those of you who work in genetics deal with this all the time, is the issue of incidental findings, because this will also happen all the time. You do a genomic workup, you do some kind of an analysis using biomarkers, you're looking out for a specific linkage, maybe inflammation markers, linked to a chronic disease, but something else is picked up which was not linked to that analysis, but clearly has a health implication for that patient, right? So how do you prepare yourself for the possibility of incidental findings? How do you communicate that in a way that, again, you are sure? Because some incidental findings might have a remote relationship with actual patient outcomes. But you might be in a moral quandary that should I disclose, should I not disclose? Do I really know with confidence that this could have some implication? Remember, in many of these cases, the incidental findings could also have implications for their families because they might be linked again to the genes. So do you only need to disclose to the patient? Do you also need to disclose to their families? How do you have that conversation, right? So these are the kind of things which also are relevant. And I think towards the end of my talk, I again want to push this idea that in this fascination with precision medicine technologies, which all of us have, I have as well. I work on studies which use a lot of AIML, where we're trying to use precision-based approaches. Let's not forget the person at the heart of it, right? So even the terminology now has changed from patient-centered approaches to person-centered approaches, right? And trying to understand what this means for the patients. What do patients and caregivers think about it, right? And when the systematic review was published, this is something that they try to pick up from published literature. And the kind of issues which were mapped from patient and caregiver perspectives were again around privacy and security, around the economic impact of this on patients, potential psychosocial harms, risks of discrimination, risks in acquiring consent, the potential mistrust in providers because of confusing messaging which might happen, issues with diagnostic accuracy, as well as what impact would this have on the doctor-patient relationship. Already we know that there are challenges with that. And this, again, I think is something which has been increasingly studied, right? Now, if you look at the history of racial aspects of research in the US, that's an important sort of example to learn from, right? You have longer term experiences like the Tuskegee study, which have impacted in the way the Afro-American population in the US perceives the health system. There's a huge amount of distrust, right? And that goes even prior to experiences of Afro-American slave populations and how they were experimented on, right? So when COVID came, for example, Afro-American populations were sometimes reluctant to go to the health system. They wouldn't go to the hospital till they got very sick. And as we know, once you got very sick in COVID, the chances of like favorable outcomes became much lesser. So if you look at morbidity and mortality data, much higher in the Afro-American population. Now you could blame that on the communities. You would say Afro-American populations do not report to health systems on time. But why is it that they don't report, right? What is the historical experiences that they have had where there is a deep sense of mistrust in the health system, in doctors, in hospitals, which is why they will only go to a hospital when they really get sick and they cannot function, right? So that is also an important factor, that trust in the doctor-patient relationship in the health system is extremely important. And the second important part related to that is when we say a person is at the center of it, let's remember, because in our practice, in our work, we sometimes reduce patients to cases, right? We will say there is an interesting case of lymphoma in the pediatric ward, or there is a case of of pregnancy loss who's had like 10 pregnancy losses in the obs-gynae department. I want to go and see because this is very interesting. It's like a textbook case, but the case is a patient, right? The patient has a name. The patient has a whole story of their life, just like you and I have a story. And so Paul Kalanidhi, who some of you might have read this book, he wrote this book called When Breath Becomes Air. Paul Kalanidhi was a neurosurgeon at Stanford who did a lot of very interesting research. Paul Kalanidhi unfortunately developed a form of cancer which was very aggressive and was terminal, and he died subsequently. He wrote about this experience. He said that when I was like a very fancy neurosurgeon doing research, for me, patients were like statistics, right? I would have like a 3,000 patients database, and I would look at them as data points, individual data points, not as patients. That relationship with that data changed when I became a patient. When I could see myself in that data set, one of the 3,000 people who had that kind of a condition for which a description of what works, what doesn't work, and discussions around precision medicine were potentially happening. He said that is when my relationship changed with that, when I became a patient myself. Now, I hope that none of us has to become patients to have that nuanced understanding, that at the heart of it are individuals who are sometimes struggling with a serious medical condition, and they need us to sometimes help them manage that, right? But that should be at the heart of anything that we do as medical professionals. The person-centeredness should not get lost in the push, right? So when we look at technologies, we should not forget the person, and that is also important because this is what patients also say, right? Patients will sometimes have written about this in important journals, like which are there in our field, like BMJ. They've said, I went to the doctor, I tried talking to the doctor never looked at me. The doctor looked at a screen, they looked at my electronic medical record, they asked me some questions, but they did not look at me, right? And for them, that was not a satisfactory doctor-patient relationship, because at the heart of it is a relationship, right? Where people come to you because sometimes, when they come to AIIMS Bhopal, they've literally perhaps been going to multiple institutions, often disappointed. They've waited for 4 days to get their OPD card, and they come to you, and maybe they'll only get 2 minutes. But in that 2 minutes, can you make them feel heard? Can you give them that opportunity of feeling that they are respected in that interaction? And we might use investigations, we might use technologies, but that person-centeredness that is at the basic level of a doctor-patient relationship should not get lost, right? And we should not have to become patients, or as doctors, we should not have to have our mothers or fathers or grandparents or kids or brothers or sisters being in the hospital to understand that how sometimes you're totally externalized from that. And many of us have had that experience, so something to remember. I'll end also by pointing out that it's important for institutions to also take ownership. This is a guideline which came out last year. I was part of the guideline development group. It comes from an organization called AIIMS, where we talk about good governance mechanisms at the institution level, also for research, but also for the development of innovative technologies, and how that is important in the way we approach regulatory systems, oversight systems, and support for those who are doing frontline research and clinical practice, which is required for precision medicine. Thank you for your attention. My intention here was to also sort of shake you up a little bit in the morning, but also because I think this is such an exciting field where there is a lot of innovation happening. All of us are a part of it, but it's also important to have some questions, some reflections, and try to think about what could be also some downsides, and how do we prepare ourselves? How do we ensure that there is adequate scaffolding available?
Thanks, Anand. You transitioned beautifully between the research, clinical practice, and finally came down to that person. Yeah, my concerns, of course, research we are doing in precision medicine. Research is actually well regulated in most places in many of our institutes, especially institute like ours. What I'm bothered about is clinical practice. There are certain set of precision medicine diagnostic which are available for many of the before prescribing a drug, or for prognosis of certain a certain marker. A lot of which are already in clinical practice and are set in the guidelines. Now, when I to quote some example, clopidogrel as a component of dual integrated therapy in myocardial infarction, abacavir in HIV for serious adverse events, many of the anti-cancer drugs, the drugs used for depression, etc. Now, by an institutional mechanism, which may be right, which may be wrong, I'm not questioning my institutional mechanism or any other institutional mechanism. We are told that yes, bypass that and then prescribe. So ultimately, what happens is that I'm still going by trial and error, even though I have evidence to the contrary, and it's a patient who suffers. I put a patient on a drug, wait for 3 months. As classically told, it takes 3 months for the drug to act. It doesn't act, then I get back to the baseline and then start the patient again on some other drug. So aren't we ethically wrong?
Thank you, absolutely. And I don't think that sometimes it's very intentional in the way we do it, but it's by almost that's the way we have been trained, right? That's how we are trained in institutions. That let's try what the conventional ways, right? And evidence, we were discussing yesterday on day one as well, the fact that evidence takes sometimes literally years, sometimes decades to come to medical education textbooks, etc. If we can leverage therapies in a way that it helps us with the person-centeredness, that is absolutely important. I mean, mental health is something that we do a lot of work on now. And what we have realized is that, of course, there are multiple problems as to why there is a 90% treatment gap for common mental disorders in this country. Part of it is, of course, people don't want to be screened because there is a stigma around mental health. But it's also the attrition. You know, someone is screened for a mental health condition and they are told you have to go to see the psychiatrist at the district level or the medical college, they just don't go, right? So beyond the fact that we don't make therapies available in primary care or in communities is also the fact that there's going to be a loss if we are not able to offer those therapies on time. Or someone will come to AIIMS Bhopal, as you're rightly saying, they will be prescribed a medication, which clearly now the evidence indicates that for this kind of a patient, it's not going to work. You're doing that trial. They will try it out for 2 weeks, 3 weeks, 4 weeks, no response. So they will probably go to the local quack who will give them a steroid shot. They will at least feel better, right, for a while. But of course, the disease is going to get more advanced and have poor outcomes. So that's the other sort of con which is important for us to discuss. That if we really know that we are going to have limited time with patients, given the nature of where we work, then our therapies perhaps should be more tailored to what is likely going to work. Of course, with the uncertainty. Yesterday at dinner, we were discussing that we are talking about precision medicine, but clinical practice is imprecise also at times, right? And there is a lot of unknowns. But at least where the knowns are, we might be able to work.
Any other questions, please?
The slides actually mentioned that if there was a controversy between population decision and AI decision, choice should be left to the patient. What kind of worries me in the circumstances that happen in India? Can you really give it space? What's your take?
Yeah, so that slide I think is taken from a guideline, which is again the problem with implementing guidelines, that what guidelines say is sometimes too idealistic and it's not possible. You're absolutely right. I think in our context, it's ultimately the patient will probably ask you, what do you feel as a clinician should be the decision? But the more important part is, should we really have a pathway for that kind of a dilemma to be posed to the patient? Or is that something institutionally we should have mechanisms where if there is discord between what the AIML algorithm is telling and what we as clinicians feel, that we discuss that internally, maybe in our department, maybe looking back at the evidence, maybe going through the patient reports again, and then come to a more an understanding of what we think is the right approach. Because of course technology could fail, we could fail as well, but ultimately it's, as a clinician, it's our responsibility. The AIML is not going to take responsibility of the patient care that we are delivering. Ultimately it's the practitioner or the provider who has to take responsibility. So we can use the technology to inform our decision, but it has to be our decision.
Yeah, exactly. Just from you whether the patient says it.
अच्छा तो I think यहाँ पे तो डाल ही देते हैं या जैसे कि
we can take to understand AI role and versus ethics committee role.
Yeah, I think that's a good question. So, not just ethics committees, I think also, there is now technical review in institutions, and you get a very interesting proposal which says the AIML based approaches are going to be used. I think at least some basic literacy is important. For example, I'll tell you, being on ethics committees, I've seen proposals where they say that the AI algorithm will be informed by working through a pilot sample of 40 patients. No AI algorithm can be developed with 40 patients, right? So when you start to see that in a proposal, you already know that someone's understanding of AI algorithm is flawed, right? And that is important because that has to be picked up. Otherwise, that study will continue. Some funder sitting somewhere has decided to take a paisa dena hai, and they might ultimately do that. But is that really going to be useful data? Likely not. It'll be nice research. Maybe it'll also be published in some predatory journal. But it's a waste of resources and time. So at least that basic thing, algorithm development में आपको कितने patients minimum चाहिए होते हैं? How do you ensure diversity of the population? Who is the person or persons or collaborator who has the ability to do the AI ML development, because that's also a technical skill. So those are the kind of questions which should be asked. And then ultimately, how is the data being collected? How is it being, how is it going to be implemented? What's the gold standard against which you're going to evaluate it? And how will you ensure that there is patient scaffolding so that there is some. So good question. I don't think so. Maybe AIIMS Bhopal can start training on how to interpret AIML, and because I think that's an important function for an institution like AIIMS Bhopal. So that's a great suggestion. Maybe Dr. Bala, you can take it to the administration. Okay. Thank you. Thank you, everyone.
Moving forward, now we have the pharmacogenomics section. In this section, we have two evidence speakers. So before that, just let me introduce about what is pharmacogenomics, its clinical applications, why it is required. And now, the Friedrich Vogel is a German scientist, human genetist. He proposed that our genes play an important role in determining the drug response, and he has coined the term pharmacogenomics in the year 1959. Now, after that, it has gained more attention and research attention in the field of genomic medicines in the recent decades. So after the Human Genome Project in 2003, the view of personalized medicines to improve diagnosis and as well as to cure diseases in the molecular level became more realistic. And sequencing the human genome, that brought some benefits in the medicine, such as early reductions of your diseases with the genetic predispositions, treating the patients with many rare diseases, and the design of gene therapy, and as well as the understanding of pharmacogenomics in the drug metabolisms of the drugs, various drugs. So today, the genome data holds the great potentials to improve the healthcare strategies across various dimensions, be like the disease preventions or enhanced diagnosis, or also in the optimized the treatment. So the biggest hurdles faced by the medical and the research community in India is the lack of the genotype and genotypic as well as the phenotypic correlations for the Indians at the populations wide and at individual level. This leads to the insufficient translation of the genomic informations during your clinical decision making. So the FDA also incorporated some pharmacogenetics informations in the drug labels and now offers a list of many drugs, the black box warning that is linked to genetic biomarkers that emphasize the importance of the pharmacogenetics for personalized the medicines. So the pharmacogenomics research is currently revolutionizing the treatment optimization by discovering the molecular markers, use of genomic and other omics informations to individualize the drug selections as well as the drug use in order to avoid the drug reactions as well as to maintain drug efficacy. So with these, we have two eminent speakers with us, Dr. Vinod Karia from Vishwanath Cancer Care Foundation, and as well as Dr. Chandrakar Rao Pandra from Pondicherry. And now I invite, and also after this, we have four short, that is invited intramural projects by the faculty of AIIMS Bhopal. With this, I request Dr. VK Yadav sir, Professor and Head and Department of Pharmacology from People's University to chair, and also the to introduce and also chair the session of Dr. Upendra Rao's section. And after that, I just invite Dr. Bala sir and Professor in the Department of Pharmacology, and as well as the Dean Students Affairs to just to introduce Dr. Vinod Skaria sir and as well as to chair his session. Thank you very much. With this, I just.
Good morning to all of you. I am Major B.K. Yadav. I am Professor and Head Department of Pharmacology, People's Medical College. And, very good morning and welcome to the session on pharmacogenomics. As physicians, we strive for do no harm approach when we prescribe, and as pharmacologists, we want to design drugs which would produce maximum effect while minimizing the adverse effects. We also want to deviate from the one size fits all type of approach. Pharmacogenomics is the answer where we can tailor medicine taking into the consideration patient's genetic makeup, which can even predict effectiveness of the treatment. And this is the premise of precision and personalized medicine. I have the honor of introducing Dr. Rao, eminent speaker. Dr. Rao holds a PhD in pharmacogenetics, medical pharmacology, and he is currently working as an assistant professor in the Department of Medical Oncology, JIPMER, Puducherry. He completed PhD at Department of Pharmacology, JIPMER, Puducherry in 2010, during which he received the Indo-Swiss Research Fellowship. Following the completion of PhD, he continued to work in pharmacogenetics (OMICS) at Cancer Surge Research Platform of Pediatric Oncology and Hematology of University of Geneva, and headed the experimental research division until May 2020. He is a recognized clinical pharmacologist from Swiss Society of Clinical Pharmacology and Toxicology. He is also serving as a visiting faculty at Department of Pharmacology, Kasturba Medical College, Bangalore, and as a guest faculty at AIIMS Hyderabad, India. His research is focused on pharmacogenetics and personalized medicine, with particular contributions in elucidating drug responses, drug-drug interactions in relation to genetic variants. In addition to having few original research publications to his credit, he founded the Forum on Personalized Medicine on Nature Network in 2010. He is a founding member of a few national and international pharmacological and pharmacogenomic organizations, including Clinical Pharmacogenomics Implementation Consortium and Pharmacogenomics Research Network. Welcome, Dr. Chakra.
Thank you, Professor, for a very kind introduction. It's too long introduction. I'm not used to that. Thank you. So maybe there are some youngsters here. I request you all to Google Pharmacogenomics Research Network and try to go to their webpage and find some resources and tools that you can use in your research, what you are planning or already doing or will be planned in future possibly. They have a very well curated list of resources, and even we have one resource page in personalizedmedicine.in that you could check. And there are some other resources also. I think Dr. Vinod Skaria also is running some virtual course also on pharmacogenomics. There are very valuable tools that are already available in the public domain, because we are in the era that there is no filtering mechanism, there is no introduction, there is no one person gathering the information and sharing, because everything is available with everyone. So it's not much of a role for the speakers here, but it's just for me, my duty is just to put the other side of the coin of pharmacogenomics, how we can use pharmacogenomics as a tool to understand some unknown research questions that we have in biology or pharmacology or in medicine. We know that pharmacogenomics we are using for what? To personalize the dosing or personalize medication, or to be able to achieve optimal outcomes. Basically, we wanted to bring every patient on the same level using some prior information, that is your genetic information. And this information can also be used to answer some unknown research questions. That's what we will see. So the title that I put here is as pharmacogenomics as a tool for researchers versus tools for pharmacogenomics research. It's a bit confusing for me when I thought about that too, but let's see. So I usually start with this. There is nothing new under the sun. There are a lot of old things that we don't know really. So basically what I'm going to talk about is something that you already know, but only thing is that we didn't notice. We didn't take time to notice it. So pharmacogenomics, it's not a new field anymore. It is there in existence for so many decades now. And even there are places where this has been implemented all over the world in many healthcare systems to use this information to guide the treatment practice. That means they're genotyping their patients, they have their electronic healthcare records, and you have the genetic information as well as the clinical information. But right now, they are using this information only to guide some specific treatment. For example, you genotype CYP2C19 to guide proton pump inhibitor therapy. So they are looking at only that aspect. But at the same time, in the electronic healthcare records, they are also gathering a lot of clinical information from this patient. And this patient also has genetic information collected. So how maybe that means there is a possibility in future that we can exploit this availability of this genetic information as well as the clinical information and try to answer some unknown questions that are not known to us as of now. So this is the purpose why we are implementing PGX, and we have the genetic information. I think it's easy to use the mouse here. Perfect. So we have the genetic information, we have electronic healthcare records, and right now they are using only one specific purpose. But in future, maybe we can use this for some other research questions. How we could do that? Because in a real-time setting, unlike a clinical cohorts or unlike a randomized trials where you have a very selective population, in real world, you have people from all different variable backgrounds in the clinic. And from them, you are collecting genetic data also, unlike in a well-designed clinical trials. Whether this can help us to add another variable, which is a genetic variable, which also contributes to the treatment response, that you could always relate with other biological samples that are collected from these patients used from the biobanks and try to use this material and the genetics to map some markers, whether they could be a protein quantitative trait loci or metabolic quantitative trait loci. That means you are trying to predict what the behavior of the proteins in that specific patient in relation to the genetic information that you already have. And the same thing with metabolites, because the technology is advancing every day. So you should be able to exploit the availability of the healthcare record systems, biobanks, and the genetic information to use for unanswered research questions. So what I mean to say is that try to use the existing information rather than trying to look for new information. It's a kind of a lazy system to use the existing resource. I will give some few cases what we did, how we used this existing information to answer some unknown research questions. So I talk about a case studies from pediatric allogenic hematopoietic stem cell transplantation setting, which is standard care for most of the malignancies when they are refractory and when they are very high risk, especially in pediatric patients. And another case study I will present in the maintenance treatment of pediatric acute lymphoblastic leukemia, which is the most common in pediatric patients, cancers. And then third case study, I will talk about how we can exploit this interaction in a very specific subgroup of patients, which could be identified using some prior genetic information. So that's what it's like, one shot and two birds. That's what we are trying to do. So you implement some system, but don't end there. Keep on observing the data that you are gathering, maybe you will answer some unknown questions in later. So that's how what we did. So understanding the role of drug metabolizing enzymes in metabolic pathway of busulfan. I will not go much into the details because most of you all already know that busulfan maybe it's a chemotherapy molecule. Many of you are pharmacologists or oncologists or other medical specialties, so I don't need to explain in much detail what is a chemotherapeutic agent. This is the most commonly used agent in conditioning regimens in stem cell transplantation setting in pediatric patients. In adults, we can use radiation, but in children, we prefer to use these chemotherapy-based regimens because of the other problems of the radiation. And this molecule is a bifunctional agent, so it's very toxic. It can bind to any nucleophile in the body. The most common nucleophile is glutathione, as you all know. But this mechanism is conjugated, is catalyzed or facilitated by some enzymes. But what we don't know is what happens once other metabolites are formed from this parent drug and what happens to those metabolites. Whether they do have any role in the efficacy of this molecule or the toxicity of this molecule, because its molecule is very toxic. Sometimes it causes liver toxicity, which is also detrimental to the life of the patient, child who is receiving this chemotherapy medication. So these are the unknown questions that we had when we were investigating how to personalize this specific medication dose in children by using therapeutic drug monitoring services in our hospital setting. We asked this question, okay, what happens to the metabolism of these metabolites, whether which enzymes are specifically involved in this process. So what we did is we asked with a similar enthusiasm like all other people do, we looked at the structure activity relationship. We thought that, okay, we had some assumption that maybe possibly the cytochrome P450 enzymes or flavin monooxidases, because they are the ones that could easily oxidize these heterocyclic molecules. So we have some prior information. Based on this prior information, we made some assumptions that this could be the enzymes that could be involved in these specific processes. And then what? Then what for example, what if, for example, you take cytochrome P450, one specific enzyme X, if it is the enzyme that is involved in this further metabolic process of this specific metabolite, what if this enzyme is dysfunctional? That means the consequent metabolite will not be formed. It will be in lower quantities. What if it is functional? The further metabolite will be available in the plasma or circulation at a very higher level. And whether this functionality could be something that we could easily be predicted by the genotype. Yes, we do know that there are some variants that are present in these enzymes that could give an idea about the function of that specific enzyme. So basically, it's a kind of randomization, Mendelian randomization, that we are trying to look for within our patient samples to see if we can group them as a functional and non-functional metabolizers of specific enzymes. And then we try to use the information that we are collected during the therapeutic drug monitoring process for the parent drug level as well as the metabolite levels, and we compared between these two groups. In nutshell, that's the process that we did. So it's not aimed. For example, is there any pharmacologist here? I think what will you do if you have to investigate the role of a specific enzyme in a metabolite formation? You usually do microsomal enzymes. You collect the microsomal enzymes, you incubate the drugs, and then you measure. So you need a lot of functional activity, and that's a very controlled environment. It does not take into consideration of all other factors that I showed in the beginning. Whereas in real-time setting, all these factors are already there. In addition to that, you are trying to investigate the genetic component of it. So that's the beauty of taking the real-time data from implementation clinics to use for unanswered research questions. And this is what we did, like any other metabolite studies. Like we identified a specific time point where we could measure both parent drug as well as the metabolite levels, and then we hypothesized that these cytochrome P450 enzymes or FMOs might be involved, but how to understand which genetic variant that we should look for. So we went to this page. That time it was not this one, firmware. That time it was a cypallele nomenclature website, but now you have the young people who are here, they have this information in a firmware web page where you have all cytochrome P450 alleles with their functionality clearly curated and annotated, and that is linked to other databases where you can also look for their allele frequency or genotype frequencies in different populations. And then we looked at this web page, I mean, the ancient web page, and then we had some idea about, okay, star 2 and star 3 allele are the more functionally deleterious variants in this specific enzyme. And then what about the number of samples that we need to consider to understand or to analyze our research question? For that, I need to know at what frequency these specific alleles are prevalent in that specific population that we are studying in. We were conducting this study in Caucasian population, so we took the 1,000 genome data set where you have a Caucasians are included in the genetic genotyping. And then we took this data from this page. But right now, for example, if you are doing in India, maybe you have IndiGenome database. I think Dr. Vinod will shed some light on that possibly. So you have some prior information already, so that you can take into consideration to design or to understand the number of the samples that you need to look at to answer your research question. And there are other tools like you have some power sample size calculation tools, unlike your other tools that you use in your epidemiological research or your hypothesis testing. Here, we also need to consider this variant allele frequency and this data that you will get from your local ethnically curated databases. For example, in India, you will have your Indian data set. And then once you have all this information, so how to get this information from the samples of the patients, the biological samples of the patient, that is DNA. So that time we opted for a real-time PCR-based assays because the next generation sequencing was still in the beginning that time and it was a bit expensive. But now I think the NGS is something that you could also use for, but in limited and resource settings, even it could be answered by a simple open array systems or microarray systems that could be used to understand this information. So here you are not investing any new infrastructure except for this method that you wanted to use for your observations to observe the genetic information from your set of patients. But when you are using these your methods, you also make sure that you use proper controls to be able to sure that the information that you are getting is the proper right information to be able to make some clear conclusions on your data set. So for that, we looked at this tool and then we ordered the corneal cells from which we could extract the DNA and we could use them as a positive controls for the genotypes of our interest. Maybe for your population, maybe you have some repositories like that from where you can extract this data. And then we group them into functional and non-functional groups. And then we compared the metabolite and the parent drug ratios. So here if you could see that this dysfunctional people, cytosine dysfunctional group, you have a very high metabolic ratio. That means the nominator, it was at a very high level than the denominator, which is the metabolite. That means these guys could not form this specific metabolite. That means maybe this specific enzyme has a role in the formation of this metabolite. So we were, without going into laborious in vitro experiments, we were able to provide some insights on the role of specific metabolizing enzyme in a metabolic pathway. And that's what I would not go into the details. I would ask the organizers to share the slides. They are self-explanatory. In the interest of time, I would not go much into the details. Then what if, okay, we showed that this enzyme is involved in the metabolic pathway. What is the clinical implication of this observation? We know that this setting is a setting where we use multiple medication, including antifungal prophylactic agents in pediatric HSCT, when we give this chemo conditioning because patients are neutropenic and there are many infections. And voriconazole is some of the most common prophylactic agent that is used as a to prevent fungal pneumonia in these patients. And after our observations, our collaborators groups also did some animal studies and they showed that this voriconazole could inhibit CYPs as well as FMO3 and this intermediate product THT, which is just precursor of sulfolane, which was the metabolite that we observed in our study. And they showed that it could not be metabolized much faster when voriconazole is co-administered compared to the people, mice who did not receive voriconazole. And it's clearly visible in a clinical setting also. And we know that voriconazole is a strong inhibitor of 2C9 and as well as FMO3. And we know that this is the parent molecule which is going through a cascade of metabolic reactions and forming the metabolites of sulfonyl. And we know that these are the enzymes that we showed that they have involvement in the formation of this metabolite. So if voriconazole is inhibiting these molecules, so there is a feedback inhibition of its own metabolism by the metabolite. So that's how we were able to, that's how now there's a clear indication that voriconazole cannot be used at least 72 to 48 to 72 hours before you administer busulfan for during your chemo conditioning regimen. So it's a drug-drug interaction that is deleterious for your patients. So that insight was able to be achieved, or that could be implemented because of this observation from the existing data, but not from any other new experiments. So pharmacogenomics served as a tool here to understand some unknown mechanisms. And we also know that it could also serve like metabolic ratios for predictive of the outcomes. And you know that metabolic ratios are also related to the genotypes. So you can also understand genotypic information trying to predict the outcomes also in the beginning. So that's how this, I will end that case study with that. But what if all this information is okay in some public domain, in some publications? For example, someone wants to do some study here. They have the same question. Okay, maybe voriconazole and busulfan drug-drug interaction I wanted to study. What is the possible literature that I could look into, whether I should go to PubMed or some other resource. So for youngsters who are here, so we have a specific tool, PharmGKB domain, where you can go and look for curated, well annotated data in relation to drugs and genes and drug-gene pair, as well as drug-drug interaction data sets that are linked to that specific gene-drug pair that you can get that information. So whatever the research that has been done, it's been updated here and annotated here, and then you guys can easily get the information so you don't lose your time again in repeating the same exercise. So that was that case study 1. So coming to case study 2. So we have 6-mercaptopurine and methotrexate that we know that we use in maintenance treatment of pediatric ALL. And you all know why we use that, because of the pharmacodynamic interaction, because they are both are synergistic in action when they are used together. Though one molecule is administered every day, one molecule is administered once in a week, but still it helps to improve the pharmacodynamic effect against the blasts. And then the pharmacokinetic interaction between these two drugs is something that is not clearly known. And ideally, as a pharmacologist, what you would do if you wanted to study a pharmacokinetic interaction, again, you do the microsomes or recombinant enzymes and try to incubate the molecules together and see the parent to the metabolite formation, etc. So we took a lazy approach. So we have a data set where we were genotyping for some of the molecules, some of the enzymes that are involved in these metabolic processes. Okay. So I would, sorry for the simplification process, because the audience, I heard that they are researchers and young students. So methotrexate is something that is glutamated within the cell by FPGS, which is a glutamyl synthase enzyme. So if this is dysfunctional, that means you will have free methotrexate levels available in the circulation. And we all know TPMT, which is a phosphorylating enzyme for 6-mercaptopurine azathioprines. And the NUT15 is something that recovers, that rejuvenates the monophosphates from diphosphates. So if NUT15 is dysfunctional, then you have more problematic incorporation of the triphosphates, and then you have myelosuppression. You have a more aggravated pharmacodynamic function of mercaptopurine when NUT15 is dysfunctional. And when FPGS is dysfunctional, your methotrexates are very higher. So we assumed that maybe methotrexate also contributes to mercaptopurine pharmacodynamic function via pharmacokinetic interaction. Okay, so how to study this using the data sets of genetic information as well as the clinical information that we have in our data sets. So I'm not going to all these assumptions. So this study is actually conducted in India in a patient's pool of South Indian origin. And just like in the case one, what we did is we grouped them into functional and non-functional groups. We genotyped the patients. We had the clinical information about having myelosuppression or no myelosuppression, and we grouped them and we saw the distribution of this myelosuppression, whether it's greater in specific group. For example, if our assumption of methotrexate free levels inhibit xanthine oxidase and contributes to the pharmacokinetic interaction, the dysfunctional carriers of FPGS as well as neutropeptide will have toxicity. In addition to that, FPGS non-functional carriers also should have some toxicity because this pharmacokinetic interaction is contributing to the increased pharmacodynamic function of 6-methamphetamine. Okay, and in addition, neutropeptide alone also should cause toxicity because by itself it has some effect on the blood cell. So that's what we try to do in this exercise. And then when we saw there is an increased incidence of myelosuppression before first 3 cycles of the treatment, at the end of the first 3 cycles, in the patients who are carrying both, when the patients are having non-functional FPGS as well as neutropeptide, that is determined by more frequently determined variant alleles. That means maybe there may be something that we also don't know because we just look for the known ones. As I told in the case one, we looked for already known information from the databases, and then we designed our study and we looked at it. But what about unknown? Maybe in NGS and other data sets, you have more unknown information that you need to carefully look at it. So that's what the message that I would like to conclude here is that, okay, so you have the people who have both, they have very high incidences of myelosuppression compared to either one compared to none of them, or dysfunctional who had very less myelosuppression. So this is actually a very good phenomena to understand the drug-drug interactions also, and also it has some public health implication. What is the implication of this one? For example, if you wanted to genotype only neutropeptide, you need to genotype 227 individuals. The number needed to genotype will be 27 to identify the 3 number needed to harm risk people. Among the 3, 1 is at risk of having myelosuppression. Whereas if you include FPGS genotype to that, the number needed to genotype will come down from 27 to 6. So it's basically you're improving the sensitivity of identifying the patients who are having more problem. This is at a level of implication wise. So you can do both implementation, application, as well as some research questions that you can ask, which are to fill the gaps that are not known in the past. So that's the message for the young people here. So, and the third case, which I would like to talk about, is exploiting drug-drug interaction to optimize efficacy of the treatment using pharmacogenetics as a tool. We all know the basic concept of pharmacogenetics is to adjust the dose so that everybody is on the same page. Nobody is up and down. Can we also use this to select the regimen? Basically, that's the concept. Basically, that's what it is for. So pharmacogenetics also could be used to define the regimens in a specific genetic subgroups. So that's what we try to study here. So you all know PROC1L, which is a axis recommended for Plasmodium falciparum as a causal prophylaxis. I will not go into the details of all that, but what we need to know is that this is molecule undergoes metabolism by 2C19 to an active metabolite called cyclo-1L, and which is actually the molecule that causes the having the antiparasitic activity. Let's not go into the details of all that in the interest of time. And we know that artesunate is some other molecule that is also used in the same setting, and it has some effect on these ligands, some molecules, some ligands that increases the transcription of these cytochrome P450 enzymes in a system. That means when a person is taking artesunate, their cytochrome P450 activity might be at a higher level than those who are not taking artesunate. But whether this activity is something that is related to the genotype, for example, if the person is already a carrier of dysfunctional variants of 2C19, whatever the transcription process is increased or reduced, it doesn't make any difference because in the end, the protein is dysfunctional. Whether you have a higher quantity of dysfunctional protein or lower quantity of dysfunctional protein is the same. It doesn't make any effect. But what if the protein is functional? For example, if the person is already having a normal function, that means he's not carrying any dysfunctional variants. So this is what we try to do here. So what we try to do here is we group the individuals based on the CYP2C19 genotype, and we showed that cycloguanyl formation is at a lower level in carriers of dysfunctional variants of 2C19, because this is the main molecule that is involved in this conversion, compared to the people who are carrying this at a normal function. That means, what if this group of the people, if they are also given artesunate, what will happen? Do you think that the effect of proguanyl could be augmented again? Logically, it is feasible, right? Scientifically, the logical question is that, okay, here maybe not. Here, if you give artesunate also, it doesn't make any difference because it's dysfunctional already. Maybe here, it makes some difference. And this is what we propose at that point of time. And now we have some data, especially from Hong Kong, and especially from Cambodia, where in one specific group of people, okay, so this is a very specific, I don't remember it's Krati. There are different ethnic populations within Cambodia, and in one specific Krati population group, the parasite clearance is much faster, possibly because these extensive metabolizer genotypes are more prevalent in that population. So this is for youngsters, for you guys to answer maybe, because this region also, I don't know if it is malaria endemic or thing, but Maharashtra, I think Gadchiroli district and that region is completely endemic region. So maybe this is something that you guys need to ask the question, whether this is something that could help. We now know that artesunate combination with proguanyl network would be used for Plasmodium falciparum resistant as a second line agent. So this is a research question which is still unanswered. So maybe some youngsters would like to take it up and investigate in future. And I would like to end saying that implementation part of pharmacogenetics for optimized patient care, it's good because it has some predictive role. It is giving some prior information, but don't end your curiosity there. Just continue observing your own data sets now and then. Maybe you will try to answer some unknown mechanisms not known to us. And in turn, that could help us to make some preventive measures, just like, voriconazole. We abandoned taking voriconazole in stem cell transplantation setting because we know mechanism now. And in the end, the objective is to provide a precise medication and personalized treatment to every patient. With this, I thank the organizers for inviting me here to discuss some of the research projects that we did in the past with you all and our collaborators, because nothing is possible as a single person, just like those single two genes like FPGS and NUT15. So we have to collaborate with each other, but not for the bad thing, but for the good thing. So that's what we did here. So we can collaborate with many people here in India, also in Geneva and in Canada, in several locations. And of course, our funding agencies who have helped us to generate these evidence and to answer these research questions. And that was a very productive collaboration that we had, and we will continue to have between India and Switzerland. And with this, I would like to end my presentation by highlighting one upcoming program that we are conducting since 2019, this Indo-Swiss Symposium or Conference Series in India. And this time we are planning to conduct in Kochi. And this is the conference. I think officially the brochure is not yet out, so possibly I will share with your conference organizers and that they can share it across you guys. Thank you very much for your kind attention. I'm happy to answer if you have any questions.
Thank you very much, sir. We'll take the questions for both the sessions together. And so please hold on to your questions. We'll have a short tea break, and before that,
We certainly have two very interesting, informative talks. May I please invite the chairpersons on the stage to give the memento and certificate to our distinguished speakers. Sir, please. We thank Dr. Anand Khan for his thought-provoking, insightful talk. Sir, please come forward to take the token of gratitude from our side. Dr. Chakradhar, sir, please come forward. We will have a short tea break for 15 minutes and reassemble here at 11.
if you want to learn the basics of genomics or genomics, I think you should go to him for a training session and then learn. And today he'll be talking on pharmacogenomics in the era of personalized medicine. Welcome, Dr. Vinod.
A very good morning to all of you, and thanks for the introduction. I'm really embarrassed seeing things in public domain. But yeah, it's always a pleasure to be back here in this beautiful city, and I never leave a chance to come back here. Over the next 30 odd minutes, I will sort of give a brief overview of a 15 years journey into looking at pharmacogenomics in a perspective of personal genomes. Now, most of the work that I'm going to talk about was done in my previous institution, the CSI Institute of Genomics and Integrative Biology, where I was there for almost 19 years. I just moved out a year or so ago. And except for the last few slides, almost all the science that I've done in the area of pharmacogenomics was with a wonderful set of people who are in there with consistent support from the CSIR and work done at IGIB. Now, in many ways, we are in the midst of a very exciting period. I'm not sure you would appreciate this fact. But in the last 2 decades, what the world has witnessed is a giant sweep in technology, and that too in genomics. And what this technological sweep would mean is that you could sequence whole genomes of individuals like you and me in a very affordable cost today. And that cost is not stable, it's continuing to dwindle, almost becoming half every 200 odd days. Now, to put in perspective, the first whole genome sequence, which is a reference genome, actually took about $2.8 to $3 billion. And sometime in 2009, 2010, when our lab started doing genomes, it was around 30 odd lakhs, that is around $30,000 odd. And today we are in a clinical scale genome sequence, which is available in the market, available as a clinical test, which is approximately around $500 odd. And I'm sure over the next few years, you would hear about $100 and probably in a decade's time, $20 or $30 per whole genomes. Now, what would that mean? That would necessarily mean that their patients are going to come to you with a genetic report. And more importantly, as young individuals in this generation, you would do your genomes as part of your clinical investigation. You like it or you don't like it. I would put this number as 50% of you would do this genetic testing as part of your clinical investigation, at least in the next half decade. And probably in a decade's time, probably every child in this country would be born with a genome sequence. And that would really, in my opinion, change the way we do genomics. Now, of course, to do that, first you need to do one, and that's what we did way back in 2009. This was the seventh genome that to be sequenced and published and available in public domain. And more importantly, pharmacogenomics is very specific to this particular genome, because it is the first genome to be analyzed in a pharmacogenomics perspective. And of course, this is a script from the paper, which sort of has an entire paragraph on the pharmacogenomic traits that can be sort of gleaned from an entire human genome. And when we wrote this paragraph, the idea was in the future, at some point of time, when every individual would have a whole genome sequence, pharmacogenomics will necessarily become a part of that analysis, and individuals would benefit from it. And that's what I'm going to talk about. Now, of course, 1 in 1.4 billion people is probably nothing, right? And of course, understandably nothing, because we are 1/6 of the global population, and one individual is obviously not going to represent anybody. But of course, you need to start somewhere. And what we wanted to also do is to understand the genetic diversity of the unannotated population. That's from the Middle East to Central and Southeast Asia. So you're part of multiple collaborative initiatives, including the first Sri Lankan, first Malaysian, first Philippines, many large-scale programs in the country, including Indigen, which closed in 2019, the South Asian Genomics Initiative and the Middle Eastern Population Genomic Initiatives, which are country-run programs, and also the Hugo Pan-Asian Population Genomics Initiative, which aim to understand the genetic diversity of this population. And the idea was very simple. By looking at genetic diversity of the population, we could also understand, apart from many other things, the pharmacogenomic landscape, because we firmly think that pharmacogenomics is something that is going to be routine of care in days to come. Now, why pharmacogenomics? The answer is very obvious. And as in a pharmacology audience, I don't need to mention this because practically everything that we give to patients is based on a clinical trial. And a clinical trial, by definition, is done on a group of individuals. And therefore, you have a measure, you have a dosing, you have a dosage schema, you have a guideline based on the clinical trial, based on medians or modes. But nevertheless, that median or mode that represents nobody. In other words, everything that you do is based on an average of a group of individuals. And that average actually represents nobody, right? And that necessarily means that everything that you take has a varied level of effectiveness in different patients. And this is very well documented. You can see that number. In approximately 75% of cancers, the standard of care is not very effective. Very understandable because cancer is not one disease, right? Even breast cancer is not one disease. As we understand more of molecular rather than morphology of a particular disease, you understand that breast cancers could be hundreds of diseases, each of them with a different molecular marker. And therefore, just treating as a breast cancer is not probably going to make any difference because there is nothing called breast cancer. Now, of course, in our era when we passed MBBS, you could pass saying you have adenocarcinoma of the breast and this is a treatment schedule, but probably not anymore. And at least for young individuals in this audience, this is going to be even more acute in the ways that most of the diseases that we talk about in loose language, when we say breast cancer is a loose language, there's nothing called breast cancer. You would find molecular classifications of diseases that is going to be preemptive, that's going to be the mainstay. And therefore, understanding the molecular classifications and understanding how to treat the molecular classifications would become a very important part of your clinical practice. Now, why does this happen in a group of individuals? It's largely because of the fact that you take drugs or what you call as molecules in multiple different formats. The commonest format is to take in the gastrointestinal tract. You open a pill. And what happens is very common and understandable to pharmacology. For that matter, I hated pharmacology when I was in medical school. I hope it was simplified. Yeah, so when you take it to the gastrointestinal tract, it is metabolized by the liver, the first pass metabolism. It is then distributed in the systemic circulation. And of course, you could take it in the parallel route that is directly to systemic circulation. And then, of course, you have kidneys, which metabolizes them and excretes them into the urine. And then, of course, there are some drugs which can also be taken as an inhalation through the breath. Now, what you need to keep in mind is that whatever drug is in the systemic circulation needs to now extravasate into the extracellular space, and that's where the cells are. And that needs to cross over to the inside of the cell, or in some cases, on the out, it can bind to the surface receptors. And then needs to bind to a particular protein, which is a drug target. So in many ways, what you need to keep understand is that just popping a pill is just a start of a series of events that would happen, which includes transport across membranes, right from the gut, metabolism at multiple different levels, the liver, kidneys, so on and so forth, and then crossover to membranes into the cell before it can even act. And every single component of this is essentially derived by proteins, and proteins are encoded by your genome. So therefore, levels of proteins and changes in the protein structure could change how a drug would bind to the drug target, as simple as that. And to put in simple words, you have a drug, the drug needs to be transported actively or passively, then you have metabolizing enzymes, then you have the interactions with the drug target, and all of these are proteins, and therefore, in very simple terms, genetic variations could impact any one of these and change your outcomes. As simple as that. Now, of course, I can take one example of a very commonly used drug, clopidogrel. Now, clopidogrel is an antiplatelet drug, widely used in clinical settings, and I'm sure everybody above 50 years, 50% of them would have this drug because you would have an angioplasty and or you would have a myocardial infarction, and you take this for your entire lifetime. Now, clopidogrel is a prodrug. It's taken as a pill. It's absorbed in the intestine through the ABCB class of proteins. It's distributed in the systemic circulation. The liver metabolizes it. It's also excreted to the kidneys. And there's a multi-step process of metabolism that involves the liver, including cytochrome enzymes. and then it is converted into the active form. The active form binds to a very specific receptor on the platelet surface, and then that inhibits platelet aggregation. So you would see that right from the popping of the pill, you have multiple genes that are involved in the entire process of absorption, metabolism, excretion, and action. And action is on the platelet surface. So therefore, genetic mutations in any one of these components could determine how much clopidogrel active is available on the platelet surface to interact, and therefore that could change how the platelets are going to aggregate or be inhibited from being aggregated. So broadly, this is what is called as pharmacokinetics and pharmacogenomics. Well, that's what you learn in pharmacology. Now, if you ask this question, how are the genetic mutations distributed, but more importantly, how is this phenotype distributed across the populations? You just move from the right-hand side to the left-hand side of the chart. Just focus on the red part of the pie, what is a poor metabolizers for clopidogrel. You'll see as you move from here to this part of the world, the red pie increases in size. And in this region where India is approximately around 15 to 30%. Now, what does this mean? This means that when you talk about pharmacogenomics of a particular drug, you need to always keep in cognizance that the pharmacogenetic variability or the gene variability is very different in different parts of the world. In many ways, the trials would be done in a different part of the world, which has a very different pharmacogenomic markup, and now widely used in a different part of the world, which might have a very different pharmacogenomic markup. And therefore, you would have to change things like dosage. You would need to look at adverse events which might be very prevalent in different parts of the world. Right? Now, how does clopidogrel work? So this data is entirely based on array data because it's an old study which was done by Ambali, who was a graduate student in my lab, now a faculty at St. John's. So what you see here is suddenly you cross this sort of a line, you see the red pie increasing very rapidly. And why is that? That's largely because you have genetic variations which are very prevalent in our population compared to the rest of the world. Now, this was a study done again on arrays because in that time arrays was only what was available. And what you need to see is this part, the lower part of the chart. I'm sure you can see this. Right, so this is the Indian population, the North Indian population to be exact, five different states, and this is the average of the North Indian population. And this is the global population allele frequencies for each of the gene variants. I'm sure you don't need to, I don't need to show you a p-value to suggest that the allele frequencies in the North Indian population is very different from the global population. And what this would roughly mean is that you have better intestinal absorption, better bioactivation, and better inhibition of platelet aggregation, or in other words, the dosage that is determined on a Caucasian population might actually be much larger in the Indian population. Right? Of course, this is only genotypic prevalence, and what I showed earlier was the phenotypic prevalence. Now, how do you really come to a consensus? Right? Is the question, because if you want to really change clinical practice, either you need to go back to the author of the guideline and say that, hey, you were wrong, or you need to provide your own evidence to suggest that that guy was indeed wrong, and probably we need to change your practice ourselves. Yeah, so that's when also the time period when we started working on whole genomes from around the world, and not just to look at things like clopidogrel, but to look at a variety of things for which the drug pathways and the genetic variations are very well known and very well available. And the second genome to be sort of mapped for the pharmacogenomics is the Malaysian genome. We are fortunate to have worked with a fantastic set of collaborators with the Pharmacogenomics Institute in Malaysia. And the idea was to essentially create a Google Maps or a route map for drugs in a particular individual. Right? Now, how are you going to communicate pharmacogenomic information to a particular clinician? Right? Because you have a variety of drugs, you have a variety of genetic mutations, and a clinician is not going to look through 12 pages of a table to figure out what should I give or what should I not. So you need to essentially have a route map, like a Google map. You can select a point of origin and a point of the location that you need to go to, and it will tell you these are the 4 routes and this is the time that it takes for the 4 routes. Or if you have a roadblock, it will color it as red. If you don't have a roadblock, it will be in blue. And similarly, you can draw such a route map for the genome. Each line is a particular drug classified, I'm sorry for the font size, classified by the indication, like cardiovascular, infectious disease, so on and so forth. You have the transporters, the metabolizing enzymes, and the drug targets. So if you have a colored bar in here, that means that there is a mutation in that particular gene, which could impact it. So therefore, your drug needs to cross through this through this before it can reach the drug target. So if you have multiple roadblocks, then you know there's a problem. Probably you should not give the particular drug. But if you have no problems reaching from here to here, because it's all in gray, that means that you have no problem giving the drug to that particular patient. So in many ways, you can create such route maps on individual genomes. Now, of course, the other question is, of course, there are individual genomes. Then, until individual genomes become commonplace, can we really glean some information from population scale genomes? And of course, the two population scale genomes that we wanted to work with, because we have fantastic collaborators, were the Malaysian genomes as well as the Qatar genomes. Both of them are very interesting in their aspects. Malaysia is a very large country, has largely 3 ethnic groups, while Qatar has a very small country, around 150,000 odd individuals, which is smaller than a district in India. But nevertheless, while being smaller, they have a very strict practice of marriage, which necessarily means that you have groups of individuals which are distinctly genetically divergent from each other. So we wanted to look at the Malaysian population, and what we found is that Malaysian population indeed has some genetic variations, high marked in here, which has very distinctly different allele frequencies compared to the global populations. The top ones are the global populations in 1000 genome and a half map, and the first row out here is the Malay population. You would see that they are darker colors of green, that means they have much higher allele frequency compared to the rest of the global population. Now, of course, this could mean very different things depending upon the drug and the genetic variations that you have. Just to keep you appreciate the fact that you could go back to literature. So we collectively curated data for a variety of studies in clinical settings to understand how does a representative population scale genome actually show what is seen in clinics. And that's what we show, that we have a perfectly large correlation on doing this. Or in other words, you can just take up subpopulation from a given large population, and you will be able to recapitulate from individual studies at a global genome scale. And this, for the first time, we showed that you can do it at very high correlation. Or in other words, a population scale genome can impact or can influence guidelines rather than doing individual studies for individual variations and individual genes. Quickly moving into the Middle Eastern genome, we looked at the Qatar genome. As I said, it's a very small population, 150,000 people, but very genetically stratified with very different ancestries. So you have the Arab ancestry, the Bedouin ancestry, the Persian ancestry, and so on and so forth. And what we show is that even within the ancestries, you would have very large diversity in the allele frequency. So you have the first row, which is the average of all Qatar population. And then you have the South Asian, Persian, Bedouin, Arab, and African ancestries. You would see, like, for example, this particular genetic variant in 3A5, which is high frequency in African ancestry, but low frequency in many other populations. Similarly, you would have, for example, 4F2, high frequency in many other populations, very low frequency in the African ancestry. So in many ways, even in small populations, the marriage practices or endogamy can affect the allele frequencies across. So this is two things that we sort of learned from it. In cosmopolitan populations, you could do sampling and you could extrapolate it to the entire population. But in very close communities or endogamous communities, you will not be able to do that. You will have significantly large differences between populations. Now, how do we take that? You take that to India, because India has both these kinds of populations. You have cosmopolitan populations, which marry freely across their communities, and you have endogamous populations, around 4,000 endogamous populations, for which you need to really look at population level allele diversity, because you might actually miss out a lot of things if you do a random sampling across. If you don't understand the population structure, you might actually create a wrong guideline for that particular subpopulation. Okay, now going from there, how do we now use this genomic data to enable precision medicine? There are two ways you can think of doing that. The first way is to be an ideal situation where everybody can get a genome. And future, of course, that is possible, where everybody can get a genome, everybody can get a drug route map, and therefore a clinician should be able to look at the route map and say that this drug has no problem, therefore I will give you. Or you could, in a country like India, where 99% of people cannot afford to have a whole genome, you need to find out mechanisms of how to convert it into an affordable and accessible assay. And genomes can essentially allow that to do by looking at prevalence of mutations in the entire cosmopolitan population as well as in subpopulations to understand what are the population scale differences for very specific drugs, which is prevalent, and make it a very affordable test that can be routinely implemented in clinical settings. When I say routinely implemented in clinical settings, that means that it cannot be a whole genome sequencing, it has to be an RT-PCR test. As simple as. So, we want an example on what we did in the past. This is for a very commonly used drug in oncology called 5-fluorouracil. They're very different fluoropyrimidines, 5-fluorouracil being one of them, the other being capecitabine and tegafur. Now, 5-fluorouracil is widely used in solid tumors and primary mode of chemotherapy, and is largely metabolized by just one enzyme, which is a DPYD or dihydropyrimidine dehydrogenase. And around 85% of the drug is metabolized by this just one single enzyme. Now, people have shown in the past that DPYD mutations could impact the metabolism of 5-fluorouracil and cause adverse events on giving 5-fluorouracil or capecitabine. And today, I mean, as we speak, this year the FDA has included it in the drug label to make it mandatory that before giving fluoropyrimidines, you need to do a DPYD testing. Now, of course, DPYD testing in the previous past used to be sequencing the entire gene. That makes it very costly, unaffordable to most people, and not really accessible to a lot more people in the community. So what we did was very simple. You could take DPYD gene, you could go to the population scale database and ask a very simple question: how many mutations are there in DPYD? If you find it in the population, then it is prevalent. You just type those mutations. We found 15 odd genetic mutations. We quickly went back to a clinical cohort of people who had DPYD or had 5-fluorouracil had developed adverse events. People who had 5-fluorouracil did not develop adverse events. Did a quick analysis in a small cohort of individuals, and this was done in the Amrita Institute of Medical Sciences with an oncologist, Dr. Pavitran. And what we found is that we have only 4 genetic mutations which has any clinical actionability. So in other words, you can convert this entire test into a test for just 4 genetic mutations, either on RT-PCR or on Sanger sequencing. That can make it very affordable and accessible. And today this test is available in the market. It's in the catalog of Dr. Lal Pathlab and many other companies, including hospitals, because we published this evidence suggesting that just 4 mutations will account for 99% of all adverse events in 5-fluorouracil toxicity. And this test today can be done approximately around 400, 500 rupees. In other words, that means that every patient who needs to get 5-fluorouracil can today access this particular test. Now, to do this at scale, what you need to have is genomes and prevalence of mutations in the population. Now, of course, we did not have a population scale genome until very recently, but in 2019 with the Indigen program, we have a population scale genome, which now allows you to look at prevalence of estimates of many of these genetic mutations. And this is a sort of cosmopolitan map of India, from which each of the dots essentially is from where the samples have come in. We have samples indeed from Bhopal. And therefore you can get a fairly good estimate. I'm not saying it's a very good estimate, because 1,000 odd genomes from a 1.4 billion people is still much lesser. We need probably 1 million odd genomes to cover the diversity of India. But at least in cosmopolitan populations, you know what is really prevalent. And given what is really prevalent, you can essentially go back and build tools that would allow you to do pharmacogenomic testing at scale in an affordable form. So we went back to this Indigen genomes, these are whole genomes. So you could look at every single pharmacogenomic marker. We looked at the highest levels of evidence, 1A and 1B, according to the PharmGKB as well as CPIC. We looked at 3 different types of genetic variations which are important in pharmacogenomics: the single nucleotide variations, the star alleles, like the cytochrome has star alleles because they're haplotypes, and then of course you have the HLA alleles. We could look at all of these 3 kinds of genetic variations and be able to build allele frequency maps in comparison vis-a-vis the global population. And what we show here is that for every single type of genetic variations, there are very specific mutations or haplotypes or HLA alleles which are prevalent in Indian population vis-a-vis the global population, for which that means that you need to do focus studies for these markers in the Indian population to derive our own dosing scheme, our own cost-effective test, so that we can avoid adverse events or do precision medicine. And much more importantly, what we also showed is that every individual on an average would have around 8 clinically actionable pharmacogenomic variants. It could be for any of the drugs out there for which there's a guideline or evidence, but on an average, if you sequence your genome, you would have around 8 pharmacogenomic active markers. Of course, you could look for the cytochrome haplotypes, and I'm sure Dr. Rao has many of his drugs in the list in here. And of course, you could look at HLA alleles, very important. Somebody did talk about abacavir. And as you see here, the HLA allele frequency is around 4% in the population, probably the largest in the world. Now, this would give an idea of what are the drugs, what are the alleles that we need to do in-depth clinical analysis in your cohort of individuals. For example, abacavir is prime target, carbamazepine is another prime target, allopurinol is another target, that you need to now know this is the HLA allele. You can make a very specific test for this HLA allele, either implement it in clinical situations after doing a cohort analysis. I'll just give you two examples, and this is one for clopidogrel. And what we show is that the poor metabolizers is approximately around 13%, very similar to the chart that I showed earlier. So arrays can also provide very useful information compared to whole genome sequences, and the collaboration is very large. The South Asian population has a much higher frequency of poor metabolizers to clopidogrel. Now, if you go back to the guidelines, international guidelines, and look at the guidelines and the variations described in the guidelines, you will see, for example, this is for warfarin, CPRC1. There are approximately 60% of individuals in the population, according to today's guidelines, would require a dosage modification. Right? And if this should not convince you, I think we need to go back and change these guidelines. We need to create our own dosage schema for cardiovascular drugs at least, because just think of it, 2 out of 3 individuals that's coming to the clinic getting warfarin or clopidogrel requires a dosage modification compared to what is there in the textbooks. The other very important and very prevalently used drug is statins. And what we show very recently is published this year. What we show is that approximately a third of individuals who take statins would require dosage modification, and at least 10 of them would require a much reduced dosage of statins. And in fact, we also show in this particular paper that the incidence of familial hypercholesterolemia, because statins are given for cholesterol, familial hypercholesterolemia is approximately 1 in 150 odd. That means there is one individual in this room with familial hypercholesterolemia. You don't probably realize that, but you have it. Now that comes to the last part of my talk in terms of how do we really perceive or how do we really implement precision medicine. Now, of course, when you are in a clinical audience, we should all realize that all of modern medicine is built on a very simple concept that you can build medical colleges, like the All India Institute of Medical Sciences. You can get in MBBS students, you can get in residents, you can train them on how to treat patients. Right? That's essentially what you are being taught. Right? You're being taught on how to treat patients. And for patients to arrive, that means they need to have a disease and they need to find a doctor. Right? That's how they come to the clinic. If you're walking on the road, you just don't come into AIIMS saying that I think I need to do a checkup. No, you need to be a patient in the first place, and you need to get to a center where you need to treat. And doctors have been trained all the while, including me, that patients will somehow find you. Right? You set up a clinic or you set up an OPD, patients will somehow find you and they will come to you. And when you have a patient, then you evaluate the patient by signs and symptoms and diagnostic test. And you say, yeah, you have this particular disease and I will give you this pill. And if you have an adverse event, I'll come back and tell you, oh, you have this adverse event, I'll do pharmacogenomics and I'll tell you, okay, you have this particular genetic condition. But is that really the way we should do precision medicine? Probably answer is no. Because the moment the patient has an adverse event, there's very little that you can do. The pharmacogenomic testing is useless. Right? The patient already has adverse event, and if it's severe, the patient is already dead. So you need to change this perspective that you need to reverse this process and think that everybody in this room has 8 pharmacogenomic variants. 1 in 10 of them would have an oncology pharmacogenomic variant, and in fact, 1 in 10 of you would get cancer in your lifetime. How can you prevent that from happening? Right? For that, you need to have preemptive testing. In other words, apparently normal individuals like you and me should have a genetic test, at least for prevalent genetic disorders or prevalent pharmacogenomic variants. And even before I get to an ER, I need to have this variant typed before the doctor can prescribe the medicine. That will prevent the doctor from prescribing. In other words, you can preemptively look at pathogenicity and preemptively look at the clinical interpretation and action. In other words, you need to test individuals when they're apparently normal, right? Before they come to the clinic. When a patient comes to the clinic with MI, you're not going to rush to do a pharmacogenomic test. That's not practical. The patient should have a pharmacogenomic test done before the patient has an MI, because in an MI, it's an emergency. You have very little time or very little resources to be committing for a pharmacogenomic test. Now, given that perspective, what you need to also keep in mind is that what's happening in the world is something even more remarkable in the sense that we have a convergence of technologies. So today we are already talking about tests for, I've been talking about very affordable, accessible tests for individual genes and mutations. But we need to keep a long-term perspective. What is really going to happen 10 years from now, 5 years from now? And what's really going to happen is in here, because the cost of genomic sequencing is dwindling so rapidly that probably in 5 years' time, a genome sequence is going to be cheaper than every single test that you do. Right? You might be building an HLA test today, which is say $500 or $100 or $50, whatever be the number. The genomic test in 5 years is going to be cheaper than your PCR test. So you need to be prepared to do that. And to prepare to do that, you need to have two things. One, you need to have clinicians educated and aware that this is going to happen. And second, and more importantly, you need to educate clinicians on how to interpret this. Right? Now, that's the convergence that I've been talking about, is in the way that today you do multiple kinds of genetic testing. It can range from karyotyping to FISH to repeat PCRs to RT-PCRs to panel sequencing to exome sequencing to Sanger sequencing, a variety of techniques to look at genetic mutations. Each of them have very different requirements in terms of equipment, in terms of personnel, in terms of understanding. But 5 years from now, what you will have is one single test, right? Which is a whole genome sequence, which will look at every single nucleotides, every single types of genetic variants at a much faster turnaround time. And today you can actually sequence a genome. The world record is around 18 hours. That means you can really put it in clinical implementation. And this is a future that you need to be prepared as clinicians. Right? While we can still do RT-PCR test for the next 5 years, we need to be rapidly preparing ourselves to this avalanche of information and prepare clinicians to this information, that there is going to be a convergence of genomic testing into one single test, which becomes affordable, which becomes fast, which becomes accessible. Now, having said that, today this is available in India. One of the companies we have been working very closely in the past 1 year has been Carcinos, which today has a comprehensive pharmacogenomic testing available in India. It's probably the only test that is available, offered from an NABL CAP accredited lab. Not just pharmacogenomics, but a variety of other information, and also comes with pre and post test genetic counseling, because that's another important component of doing genetic testing in a very ethical way, not just looking at cancer, looking at incidental findings, looking at pharmacogenomics that normal individuals like you and me can do. And of course, there are going to be genomic pioneers who are going to take this first, but also to prepare the community to say that a lot more people would take this in the coming years. And more importantly, in a decade's time, probably every child born in this country would take this particular test. So I'll close there and say that, just to say an old Chinese proverb, superior doctors prevent the disease, mediocre doctors treat the disease, and inferior doctors treat the full-born disease. So you aim to be superior doctors to prevent the patient from coming to your clinics, not treating patients who come to your clinics. Thank you very much.
Thanks a lot, Dr. Skaria. Wonderful, wonderful presentation as expected. And I open the platform to questions now for his session as well as the session which was taken before.
Very well delivered talk on this complex topic. I am a physician, and we are dealing every day patients coming with young patients coming with strokes, young patients coming with MI. It has become so prevalent that in 30s and 40s we are getting patients. So are you aware of any studies on this select group of patients where preventive measures could be taken, because they run in families and we are having family history? I have seen patients myself where 3 generations of their family, they have succumbed in between 40 and 45 with MI. And 4th generation is worried, what should I do? My father died, my grandfather died, and I am now 30, 35. I am hale and hearty, but I am scared, what should I do? So are you aware of anything that can be delivered to this group of patients where they can take more strong and more intense preventive measures so as to succumb to this kind of situation?
Yeah, really fantastic question, and really pertinent question is what I would say. 5 years ago, in the same podium, I have given a lecture on rare genetic diseases, where I sort of suggested that complex disorders are out of the purview of genomic testing, right? And today I stand corrected after going through the population scale data. And you will be surprised what the population scale data can actually provide. And we have publications for this. Approximately 1% of individuals in the population have familial hypercholesterolemia or dyslipidemia, familial hypercholesterolemia being around 100. And all of these individuals would get their first cardiovascular event in their mid-30s to mid-40s. Right? They are untested, undiagnosed, untreated. The opportunity to treat them is already lost by many. Right? And in fact, for the same reason, there's ample evidence from Western literature that many countries have implemented familial hypercholesterolemia screening. And screening is not genetic, it's a very simple biochemical test to do LDL cholesterol. Very early in life, it costs 350 odd rupees today. And if it is done mandatory, you can save 10 years of a productive life. You have not been doing this before because nobody knew this. Second most prevalent genetic disorder is cardiac channelopathies. I'm sure you would have heard in news, very young, agile individuals who have gone to gym, suddenly collapsed, died. Right? Very famous actors, very famous personalities. These are all because of a very prevalent genetic disorder called cardiac channelopathies. These are genetic mutations in the cardiac channel genes. Many of them are treatable, preventable. And if you know that you have the genetic mutation, then you can avoid some lifestyles. You can give beta blockers or you can put in a base. The families of individuals who have died on sudden cardiac death without a diagnosis because you're dead. If you're dead, there is nothing to be diagnosed. Right? Very prevalent, that's approximately another 1%. And the third, in fact, the most commonest genetic disorder in the population is familial cancer. 3% of the population has one of the most prevalent mutations for familial. Breast and ovarian cancer, prostate cancer, pancreatic cancer, or colorectal cancer. 3%. That means there are 3 people in this room who have a genetic variant which already has a process of early diagnosis, early treatment, and prevention. But unfortunately, we don't know this prevalence and therefore we don't have it. And that's essentially why I said that therefore preemptive testing is the way. How do we do this? Today, of course, the cost is, for example, a preemptive germline screening for cancer costs approximately the price of a CT scan. Right? Of course, we need to have it much lesser than that, and that will happen only when large. When few people use it, the cost is of course large. Large number of people use it, the cost becomes extremely small. How can we as a country, as a population, as a clinical community accelerate this? We can change the life for a large. Thank you.
Any other questions, please?
What about the alternative medicines and the pharmacodynamics? Should they lack pharmacokinetic and pharmacodynamic data for allopathy?
One of the biggest problem today, which is always swept under the carpet, is that practically every patient also gets some alternative medicine under the carpet, under the desk, without any record whatsoever. Because nutrition supplements are widely being used in the population without any prescription because they're out of the counter. Drug-drug interactions of this is practically unknown. Right? So this is something that is a problem, but nobody wants to address it because there's no clear-cut way to address it, because unless you don't have a prescription, how are you even going to know that patient is going to have it? And even if you know it, how do you even know what is there in that pill? Right? Many of this actually lack any standardization. So you don't really know what is there in the pill.
Dr. Rao, do you have any specific set of this for cancer, either therapy or recognizing adverse effect of drugs like F5FU? Do you have any panel of this which can be commonly done?
So I think Dr. Vinod mentioned that he has a panel of all pharmacogenes that has allows a list of some of the genes and variants which are having some impact on the oncology drugs, for example. I think you mentioned like TPM3, MIT15, which is quite prevalent in our population in Asians, especially Indians also. And for example, the PYD testing. And then maybe there is, for example, glutathione transferase protein or enzyme variants. I don't know the panels that what we are using right now, I think they are using information from curated guidelines from the Western world, CP guideline, for example. That is the norm for us to define the panels. But we are defining the panels without testing the implication of the evidence here in our setting. I think this is where I think you all have to have a role, and where you can contribute actually is to generate this evidence and contribute to the existing domain of knowledge that what we have is that, okay, is it really worth testing to 15 here in our population, so that other people who are including them in the panels can, okay, provides a strong evidence to make it happen, so people can start using it. This is where we started this study in pediatric ALL. Right now, we are in the third year of our study. It's a prospective study. You have to do some prospective, even observational work. You don't need to do randomized studies. Just an observational, prospective observational cohort study, where he correctly mentioned about the record problem, okay? Drug-drug interactions, etc. Define a clear-cut, practically feasible CRF that can pick up the data that is needed to answer your research question, for example, genotype and drug-drug interaction, and try to implement that and generate the evidence. I think this is where I think we are behind in generating evidence in our setup. So I think that answers
it does partially answer my question. And yeah, I'm very happy that in the last 5 years, many of the PhD theses I'm getting, and even MD theses I'm getting for reviews on oncology based pharmacogenomics. So I think, yes, we are in the process of.
That is at the level of the germline.
Yeah.
The somatic level, it's a different story.
Any further questions? Yeah.
So my question is to Vinod sir. What kind of genomic testing are available for people who had family history of myocardial infarction? As you said, genomic tests are available. So is it easily available like all the other tests? Because I had a family history where this had happened. So I was asking.
Yeah, so this is something that the genetics department should actually start with a pedigree, because everything in genetics which is familiar, which is familiar may not be genetic, but everything which is genetic is familiar, right? So somebody needs to really evaluate the three things that you need to evaluate. One is the pedigree or the relationship between individuals. Second is the age of onset, which is typically peculiar for genetic diseases. So when you take a complex disorder like myocardial infarction, you expect a large proportion of myocardial infarction to happen in the mid-50s to mid-60s. That's a profile, right? So everything that you can sort of build into a bell curve. Extremes of this phenotype are always important. Extremes could be protective, extremes could also be detrimental. So for example, if you have a familial history of myocardial infarction in mid-40s, that's clearly an abnormal entity, and that is clearly an outlier, very likely to be a genetic. If you have a pedigree, you have age of onset and the severity of the disease, and you have a mode of inheritance, whether it's autosomal dominant, recessive, X-linked, then you can pretty much pinpoint on what is the test that you need, right? If you don't have any one of this, I would recommend you to do a whole genome, right? You cannot throw stones when you're blind. If you want to throw stones, then actually you can use an AK-47. Right? You shoot everywhere, you will hit somebody, which is a whole genome sequencing. But if you want to really hit what you want to hit, you need to do that additional clinical analysis or a genetic analysis.
It's nice talk. See, when we talk of whole genome sequencing, we all talk about it. But whole genome sequence will not work out until there is an environmental interaction. Either you talk about drug interaction with the environmental factors, drug with the genome, environment with the genome, will decide on the final outcome of the disease. So then how we definitely can tell because single gene is not a thing which can regulate a single pathway. It's a multiple pathway. One drug regulates multiple pathways. How to pinpoint? Just sometimes think about it. How to pinpoint exactly this will be happening there.
So I'll give you just two examples, two extreme examples. The one example is BRCA1, BRCA2. Right? I'm only talking about Mendelian disorders. The BRCA1 and BRCA2.
They work very well in the Mendelian disorder.
I'm only talking about Mendelian.
Okay, you're talking only about Mendelian, not other disorders.
BRCA1, BRCA2 is associated with hereditary breast and ovarian cancer. The lifetime risk of breast and ovarian cancer is almost 85%. That means that if you have BRCA1, BRCA2, almost likely that you will get breast or ovarian cancer in your lifetime. And therefore, you can put yourself into a high risk screening very routinely and be able to diagnose them very early on, because stage 1 of breast cancer is treatable with a very favorable outcome. You can live your entire life. But if you have stage 3 or stage 4, then there's pretty much nothing that can be done. So the opportunity is there. You can, where the risk is large, you can do screening. Now I'll do the other extreme. I talked about cardiac channelopathies. The lifetime risk of cardiac channelopathies is only around 30%. Right? But then how do you use that genetic testing is because if I know I have that particular mutation, I would not put myself into strenuous activity. I would not put myself into stress, because these are all trigger factors, which are environmental factors, which can be additive. If I have a BRCA1, BRCA2 mutation, as a male, I can get prostate cancer. I can also get male breast cancer, but that's much rarer. I can get prostate cancer. The risk of prostate cancer is much larger if I smoke. So, by knowing the genetic insult, I can now proactively modify my environment. Oh, can I answer this? That's right. By early detection. Right? But unfortunately, early detection cannot be done to everybody. See, the problem is also that when I have the entire population do MRI, the answer is no. Right? Even I cannot do a mammography for the entire population. So I need to first triage the population. Right. But what I can at least do is to find out this 1% of people. So in fact, the prevalence of BRCA1, BRCA2 in the population is 1%. 4 times that of international average prevalence. That 1% of individual, I can tell that you do mammography and you can diagnose very early. I've prevented that. Right? And I have a modality to prevent it, evidence to prevent. I'm not changing anything. Not really. I can give you this numbers. So if you take if you take the population, BRCA1, BRCA2 mutation is approximately 1%. Of course, it might be different in different subpopulations. Like, for example, some subpopulations of endogamous have larger founder mutations and larger frequencies. Like Ashkenazi 1 in 40 prevalence. Having said that, if you ask breast cancer patients in your clinic, what's the prevalence of germline mutations is 30%. 30. That means 1 in 3 individuals with breast cancer do have one of the HRR mutation pathway genes. Advantage being that both of them are important. The population scale is for risking. Patients is to understand whether they can be eligible for PARP inhibitors. And more importantly, can their extended family be counseled and tested? Because these are autosomal dominant conditions, 50% of the relatives will have it. They might have different kinds of cancer. BRCA2 is not only breast cancer, it can be prostate cancer, it can be pancreatic cancer, it can be many other cancers. So they can be screened. And therefore, the onset can be prevented or early diagnosed.
Thank you. Can we have the question during the lunch hour? Because we are running late. So this was a very intense session as well as discussion. We have to quickly move on to some intramural project presentation. So our faculty members here at AIIMS Bhopal have submitted some projects, intramural projects based on precision medicine, and the projects that are going to be presented here are focused on pharmacogenetics, pharmacogenomics. So we would request all the presenters to take time which is allotted, hopefully within 10 minutes. And the first presenter that I'll call upon is Dr. Yasmin from Department of Medicine.
Good afternoon all. Today I am presenting my intramural project on pharmacogenomics, that is the longitudinal assessment of pharmacogenomics of pantoprazole in functional dyspepsia, understanding the genetic influences on treatment outcomes. Basically, we all know that dyspepsia is a very prevalent problem in Indian population. Around 40 to 50% of the OPT visits are related to dyspepsia patient, and all over the world it includes 3 to 5% of the primary care visits. Symptoms of dyspepsia include epigastric pain, burning, postprandial fullness, early satiety, bloating, nausea, and belching. In functional dyspepsia, especially epigastric pain syndrome, medications like PPIs or H2 blockers reduce the gastric acid secretion and elevate this pain or burning. It is a very distressing symptom for the patient. Variability in PPI efficacy involves genetic and non-genetic factors like meal timing, co-administration with other drugs, which affects its absorption and metabolism, notably CYP2C19 activity. CYP2C19 genotype accounts for around 57% of pantoprazole clearance variability in adults. So basically, CYP2C19 enzyme is responsible for 57% of the clearance. Rest is managed by CYP3 enzyme. Now, how do we diagnose?
Vinod, this question is for you. Is it worth doing some in genomic study for pantoprazole when you got esomeprazole and other rabeprazole probably, which are not metabolized so much by CYP2C19? You can use an alternative drug. You just.
I have two thoughts on it. One of it is scientific, and one of it is conceptual. Scientific. I have two thought processes. One is scientific and the other one is conceptual. The scientific thought process is every study, whichever drug it is valuable. Right? We might learn something from it. A conceptual point of view is exactly what you stated. For a drug that is widely used, which is cheap, and the alternative is also affordable, very unlikely people will do pharmacology. Right? So if I were to think of it in a non-scientific aspect, in a sociological aspect, I would say that information is useful, good add addition to literature, but very unlikely people might use it.
It's a good point that when the alternative is affordable, that's a good point that you can straight away go with an alternative. But as a pharmacologist, I think we also need to know about the long-term consequences of the alternatives also. In this case, it's okay. It's a good alternative. It's a scientific point, but the pharmacologist, I think you guys know very well that, except forget about this scenario, think about another scenario where you have a new alternative, which we don't know much about. Maybe in that case, that's just wanted to add something to the youngsters. Thank you.
So we decided to use pantoprazole because it is most commonly prescribed drug in our clinics. We commonly use pantoprazoles in our outpatient department, so decided to go with this drug. How do we diagnose Rome 4 criteria? Is used for diagnosis of functional dyspepsia. It includes sense of solid or liquid food stucking, lodging, or passing abnormally through the esophagus. Absence of evidence that the esophageal, mucosal, or structural abnormality is the cause of the symptom. Then absence of evidence that gastroesophageal reflux or eosinophilic esophagitis is the cause of the symptom. Absence of major esophageal motility disorders. This criteria should be fulfilled for at least 3 months with symptom onset, at least 6 months prior to the diagnosis, with a frequency of at least 1 per week. Now, how we proceed in a patient of functional dyspepsia? The patient comes to the OPD with complaints of recurrent postprandial fullness, early satiety, epigastric pain or burning. We do a history and physical examination. We look for any alarm features. Alarm features include significant weight loss, GI bleeds, family history of malignancy in the patient. If any alarm features are present, we go for upper GI endoscopy with biopsy. If no alarm features are present, then we consider empirical therapy with PPIs or H2 blockers. If the symptoms are resolved, we treat accordingly. Now, with in the patients who undergo upper GI endoscopy, if abnormality is identified, then we move according to the treatment of that structural abnormality. But if no abnormality is identified, then we classify the patient as functional dyspepsia. Now, functional dyspepsia comes into three classes, that is postprandial distress syndrome, where the patient mainly complains of satiety and fullness, while epigastric pain syndrome, where the main Now, how will we assess the severity of symptoms? We will use Glasgow Dyspepsia Severity Score. This score is a validated. So it is a longitudinal study design. The inclusion criteria will include all the patients with age between 18 to 60 years with a diagnosis of functional dyspepsia coming to the outpatient department will be eligible for the study. The patient should give consent for the study. Exclusion criteria will include all patients with unintended weight loss, presence of dysphagia, persistent vomiting, evidence of GI bleeding, family history of malignancy will be excluded. All the patients with peptic ulcer disease will be excluded. All the patients with malignancy will be excluded from the study. All the patients who are H. pylori positive on biopsy will be excluded from the study. Procedures, the study site will be outpatient department of AIIMS Bhopal. The process, we will identify the patients with functional dyspepsia according to the Rome 4 criteria. At the initial visit, the patient will be assessed using Glasgow score for dyspepsia, and these scores will be categorized into tertiles for subsequent analysis since we don't have a specific cutoff in Glasgow scores. And then we will analyze these patients for two specific SNPs, that is RS4244285 and RS1224860 within CYP2C19 gene using RT-PCR analysis. Then we will follow up the patient at 30 after prescribing the treatment with pantoprazole, we will follow up the patient at 30 days to reassess their Glasgow score. Sample size, we shall include 75 patients with functional dyspepsia as most of the studies have been done in the Asian population and the data size is very low. In previous studies, it has been ranging between 20 to 45 patients only. Outcome measures will be the presence or absence of these SNPs in CYP2C19 gene, and the changes in the Glasgow scores of the patients will be a measure of response to therapy, whether those with SNPs RS4244285 and RS1224860 have a greater decrease or increase in Glasgow score as compared to those having absence of these SNPs. We all know that RS4244285 has been associated with the genotype of CYPC2C19 2 allele, which is a no function allele since the enzymes function will be absent. So these patients will obviously have a higher level of the drug, and the drug will remain in the body for a longer period of time, and we are thinking that the GCS scores will be low in these patients as compared to the other patients. While in RS1224860, it is associated with the CYPC2C19 17 genotype, which is seen in rapid metabolizers. That is, the drug will be very rapidly metabolized in these patients. So we will need a higher dose of drug, or the patient's symptoms will not be relieved and they will will be having higher GCS scores as compared to the normal patients. Novelty, we aim to bridge the gap in the current understanding by conducting a detailed longitudinal assessment of treatment outcomes correlated with specific SNPs and how genetic variations in CYP2C19 gene impact the response to pantoprazole therapy in patients with functional dyspepsia. It integrates the pharmacogenomic analysis with standardized dyspepsia scoring, that is Glasgow score, to personalize the treatment strategies. If we are able to know that which patients will better respond to the PPIs, and if we are able to know that which patients will not respond, then we can offer them other drugs or other treatment strategies so that they can be relieved of their symptoms. As we all know that dyspepsia is a very distressing symptoms, and these patients keep on moving from OPD to OPD, and they don't get relief from their symptoms despite taking multiple drugs, and the problem is really there. By identifying the genetic markers associated with variable treatment responses, the study aims to facilitate the tailored dosing regimes that optimize the therapeutic outcomes for individual patients. Longitudinal study design enables the observation of changes in symptom severity over time, providing insights into the stability and durability of the treatment effects. Since most of the studies have been done in Asian populations, the data regarding the South Asian population is lacking. So this study is a novel study in this regard and one of the foremost in the Indian populations. Relevance of the research question: by identifying these variation in the gene that influences the pantoprazole metabolism in patients with functional dyspepsia, we can we can obtain a personalized treatment regimes for these patients, and this information will be really crucial for optimizing long-term management plans tailored to the individual patient needs. Clinical applicability: the outcomes have the potential to enhance patient care by integrating pharmacogenomic testing to the routine practice, and by incorporating a genetic data into treatment decisions, clinicians can aim for better symptom control, improve patient adherence, reduce healthcare costs associated with ineffective treatment.
You can have one question or comment or suggestion if anybody wants to.
Just one quick question. So it's an observational cohort that you are doing, only one single arm, but you are doing only genotype based dose adjustment and you are monitoring the patients. So is that the right design to prove or to create evidence for that your genotype based dosing is more optimized compared to standard of the care, or you're going to, sorry, it's an intervention. You are changing the dose.
Because we will be starting with PPIs. Yes.
You said the prospective longitudinal study. I understand.
So
I think
basically, the PPIs are the routine drugs being used for the patients of functional dyspepsia. So we will be prescribing these patients with PPIs, and we will be selecting 75 patients of functional dyspepsia, and then we will analyze their GCS scores, and then we will look for the specific SNPs in those patients.
So it's not actually a intervention.
it's not intervention.
It's not intervention.
No, you said suggesting that that is the intervention actually.
So later on, after the completion of the study,
Okay.
we
You
know
want
that
to? Okay.
we can use it for the help of the patient.
Okay. Got it.
Thank you for a wonderful presentation. I have been online since morning and there have been very excellent presentations. And Dr. Yasmin, one thing that I wanted to ask was the presence of, like, most of the population, which even today we do not go for the investigations for H. pylori, which is one of the most common causes to cause, severe gastritis and not being treated. So have you, because I missed it in between for a minute
Ma'am,
or
we will
two.
exclude the patients with H. pylori infection who will be going for gastric biopsy through endoscopy.
Okay, so you will exclude this. Okay.
Sir, the prevalence of C/PC to C19 to genotype is around 33% in North Indians in some studies and 36% in South Indians. While C/PC to C17 is around 16 to 17%. So, since the data is really not available in Indian populations, because most of the studies have been done in Asian populations only, and some data is available for African populations, Caucasians, but in Indian population there is really lack.
Thank you, Dr. Yasmin. And we have the next speaker, Dr. Murli. Yeah. And in the interest of time, I ask all the speakers who will come up now to mainly stick to the rationale, the objectives, and then the methods of their presentation, because we are all standing between the audience and the lunch.
Good afternoon, everyone. So this is my intramural project which I have submitted for the grant. So this is the title of my project is Integrating the Pharmacogenomics and the PAPK for the precision therapy for oral alkylating, that is chemotherapeutic drug, the temozolomide, that's based chemoradiations in the treatment of the glioma patients from the central India. So these my collaborators are from Department of Neurosurgery and from the Department of Radiotherapy and from the Department of Medical Oncology with our department from the Department of Translational Medicine. So I'll go through, I'll skip the slide, okay, one by one for the coming to the background. So that you can see the incidence as well as the prevalence of the primary, that is the gliomas, and moreover, the Indian Council of Medical Research, and based on the hospital-based cancer registry, the brain tumors supported for 1.6% related to all types sites of the cancers, and the incidence of CNS India ranges from the 5 to 1 lakh of the population with an increasing trend. So moving ahead, the biggest challenge is like the extreme therapeutic challenge, as well as the labs, as well as the survival rate is median survival rate is between the 14.5 to around some 17 months, the grade that is for glioblastoma patients, as well as there is a chemo resistance based on because of the drug will not in the methylations parameters of the MGMT06, that is methylguanine DNA methylations plays a major role in the that is temozolomide resistance. When it is hypermethylated or unmethylated, based on that the response we get. If it is unmethylated, you will not get any response, and by treating the temozolomide, when it is methylated, unmethylated means you will get the response with the TMZ treatment, and based on that, so the temozolomide is a prodrug, so it undergoes the metabolisms, undergoes the metabolites which you can see here is MTIC, that is I don't to just IUPAC name, and again it also metabolizes into a non-active metabolite, that is AIC, that is an intermediate of your purine metabolisms. It is mostly excreted in the urine. So 50% of the temozolomide as well as these metabolites are the refractory to this therapy, and when they come to the pharmacokinetics parameters, it has got very short life, that is around 1 hour, and in the empty stomach, and it is in the fast meal, it is around approximately 2.25 hours. And half-life of the drug is around 1.8, and clearance rate is, you can see in this, and the standard therapy is a standard chemotherapy along with the radiation therapy, and after that adjuvant as well as the maintenance therapy is based on for the 6 cycles, and we have to increase the dose of 150 to 200 milligram per meter square body surface area without or with radiation therapy. So what is MDR1? MDR1 is the drug transporter enzymes or the P-glycoprotein enzymes. So this plays whatever I just mentioned, what are the the polymers of SNPs which are present in our Indian context, in our North Indian, that's already have got in the pharmacogenomics journal. Based on that, just here I wanted to investigate the MDR1 gene polymorphisms in the context of your central populations. This is a pilot study which I'm going to screen. I wanted to know which polymorphisms from the genotype, and I want to based on that. So along with that, that is already is a proven marker, that is O6, that the methylguanine DNA methyltransferase. So I have to combine this both as a predictive markers. I want to screen in our central populations, and along with that, I wanted to do the population pharmacokinetics to understand what are the covariates. The population pharmacokinetics is nothing but it's a subfield of your pharmacokinetics that studies the variable in the drug absorption distribution as well as the metabolisms of across the populations. It also aims to understand how various factors, cofactors such as age, weight, and genetics of the disease influence the drug pharmacokinetics. I can show you some differences between the traditional pharmacokinetics as well as the population pharmacokinetics. In traditional pharmacokinetics, we particularly we just the component models like linear kinetics, but here we just work on the non-linear mixing effect models plays a major role, and as well as the assumptions, it is a linear kinetics, homogeneity, as well as a minimal variability, non-linear kinetics, heterogeneity, and significant variability. So with this, I just designed the rationale of my study is approximately 50% of that temozolomide treated patients are refractory to this therapy. The main barriers of the cancer therapy, that the medications are characterized by means of your narrow therapeutic windows as well as the drug resistance and the substantial intra and the intra-patient's variability in the therapeutic as well as the toxic effects. So the MDR1 also plays a major result in the intensity, that is glioma resistance, that also plays a major role in the outcomes in the therapeutic failure of your chemotherapeutic drugs. And also another prominent role is that is, as I mentioned, that is MGMT also plays a major role in case of your resistance of your GBM. So this all the epistemological knowledge of the pharmacogenomics as well as the population pharmacokinetics could be potentially that is utilized for designing the individualized drug therapy for your temozolomide, the patients who are resistant, who are having for the better therapeutic outcomes as to reduce the better, that is adverse effects as well as your resistance. With this, what is the research gap which I have identified is what has been done in the other ethnic populations. Already this, okay, the MGMT has been is a proven biomarker for fixing of your optimizations, you are like what you call for the temozolomide, like for your therapy, and as well as the SNPs also plays a major role, that is drug P-glycoprotein, MBR1 also plays a major role that has been studied in various ethnic populations, other populations, and also the population pharmacokinetics for your metabolites, MDIC, as well as for your the temozolomide drug has also been studied in other ethnic populations, but whereas in India, so there is a heterogeneous outcomes of the MGMT promoter methylations also, and also there is the correlations, the different genetic alterations that is makes very hard to treat the evidence-based treatment. And also the literature suggests that there is no Indian study pertaining to development of the population pharmacokinetic model for temozolomide and its metabolites in the glioma patients has been carried till date. And there is a current study that aims to explore the use of MDR1 gene polymorphisms and MGMT promoter methylations among the glioblastoma patients for the population pharmacokinetics model approach and potential dosage individualization plan. So these are just the objectives are to investigate the MGMT promoter methylation status and also to study the SNPs, that is from our patients who are with the temozolomide chemoradiation therapy along, and as well as, and the third objective is to estimate the plasma drug level of the temozolomide as well as the metabolites in GM patients, and for studying to know about the pharmacokinetics parameters by using LCMS method, and also to with all the parameters, genotypic parameters and the methylation parameters and all covariates, we want to develop the population pharmacokinetics in our sets for your central populations to know the study the populations for recommendations of your dose optimization. So with this methodology, the department involves, as already mentioned, neurosurgery, radiotherapy, medical oncology, and translation medicine. So this is a pilot study that first initially wanted for the proof of concept. We just taken only 25 samples to 30 samples per year. Only this project is just for only 1 year, the duration for 1 year. Based on that, so we are just wanted to like recruit the patients from the radiotherapy and who are on glioblastoma, that is grade 4 like patients, and we want to screen the MGMT polymorphisms as well as the MDR1 polymorphisms, and coming to the pharmacokinetics, and we want to like, these are my inclusion criteria and exclusion criteria. That's here your glioblastoma subjects from the central India, you can see, and what are the colonoscopy score, the KB score should be like greater than 70, that is an assessment of the stool for the functioning of your impairment, as well as the post-operative cases of your glioma up to 8 weeks, and the proven biopsy cases will be taken, and the chemotherapy drug dosage for the maintenance therapy and for radiation therapy I mentioned here, and the toxicity, patients who are on toxicity with the thrombocytopenia, neutropenia, and as well as the bone marrow suppression to temozolomide can be recruited, can be considered in the inclusion criteria. Coming to exclusion criteria, the subjects other than central India and the previous history of your cancer-related surgery and other like that drugs, the inducers or the inhibitors, the temozolomide can be like excluded. So coming to the samples collections for the genotyping, first we thought of like okay, screening of the MGMT polymorphism, MGMT methylation studies from the tissue samples because we don't have any like feasibility of obtaining the tissue samples. We are thinking to like do the MGMT studies from blood samples. One study has been already reported. We can extract and we can do the from the CFDNA, and we will try and we will establish this method in the translation medicines. And moving forward, we wanted to do the pharmacokinetics populations for that, the time sampling points I mentioned here. So here I wanted to like collect the samples. We wanted to collect the samples, the patients from the patients who have already reached the steady state concentrations of the drug, the peak concentrations also taken, as well as the patients which are already trough concentrations from the steady state concentrations, the time points I mentioned, that is from the windows time point from 1 to 3 hours, 4 to 6 hours, and 7 hours to 12 hours, and 12 to 14 hours, from the ranging from 3 time points to 4 time points, depending on the convenience and the logistics, we are going to collect the samples. And followingly, we are going to genotype, MDR1 genotyping, and will be done of extraction of your DNA, we'll be doing by Tiemann genotyping method, and as well as for the MGMT promoter methylation kit, and we will be procuring the kit, and we will be doing by using the methylation specific polymorphisms and chain reaction studies. And already just I mentioned for the genotyping of MDM G1 polymorphisms, and for the temozolomide and these metabolite estimations, we have the LCMS system in our AIIMS, that is acute TH class system with a Zivo, the TUS, that is a micro. So we used to establish the method, and also we have to validate the method for pharmacokinetic studies, and with that we will be doing all the PK analysis. So will be the modeling step which I mentioned here, or like patient demographics, we will be inputting and pharmacokinetics analysis, and we will incorporating all the inputs from the PK, that is pharmacokinetics data, as well as the pharmacogenomics data from MDR1 gene polymorphisms. We have the structures like base structural and statistical model, and moreover the pharmacokinetics like PK analysis will be done by PUMAS package, that is freely available software. It is available earlier, the non-MEM software, we can do it by either by non-MEM software or else by PUMAS package, that is a freely available software. So this is a tool used to run all your pharmacometrics in modeling as well as the simulations. And the modeling step which I mentioned, the structural component, statistical component, and the covariate component developed by using the various visual predict check, goodness of the fitness, as well as non-parametric bootstrap. By using all these parameters, when you input everything, we create a model. Based on that model, it will give the output, the clearance output, so that we can use the PK model. What are the cofactors? Whether it is the cofactors that is BSA is affecting the drug, or whether it is like covariates like pharmacogenomics that is affecting your like a drug, as well as the other like parameters, biochemical parameters, or affecting your like stress response, we can calculate and we can measure by using the PK method. So what is the application in clinical practice? Once you diagnose the patients with the GBM with the prescribed temozolomide, for the patient dosing protocol, we have to collect the samples, we have collect all the covariates as well as, and based on that is proven like MGMT, like promoter methylations and the MDR1 gene polymorphism, which enzymes, and basing on your input, we'll get a clearance, and based on that, we can go for that dose optimization. So, and what is the research outcome? So already the population pharmacokinetic model will help to recommend a precise dose regimen for individuals with the temozolomide therapies patients for better outcomes, reduce adverse events and resistance, and increase the survival rate of glioblastoma patients. So now this work has been carried out at the AIIMS Delhi when I was working in AIIMS Delhi. So one of the paper on MDR1 CM, that is for the MDR1, that is pharmacogenomics of ATP binding cassette transporter, that is we have screened polymorphisms, we measure the TMZ, and we have correlated genotypic and phenotypic, and this has got like annotations in the form GKP, and they are published in the pharmacogenomics journal with this supporting like MDR1 gene polymorphisms. Now here we want to establish the PK method, and we want to establish the like MGMT polymorphisms, MGMT methylations and the biomarker, as well as MDR1 polymorphisms, as well as we want to develop a method for temozolomide as well as the metabolites in our own institution, so that we can help the radiotherapy department and other cancer patients, and for the therapeutic drug monitoring, as well as for genotypic, as well as for your biomarker screening. So with this, I just thank you, everybody. Thank you.
Thank you, Dr. Murli. Any comments or suggestions from the experts?
So we don't have any population pharmacokinetics, like no study has been done here. Okay, in India, maybe in other Westerns, they tried some like for the population pharmacokinetics, we need the maximum samples ranging from 30 to like 1,000 or 500. Okay. So already from one studies where I have gone across, that's 39 patients for the infants, they have screened. Okay, they have done POPPK studies for temozolomide, okay, in the infant populations. So we don't have a data in our Indian scenario. We have only the genotypic data and pharmacokinetic fluctuations. We know only the proven biomarkers, only MGMT. Apart from that, okay, for the any for TKAs or any newer like for the targeted drug therapy and for TKAs or monoclonal antibodies, whatever we treat along with the temozolomide for the maintenance therapy, for the adjuvant therapy, it doesn't work. And only the they have like mentioned only the overall survival is no it's of no use. It's not used, that's not extendable like okay survival, and for the PFS like at least for 3 to 4 months they have mentioned, sir. Yeah. Yeah. Existing models. Yeah, that also we can try, and okay, then
I think that is the first way to do, because you are developing a new model. It's maybe different than others. Again, it's that's what he's asking.
It's a which
there are a lot of POPPK modeling for temozolomide established. I think you can try the existing model.
Existing model, yeah.
Then you can go for, if you want, you can do in your own model.
Yes, that can be done.
Yes.
Yeah. But here there is just only the 25 sample, that is 230 samples. That's for POPPK is not sufficient.
So
Here
that's the bottleneck. The sample is the bottleneck.
Yeah, bottleneck, sir. That's the problem.
Yeah, so.
Feasibility 1 year, I'm not sure.
Is very difficult, but still we'll try to get the sample size. We just okay. That's a pilot, this proof of concept we want to establish, and further we want to validate as okay, suggested, and okay. So we'll just carry forward and to submit into some extramural grants in future.
And maybe even for youngsters, you can also think about physiologically based PK models also.
Yeah,
in addition to
that is also available, and we can also think of
PK,
that.
and then try to
build up a model and validate it. Okay.
Yeah, that could be something that could be done even without all this exercise.
There are other drugs also which are being used for the same glioblastoma, and monoclonal antibodies, carmestin, anti-seizure drugs like phenytoin and all, they do affect the induction, or they stimulate the enzyme CFP, chrome P450. So how do you ensure that the patient is only on monotherapy? Because that is what is now being used more commonly, monoclonal and everything. So how do you take into account when multi-drugs are given?
Ma'am, the temozolomide is getting metabolized only by PGP glycoprotein pathways, plus drug transporters, not by phase 1 or phase 2 metabolizing enzymes. Okay, whatever the phase 1 or phase 2 enzymes they give, and it will not get metabolized, okay, by the drug transporters enzymes. And moreover, for the temozolomide is the standard of care. Okay, it has been approved by US FDA in 2005. Till now, okay, only this is the standard of care that we are using for treatment of glioma patients along with the radiation therapy, ma'am.
But I do know of patients who are on monoclonal antibodies. So how do you
only we can increase the PFS survival, not with the overall survival. It cannot be extended, ma'am. Okay. Still they are trying, but still it is sometimes it works and sometimes doesn't work. TKI inhibitors, monoclonal antibodies, as you suggested. Okay, others drugs also.
So it is not going to affect in any case.
Right,
Even if your patient is on multi-drugs.
No, ma'am. No, ma'am. It's only PFS survival is just increasing.
Okay.
Yeah.
I mean, I don't know how many oncologists are
here,
but I
can
would definitely like
this,
their
okay.
comments on this.
We are the routine to MGMT gene methylation. That
Yes.
is in all cases of glioblastoma.
Yes, ma'am.
It is a decision of the radiation oncologist to decide whether they want to give it or most of them add temozolomide to the protocol anyways.
Yes, ma'am.
But they do have comparison data, and I believe the ones who have the methylation actually respond better.
Yes, ma'am. That's how. Still, look, unmethylated, they don't, and
This
some
is like a routine test. Of course, it's nice that you're going into the pharmacokinetics.
kinetics and so like skin. I'll just compare the drug levels, and more after doing maybe in future we think of with the CSF samples also.
And maybe other
markers, metabolites and boosting it. Yeah.
Congratulations on your project.
Thank you, ma'am. Thank you very much.
बीच में करता हूँ तो बीच में करना ज्यादा अच्छा है। हाँ हाँ वही होता है। हाँ पिछली बार जो हुआ था वो वही वाईफाई यूज किया था, इसलिए वो आ गया था।
Good afternoon, distinguished faculties. I am Dr. Jitendra, Assistant Professor Neurosurgery. I want to thank OMICS to give me opportunity to present my intramural project over here. I want to develop a novel device which can replace.
I'm sorry, I just wanted to add that Dr. Jitendra's project is not per se in pharmacogenomics, but it is a precision medicine based project. So please have a look at that.
So the conventional neck supports that we use in neurosurgery will mostly discomforting to the patient, and mainly the people at home cannot use them. So I want to design a new device. The conventional device is on the right hand side of the screen, and this flow that I want to develop is a novice device. Then I want to compare it from between 10 patients, and then then the feasibility and what the benefit the patient get, we'll get to know after the study. So Philadelphia collar, that conventional device we use in hospital, it is easy to use because residents or consultant nursing staff is going to use. But when we discharge a quadriplegic patient to the home, then it is difficult to use them, and most of them attendant are not able to use them properly. And at that time, there is difficulty in feeding. Patient is unable to speak also. But there are chances of aspiration also. By this device, I hypothesize that this novel device will uh, give good nursing care at hospital and afterward in home also. So this is my cartoon representation of the device. Right hand side is the conventional device, and left hand side is novel device that I want to make. So these are patient discomfort, satisfaction, and patient usually like in anxiety. So when the upper collar is not present, the patient feel that the amount of depression he will feel less. So this is discovery pilot study I want to start by making a novel device. So the study can be done in 2-3 months because most of the patient we are getting C spine, quadriplegic spine. Thank you.
So here, so it's cheaper than the current device what you have.
I think, sir, I have calculated that it must be lesser cost than a conventional device.
The question is, so what material you put in that new device?
That is the commercially available foam based that mattresses we use.
Okay.
So I want to make by hand myself only.
Okay.
So I think the cost will be definitely less than conventional device we are available.
So is there any expect some skin issues when you put up that?
That is the main thing that I have to check.
Okay. So you have that objective in here.
That objective I have.
So device induced ADRs.
Yes, sir. Yes, sir. That is the main thing.
Okay. Thank you.
Only the concern thing that is it going to a hypersensitivity there or not.
Okay.
Thank you, sir.
Thank you.
So just a scores of anxiety or the bed sores, incidence of bed sores or the skin allergies, we want to document and compare.
Sir, do you have a material vigilance program here?
Yes.
Yes. Okay. It's usually IAC will involve in that, right? They'll involve in that. Okay. Thank you.
Thank you.
And we have the last presenter for the project, Dr. Ajay Shukla.
Good afternoon to you all. At the outset, I would like to give a disclaimer that after all these complex projects, this one is going to be a simple and short presentation. The title of my project is Development and Validation of the Pharmacogenetic Clinical Decision Support Application. As we already know that genetic variants, depending on the drug, genetic variants are associated with to affect 20 to 95% of drug response and efficacy by influencing the pharmacokinetics, that is the absorption, distribution, metabolism, elimination, or the drug targets that can be on target or off targets. Therefore, pharmacogenetic recommendations are available online freely that can guide the clinical decisions for drug selection and dosing, which can improve the drug efficacy and avoid ADRs, which can lead to the increased adherence and outcomes. PharmGKB is the data, PharmGKB, that is pharmacogenetics knowledge base, is a database which collects and curates and disseminates the information for various professional bodies like CPIC, DPWG, USFDA, and gives the information regarding clinically actionable gene-drug associations and the genotype-phenotype relationships. But despite this information being present, there have been poor application of pharmacogenetic, which has been a main barrier for implementation of the studies in routine treatments. Apart from the cost, the information that is available in those databases is very much complex, so comprehensive, and not patient-specific. So a rationale for doing this project is the clinical research and support application that integrates pharmacogenetic data can address these barriers by providing the real-time actionable recommendations to the healthcare providers. It will facilitate the clinical decision making and improve patient outcomes. Therefore, our project aims to develop and validate a pharmacogenetic clinical decision support application to achieve these goals. Aim of our project is to develop a pharmacogenetic clinical decision support application, and objectives is the selection of the actionable gene drug pairs on their actionability and availability in our country, development of the application prototype, and evaluation of the application in the real world setting. So basically, depending on the objective, we have divided the method in 3 phases. First phase, we will select the actionable gene drug pairs depending on the actionability and whether these are available in the country or not. Second, we will select the genetic variants of the pharmacogenes depending on the latest CPIC guidelines. And third, we will obtain all the possible genotypes that could be linked to the specific therapeutic recommendation. In the second phase, we are going to develop an application prototype. If I were to demonstrate a rough framework of flowchart of what we intend to plan, that physician or the clinician will add the name of the drug, and it will suggest whether the pharmacogenetic testing is required or not as per the guidelines. If it is no, that he can continue with the treatment. If yes, which pharmacogenetic test is basically required. And after the testing is done, if he enters the test results, then it will give the recommendations based on the evidences. So, if you look at the rough the framework of that, physician will enter the drug name and he will give the whether the pharmacogenetic test is required or not. Second, if he adds the drug name, pharmacogenetic test is required, then he will write the drug name, then which pharmacogenetic test is required. It will give which CYP, which SNP or Indel, or it will suggest that. And if he enters the pharmacogenetic results, it will give the recommendation according to the guidelines. After the development of the protocol, we will evaluate the application in the medical setting. We will do the qualitative analysis among the prescribing physicians to determine the user friendliness, satisfaction, time taken, accuracy, and we'll incorporate these changes into that. So basically, we will focus on basically the format of the application will be focused on the inputs from the clinicians so that it can be used more widely. So if you look at the flowchart of the methodology, first we'll do the data extraction and curation from the websites, principally farm knowledge base. Then we will do the prototype development, and we will get the feedback and evaluation from the clinicians, and we will do the appropriate changes after that. So our expected outcomes are facilitation of the pharmacogenetic based clinical decision making by providing precise real-time actionable patient specific drug recommendation based on the pharmacogenetic test results, and it will basically lead to the broader adoption of the pharmacogenetics, which will lead to the improved awareness and utilization of the pharmacogenetic information in clinical practice, and optimized therapeutic outcomes in terms of the increased medication adherence and poor reduced incidence of ADRs. Thank you.
Any comments or questions?
Buddy. Thank you.
Thank you very much, all of you. This has been an extended session. I'll just finish off by giving the rapporteur's report in the shortest time possible. So we have had three wonderful speakers coming up here and giving their presentations. We have had 4 intramural projects which have been presented. So we started out in the morning with Dr. Anand Bhan's session, where he very succinctly talked about the ethical challenges that are likely to be faced in doing precision medicine and research in precision medicine as well as its application. You know, how will we adopt new technologies and, you know, the accuracy, cost effectiveness. And he ended by talking about something called as person-centered approach. He also introduced us to some of the principles of using AI in research, the new guidelines that have come. Then we had a session by Dr. Rao, who talked to us about how pharmacogenomics is used as a tool for research and what are the tools for using pharmacogenomics. And he provided us with case studies regarding busulfan. He talked to us about drug-drug interaction with genes, using examples of anti-malarial drugs like artesunate, atogacone. And he also gave all of you introduction to databases like PharmGKB, PharmVar. Then we had the last speaker, Dr. Vinod Skaria, who talked to us about how pharmacogenomics fits in today's space when we have personal genomics available. So he really gave us a glimpse into the future, whereby we can imagine doing whole genome sequencing of individuals in short duration of time in the future. So he gave us examples of clopidogrel, 5-fluorouracil, how the various genes associated with them, can be evaluated, and how there have been large inter-ethnic variability which has been found. So all of these sessions were very interesting, very informative. I hope all of you have taken some outputs for your own personal, learnings and future projects. We had 4 project presentations. I thank all of them. And I think with that, the scientific session is now coming to close for this particular session. I would request for the felicitation to be carried out.
May I please invite our chairperson to please come up and felicitate our distinguished speakers and presenters. Dr. Yasmi, I think she is not. Dr. Mulli. Dr. Jitni. Dr. Ajay Shukla. A sincere thanks to you, Dr. Vinod Sakaria, for your insightful presentation. So please come forward to receive your memento as a token of gratitude from our side. Now may I call Dr. Shubham to present a memento and certificate to our chairperson. Ma'am, please. Thank you so much. All will break for lunch now and resume back for our last session at 2:15 p.m. Thank you.
I changed my virus. No, they lights they don't.
Good afternoon, and on behalf of the organizers, it is my privilege to welcome all of you, the experts and all the participants who have come from different parts of the country, and it's a real privilege that we are going to discuss about the precision medicine pertaining to oncology in this session, which is part of the larger program which is going on since yesterday. Now, I think everybody in this hall would agree that precision medicine is particularly relevant in the field of oncology, be it surgery, or robotic surgery, or radiation oncology, which is highly precise a form of image guidance, or proton therapy, or systemic therapy like targeted therapies, immunotherapies, and all. Now, we know that if you cannot see it, you cannot hit it, and if you cannot hit it, you cannot win the game. So, unless we have some way to see the variation, a biological variation of the tumor, and then tailor the treatment based on that biological variation, we are not going to be successful or optimize as far as the treatment or the cost is concerned. India is a very heterogeneous country compared to the Western countries. We all know the pattern of cancer is different in different parts of region. Even though we have a registry data which covers less than 10% of the population, but that robust data shows that the presentation of the disease and its pattern of treatment is different in the different area. Pertinent question is that precision medicine, whether it is relevant for low and middle income countries. I think the evidence shows that it is highly relevant, because that is where the intensification of the treatment, and also another point is how to judiciously use the resource which is available and to have an utilitarian value to the population, that is important. So to take this session forward, we have very eminent speakers, and to chair this session, it is my privilege to welcome Professor Dr. Nilkamal Kapoor. Welcome, ma'am, again. And I mean, we all know ma'am, she needs no introduction. But for those who are outside from the institute, ma'am is the previous head of the department and founder of the pathology and lab medicine. She also had led the institute as Dean Research, and she had played a pioneering role in establishing the lab services of the institute. Welcome, ma'am. And I request ma'am to invite the next speaker, or shall I? Okay. So our first speaker is Professor Dr. Mahadev Rao. Professor Rao has been associated with AIIMS Bhopal for some time now, and his effort to establish in the field of the precision medicine is quite remarkable. Professor Rao is currently in the Department of Pharmacy Practice, Manipal College of Pharmaceutical Sciences, and coordinator of the Center of Translational Research, Manipal Academy of Higher Education. Dr. Rao has completed diploma in pharmacy at SSS College of Pharmacy and then a master's in pharmacy at Government College of Pharmacy in Bangalore. I mean, his CV runs in pages. After receiving his PhD from Manipal Institute, he has spent a significant time of his career in USA, where he has conducted several landmark studies under the aegis of National Cancer Institute, National Institute of Health, Bethesda. In 2002, he continued his fellowship in translational oncology at Lombardi Comprehensive Cancer Center, Georgetown University, Washington. In 2007, he moved to surgery branch at NCI as a senior scientist and made seminal work in clinical research and trial. And he also has also received several awards in US federal agencies. And since 2007, when he relocated to India, he established the Center of Translational Research in Manipal, and then he has been playing an important role in Global Cancer Consortium and trying to amalgamate many institutes in the Southeast Asia. So I welcome Professor Rao to deliver his talk on precision oncology in clinics.
Dr. Das, thank you very much for that introduction. And thank you, Dr. Biswas, who invited me for this presentation today. And I'm associated with AIIMS Bhopal for last more than 3 years. And happy to be back here again. So I'm going to talk about the precision medicine actually in the clinics, because I work in the cancer as well as one of the ICMR funded project in the tuberculosis also. So this is my disclaimer notice. So I'm not going to introduce this part, but for the sake of students, I just put up this slide. Earlier in every disease, now these days, every disease they call as a genetic disease. But this is basically from my previous institute, National Cancer Institute, where now they call it the genetic disease. And thanks to the Human Genome Project invention as well as TCGA, which is started in 2015. I think now you can go and check CBio portal or TCGA database. There are more than 100 tumor histologies has been classified. And what I want to say here is that, it's basically this disease due to the genetic changes. Now, one thing, we all talk about, prevention, early detection, many words we keep using. But one of the important thing is, if you look at the this slide where latency period, what we call, when this disease starts, you all know that. I think clinicians knows very well. Most of the time they'll come in India, maybe stage 3 or stage 4. So when exactly the disease starts? So if you look at on the left hand side, these are the different steps where you can get an invasive cancer from normal to an initiation of the one cell in the epithelium. Then you'll have a mild dysplasia, moderate dysplasia, severe dysplasia, and CIS, and eventually invasive cancer. So very, very nice, this figure has been illustrated in a way that every cancer behaves very differently in terms of latency period. It is not that, some cancers will have in 3 years, 5 years, we don't know. So if you look at for the first one, cervical cancer, so it may be, one step. If you want to look at the CA, and it takes 6 to 10 years, and then followed by 5 to 10 years. So the cells might have started maybe 10, 15 years ago. If you look at the lung cancer, if somebody smokes 20 to 40 pack years, you don't know when it starts, what is the exact idea about the when cancer has been started in your body. So the message, what I'm trying to say, we all talk about genome, a lot of the things we are trying to do, but this is also important to know that even diabetes, 7 to 8 years, you will not be knowing. In India particularly, some patient has to fall down, then only you know that he has a diabetes. Very unfortunate. Similarly, in the cases of the cancer, if you look at different cancers, the latency period is different years. And once again, I want to emphasize that the initiation starts maybe 10 or 15 years ago. So that is the one thing. It takes a long time to get proliferate and genetic mutation and different stuffs of the cancer, where you can detect in somewhere you have a cancer, the stage 1 or stage 0, whatever you call, the clinicians or pathologists know better than anyone. So that is a one complex thing in the case of the cancer. So in terms of precision oncology, when you talk, you need to know these problems. And another thing is, usually, when you classify the different stages of the cancer, pathologically or molecular subtype, again, you see now these are the different classes of the breast cancer. I think around 10 different types are there. If you go to CBio portal, you could see every day they are adding the new patient data. Now, if you look at on the left hand side, for example, we know usually DCIS and LCIS very common in maybe we studied in undergraduate or in the postgraduate. But there are a lot of different subtypes are there. Nevertheless, you have a more molecular subtypes, lot of genes which involved in these particular subtypes. So this is also very, important to know when you want to treat a patient, we need to have these complex problems. So in the morning talks, you all heard that, a lot of genomic or genetic changes are very important. But these, classification of these histological tumor subtypes as well as molecular subtypes to treat the patient. And then if you look at these, a lot of interest in understanding now, particularly in the United States, they want everything in the early detection. Cancer has to be detected as early as possible. A lot of new technologies like liquid biopsies, and the tumors are, heterogeneous in the genetically. So that is why, this is the process where you see if you want to prevent, cancer, you need to understand where exactly you have to start the therapy. So for that, what kind of a therapy? As I mentioned in the previous slides, you need to know, many things if you want to really go to the real world practice. So what we are calling now screening is if you look at the goal, most of the time we talk about early detection of the cancer. And as I mentioned in the previous slide, it's early detection means I'm talking about maybe stage 1 or stage 0, somewhere in there. But again, you have a latency period. There's another challenge. And then the guidance of local therapy or selection of systemic therapy and prediction of response. This is very important. I think yesterday, one of the audience asked that question, why we have to adopt US practice in here. Actually, quite honestly, I agree with that. This is you clinicians have to take a call. In my patient, what is the best therapy? It is not that what they have decided, you take this, you take this. No, I think this is very important in a point where locally you need to decide, clinicians have to decide what is the best. I will explain why, those things are very important. And finally, the early intervention is better so that you can treat the patient better. Now, this hall we talked about, I think Dr. Skaria had put this slide in the morning, one side doesn't fit all. So most interesting thing is, this is basically study from the United States where 75% of the cancer drugs don't work in the patients, because of the problem what we have just mentioned in the previous slide. So patient can respond differently to the same medicine. Now, US is spending a lot of money, and I practice there, and with the clinicians, nearly 20% of the GDP they spend for healthcare in US. Now, if you look at the same, as I mentioned, 75% of the drugs don't work. They did this is the Wall Street Journal article, and the Medicare patients who are basically paid by the government of the United States, and they did the math, and they found out approximately 79% of the treatment is not working. The same numbers on the left hand side, and it is just wasted. So billions of dollars which where they don't get benefit, particularly in the not only that in a general, but in the case of the cancer treatment, it may be little higher. Now, this is how the I think morning somebody sir has given slides talking about precision. It's not something new to us. I think it was there in our Ayurveda also, the precision medicine. But in the modern world, they talk about. That is what I put up that slide where the the clinicians were practiced based on the intuition in the past, and now we are all practicing the evidence based. The reason is because intuition in those days, a clinician and a patient, there is nobody else. There is no data. Now slowly, we have globalized. We have get a lot of or tons of data all over the world, and that is why we talk about evidence-based medicine. And then now you are all talking about big data, artificial intelligence, and this whole and integration of the different omics. All these things, there's tons of data poured from the different part of the world. If you go TCBA database or CBioportal database, there you have a more than 100,000 patient data. Every day it is updated. Anybody can go and access and see what is the different types of tumors are there in the different part of the world. So this is how the evolution of precision medicine has been over the time, and I think future. This is a very bright future for this precision medicine program. I think I really happy that AIIMS Bhopal has started this particular program in India, and it will be indeed beneficial to the many patients in this part of the world. And again, I'm not going to mention about this. Basically, enough one, right treatment, right patient, right dose at the right time. So you are basically stratifying the patient. So in the standard therapy, you give the drug whatever the based upon the what you did diagnosis, but in here you are stratifying the patient because of the particularly the genomic the genomic in the case of the cancers. Now We have, I think, back in maybe 25 years when I was a student, inter-individual variation of drug response. We typically studied in pharmacology. That was the questions every time we used to get in the examination. What are the, inter-individual variation in the drug response? But there is a lot of things have changed since then. I think that is why the study of the drugs now, study of the drugs on the genes. That is what now we call. Now, if you look at these are the different inter-individual difference in drug response. So, liver and kidney around 10 to 20%. That basically these diseases, doesn't allow the drug to act properly because liver is a primary organ for the metabolism of the drugs, and the kidney is for the elimination. And 20 to 30% of the drug-drug interaction. I'll catch up that later. And again, yesterday Dr. Sharan mentioned about placebo, around 10 to 30%, and unknown SNPs we don't know, around 5 to 10%. And morning, people talked about SNPs in the clinical relevance around 5 to 10%, and then 5 to 10% environmental factor AIIMS. This was when we studied in the pharmacology. This was the main factor, but things changed over the time because of the invention of the human genome as well as the cancer genome atlas. Now, SNPs determining phenotypes of clinical relevance, poor metabolizer, extensive metabolizer, ultra rapid metabolizer. There is a lot of guidelines out there. Now, it is also in an infancy stage in the world stage. However, in the like US or maybe in the Europe, there is some countries practicing regularly. So these are some important individual variation in the drug response. Now, I think Dr. Scaria mentioned in the morning talking about, it is very expensive. When you go to a medical oncologist, or who will do this screening for 5,000, 10,000 rupees for EGFR mutation, for example. But, I think in the morning talk he explained, when I was in NCI, one sequence costed $100 million in 2000. Now, in India, we get for $1,000. Recently, Anil Ambani said, I'll do it for 12,500 rupees for whole genome sequence. So, I think Dr. Scaria is right. As we go down, I think it will be more cheaper and cheaper. And this will be practical in our part of the world too. So it is not that anxiety was there, 7 years ago when I come to India, they said, "Arey yaar, koi karne wala nahi hai, SNP nobody will do, or EGFR mutation nobody will do." So over the time, things have changed. I think and again, the technologies are numerous. You want a whole genome sequencing, exome sequencing, NGS. Yeah, these are only for 3 years. Now we have a very small, like a matchbox, like a, you like a cell phone, you may get it tomorrow, the sequencing machines. So what I saw in the around 800 square feet sequencing in NCI when they did the first genome sequencing. So, but today you can, get all these machines. I think you are all, well aware of these things. Now, this is my personal thoughts, was in there. So most of these FDA approved drugs, what we are using in India, I'm also in the chairman of the PTC in the hospital formulary. That is why I put up these slides. So majority of these drugs have not done trial in our population. There are nearly 3,000 drugs, actually maybe 1,500 drugs, but we have a lot of irrational combination in our country. 2 or 3 drugs they add without any reason. But before 2018, we didn't have much of the clinical trial. Now I think slowly they are coming into, that is where we got a 2019 CDSO. There is a new drug trial act in India. Now they mandate if you have to sell the drug in India, any new drug, you have to do a clinical trial in our population. So that is the one, new act has come. So though it is a late, but it's a very good decision by the CDSO. Now, why this is important? Is there a difference in the drug response? Of course, yes, because if you see in the West, most of the diet, lifestyle, environment is different than in our country. What they do, they drink beer, they eat burgers, they, play basketball. They have 4 different, US, you have a winter, autumn, summer, all those things. But in India, we had just now, whatever the food I'm explaining, the morning I had actually. And we have a monsoon and summer is all we play cricket. And then, small villages, we do all these activities. So there is a little bit difference on the lifestyle and environment. But one thing we never, kept up with the genetic makeup. Does this affect? Yes, of course. Because what we eat, that is why, you know, when if you eat a very good food, you'll have a good day. You take my words. If you don't take a good food, if you have a good diet, I think you'll have a, you know, very bad day. I'll tell you. This is even in my case also. So that is why you may have a different drug response, drug PK and PD. So this is the, you know, very important in the Indian context. To that, explain to that, you know, this is the one, the two of the studies done in the two different part of the world for the colorectal cancer. On the left-hand side, it is an US population cancer patients, but, you know, we had a lesser sample in India, but in the case of left side, you had a more than 1,000 sample they screened. If you look at the genes which you are expressing in their population, in our population, this is one study, and we don't have a robust study in this country to explain the cancer genome yet. I think there are a lot of efforts are doing now, but still we don't have, you know, very good science yet. But if you look at oncogene, you know, PIK3CA is a major gene in the US population. If you look at tumor suppressor gene, it's a P53. But you come to our patient, you don't have those genes. For example, we have FGFR3 is the predominant oncogene. If you look at tumor suppressor, you'll have MLL3 or maybe ARID1A mutation. So what I'm trying to say, genetic mutation they have need not we have. And some of them are, most of them we have, but in this particular study, we have seen this part. Then, you know, you can go to the database now. A lot of databases are publishing, you know, genetic mutation or gene sequencing or overexpression, etc. For example, this is the ICGCD database. So if you see in the left-hand side, India, so the predominant mutation we have is the P53, and then you know, Cas8, if you see on the first left-hand side bar graph. And in the US, you know, you have a P53. But when you go to China, you don't find that. You know, those green color, you don't find in the Chinese population. P53 mutation is very lesser extent. And again, in Saudi Arabia, you have a BRAF mutation, very predominant. But India, we don't have. Maybe in US and China, we have. So these are all, again, you know, as I told you, this is not, may not be related to exactly what I'm talking, because as I mentioned, there are a lot of molecular subtypes, molecular tumor histologies. So there is a lot of confounding factors here. But if you look at in these databases, how do you, you know, treat a patient? So that is why it is very important to understand our own patients in the pan India, to understand, you know, many people tell that go global. I think go local is the right word for the precision medicine. If you want to practice here, you see what is the genetic mutation in our population. In a Bhopal cancer patient, what we'll be having compared to Manipal or compared to other people. And these are some of the, you know, work we are doing in our clinic also, non-small lung cancer patient. We are doing two of the things. One is the genetic mutation we want to find in our population. And other thing is, you know, we want to see whether some of the drugs can be given to the patients. For example, gefitinib is a tyrosine kinase inhibitor. So we want to see pharmacogenomic profiling, you know, in, and again, we have developed a new method to screen EGFR resistant mutation, T79M mutation in the lung cancer patient. And this is where we, you know, we wrote a review and policy paper where if you want to practice precision therapy of the tyrosine kinase inhibitor, ideally, you know, most of the practice is, well, when you give a first line TKIs, for example, gefitinib you want to give, you will say that, okay, he has a, you stage, you know, you do all kind of a pathological and surgical, you know, grading. Then you say that, you know, you can give this patient gefitinib. But one thing they usually don't give attention to is whether he is eligible to take or not. As I mentioned, you know, there is a CYP A34 and CYP2D6. These are the two enzymes are very important. These, if the SNPs whichever in these two genes are present, you cannot give the gefitinib because ADRs are very severe. I think many medical oncologists see that, you know, hyperimmune reactions and you have a, you know, GI problems and all those side effects or ADRs we usually see in the clinic. So another take what you want to say here is, you know, tumor heterogeneity is one problem in the tissues. So we are doing now both liquid biopsy, a sample we are taking to evaluate the ctDNA protocols to, you know, EGFR mutation, as well as we were screening that same patient for the PGX, whether that patient is eligible or not. By doing this, you know, you might see maybe at least, you know, 15 to 20% patient in the first place, you cannot give the gefitinib because they are not getting benefited because of the ADRs. They may, because when there is an ADR, we don't care about the therapeutic outcome because that is a more worse than this one. I'll explain in what we have done, some of these research in Manipal. And not only genetic mutation we are focusing, also we are focusing on some of the genes which are overexpressed in the cancers. Particularly, we are looking at some of the epigenetic molecules which are overexpressed in the breast cancer, where we want to see in our patient how it looks like. So this is the project we are doing now. Basically, we are to find this particular KDM5E gene expression in our population. Then can we target with existing drugs? There are a lot of existing drugs. We do, Schrodinger in silico, data where we see that whether this particular drug will target that particular gene or not. Based upon that, we will, choose the existing drug and if there is any benefit to the patients. Basically, this study we are doing in the preclinical. And this I'm showing, this is, as I mentioned, I'm go local. So we want to see, there are a lot of genes which have characterized in the literature to that some of these genes are overexpressed or the mutated in the other part of the world. So we wanted to test in our population, particularly in the oral squamous cell carcinoma. The reason I put up this one because if you look at our patients in Manipal, they smoke cigarette, they smoke BD, they chew the tobacco, they eat with betel nut, and these all very important in the changing in the gene expression. I think many geneticians definitely believe in that. What kind of a harmful substances we have taken. So I'm just putting up one of the gene which we do see that there is a change in the expression in our patient, and many other genes we screened which is important in the other part of the world, but it is not important in our patients. And this is another paper where we have an oral metronomic therapy for the COX-2 inhibitor, that is the celecoxib trial. In that, this is the one gene we are screening to the patient. But many patients don't have this, the overexpression of the TTGS2. If you don't have that, there is no meaning of this giving that drug. And ideally, what we do, you think that you give this drug, it will be beneficial to them. I think it may not be. But that is what the precision oncology protocol is supposed to look like. And this is another new gene we are trying. The first time we are talking about this particular gene is overexpressed in the cervical cancer in Indian patients. There is no literature in the other part of the world. So we are still working on the characterizing this particular gene, how it is overexpressed in this particular cancer. Now, having said that, this is a quite common question everybody will ask. Okay, there are multiple mutations in the tumor. How do you target? This is a very, very difficult question to answer to anyone. But what we try to now, I think immunotherapy protocols based on the mutational burden, they may target hundreds of mutation when you give the immunotherapy, but still success is very low, around 11 to 15%. And there is another question: is synthetic lethality mutation. One mutation will drive the expression of other oncogenes. All these issues are there. So this study, if you see in the lung, they took the pieces of different parts of the lung and they screened for the gene expression. Only I think they said one of the gene was overexpressed in the different part, but every part you have a different genes. Now how do you target this? So that is why there are a lot of opportunity to understand this intratumoral heterogeneity in the cancer patient. Now these are I think you keep hearing from last 2 days, what are the different TGF, genetic mutation, etc. So this is my, another, very important question. I think morning, some of the speakers were talking about the drug-drug interaction, etc. So one of the major problem what we have in India, this is an Indian study, meta-analysis study. Polypharmacy, hyperpolypharmacy, and inappropriate medication use. So polypharmacy means you have 5 to 9 drugs. Hyperpolypharmacy is the 10 drugs, more than 10 drugs. Inappropriate medication use means geriatric patients, some of the drugs you cannot give. There is the protocols are there. Now, if you look at the number, polypharmacy is 49%, and hyperpolypharmacy is 31%, and around 80% of the people getting more than 5 drugs. Now, in the cancer treatment, this is the biggest challenge. You all know that along with the cancer, you may be having other comorbidities, maybe cancer-driven comorbidities or pre-existing comorbidities, or maybe by unknown reason they will having lots of comorbidities. So this is the biggest challenge what we face now in the many of our cancer patients. The reason is when we get, I think average, I do see 15 to 20 drugs average for one oncology patient. Now that is where the whole issue they were talking in the morning, are those drugs really needed? There is one of the question you need to really ask, if you are a clinical oncologist, when you want to give a drug therapy, you have to keep this thing in mind. That is why we did a study in our tertiary care hospital. What we do see is, this is basically, we have just checked a retrospective study, how many of them are taking anti-cancer drugs for the lung cancer. So what is the interesting data you see, these are all the drug interaction based on the weak, moderate, and high drug interaction. 83 of the patients of 196 had a severe drug interactions. They don't get any benefit. And we do have some of them contraindicators. Why? Because of they're all CYP3A4 inducer. So now you give one drug inducer, you give another drug inducer, the problem, inhibitor also problem. This is one of the challenges we have. So they may not be getting any benefit. We publish this data, and that is why these are the polypharmacy is the most risk factor for what I believe that polypharmacy or drug-drug interaction is the majority of the drug failure problem in the cancer patient, and all other things anyway. So that is why we have a now oncopharmacist where they will suggest what all the different drug therapy should be given. They'll prepare the chart for the oncologist so that you can treat the patient better. And now this is the other things, morning, people were talking drug herb interaction. We got a AIIMS funded project. The reason is why we started this project is we had clinicians, we wanted to, understand some of the drugs which is used, the CDK inhibitors in the practice, palbociclib and ribociclib. Clinicians said we don't use anymore. They said that it is very, very toxic, very difficult, no good outcome. Then we went back and we did all the literature and research, and we wrote a AIIMS grant on what are the different problems in the bench level. So remember that precision oncology is not only clinical level. If there is a problem, you go back to bench and see what is happening. So there are a lot of a lot of dietary components are there. So we did in silico Schrodinger, which is the study where it will tell what all the difference a drug can bind and remove the drug from the binding site wherever the drug is supposed to bind in the protein. So we did that, and we found two of them are curcumin and quercetin. So what these two dietary components do is they displace the CDK inhibitors from the CYP3A4 substrate binding domain. So CYP3A4 required for the CDK inhibitors. So when they replace, what happens? These drugs accumulate in the body and causes the toxicity. So that is what 6.4 fold they were this curcumin and quercetin prolong the in vitro half-life of CDK inhibitor. So when they stay more in the body, it is more toxic. And we have published most of these published in the peer-reviewed journal. And other drug interaction, we are talking about drug is only drug gene interaction, drug disease interaction, drug food interactions, drug lifestyle interaction, drug microbiome interaction, drug geriatric, all those interactions are very important. But as I always tell that when you give these anti-cancer drugs, you don't expect that they are going to get a cure or something. That all we know that very well. So one of the most important we do see the quality of life of the patient, particularly in terms of physical well-being, psychological well-being, social well-being, and spiritual well-being. This is as yesterday a speaker mentioned that it is a more nurturing the patient by the oncologist. When they come, you need that kind of a more nurturing the patient to understand all these things. So these are all different problems we face, but some of them definitely we can avoid. Some of them we need to do more research. Unless we do research in our patient, we may not able to understand and do the better. So that is why the whole cancer drug trial has been now changed in a very different way these days. This is the you can check in the FDA website. First one is a basket trial where you have multiple cancer types, and you have to screen the single biomarker and only one possible drug which you can use as a biomarker for that particular patient. And in the case of umbrella trial, it's other way around. You have a single cancer type and screen the multiple biomarkers and take the multiple possible drugs, and you can, you can give the one of the those drugs to the patient. So what are the implication of this precision medicine in the onco clinics? I think shifting the emphasis to medicine from reaction to prevention, I think that is the one, some of these things you can prevent in the first place. As in the morning, PGX people also, they were talking about pharmacogenomics, and if you know screen very well, I think you can prevent that one. Targeted therapy and reducing the trial and error prescribing. You all know that, that you are aiming for therapeutic outcome as well as less ADR. That is a big challenge in the cancer clinic. So you can't, do trial and error, and also the, other the targeted therapy drugs are available. You can treat with that, and reducing ADRs, and the many drugs, many cancer drugs, ADRs are very significant, and one of them, nausea and vomiting is the biggest one. With the most of the drugs, I think more than 95% of the drugs does that. And increase the patient adherence to treatment. I think clinicians will definitely tell that many people, they don't come back, whether any type of the treatment, even immunotherapy or radiation or the drugs, if they don't come back or they don't adhere to the treatment. And finally, in like India country, helping to control the overall cost of the healthcare. This is the big problem in our country, because in US, more than 90% people are covered with insurance, but in India we don't have that system. So that is why these precision medicine may be, though practiced in the other part of the world, more appropriate to our country than any other country. This is what my personal way of thinking. So this is how the precision oncology team model will be. So initially, patient will be diagnosed with cancer. The patient will consult with the oncologist and then obtain the consent. Then they'll go to tumor board. So here, what I want to say, different members you need. Tumor board is just, it is not about only clinicians. All other, every component should be there. Who will break the news to a patient? Ideally, in our culture, we usually, clinicians will tell but in the US, social worker, he will take them separately. There is a lot of protocols are there to tell them that they have a cancer. They don't tell directly that you have a cancer. This is what we practiced in the, in the tumor board in the US. And then, this is basically, I want to emphasize Dr. Biswas on the molecular tumor board, how we do that there. Then you screen for the, whatever the mutation you want to by next gen, and PGX and TDM, everything, then you have that screening. Then you go back to molecular tumor board. There, that is a depend upon who wants to be there. That is the tumor board, you will have a chair for that. They will decide, and they all will come together. Then you go back to the patient and treat. This is how the importance of the molecular tumor board. So I just want to detour another, precision medicine we did in the tuberculosis. So this is basically, here again, we are targeting the tumor and the host. Here we are targeting the pathogen and the host. The reason is, drug resistance is the big problem with the tuberculosis patient. And again, the host, as I mentioned, NAT2 gene, which is metabolizing the INH. And if there is a poor metabolizer are there, very difficult to treat those patients because they will have a different ADRs. So this is the, what we did first was, we recruited around 400 patients for the whole genome sequencing. So this is the patient data. This is basically funded by NIH, and we jointly wrote this paper, where we found, several high, intermediate, and low level resistance to first and second line ATT drugs. And when you give these drugs, you need to know this mutation profiling. So in INH, we have around 78% with the CADG mutation and 15% with INHA mutation. So that's very important to know, because there is no drugs available for INHA. CADG, you can increase or decrease INH drug dosing, but you can't do anything with INHA. There is no drugs. That means approximately nearly 15 to 20% patients not eligible to take INH in the first place. Despite that, when you go to a patient, go to a clinic, they will give this drug, combo pack, but they may not be getting any benefit because of the resistance. And another thing we did was NAT2 allelic frequency in this around 455 patients. This is the collaboration with the AIIMS Jodhpur and Manipal Center. around 455 patients we screened. What we see is, if you're in the left-hand side, we have compared this allelic frequency with the global data. So we have a all of us data agreement with NIH. What we found was there is a differential, the SNPs, these are the SNPs, and there is allelic frequency. What we do see in the geographically, if you look at the SNPs, every part of the world you have a different SNPs are. But we take that as a model. Like for example, WHO tell that, okay, you take this drug, you do this, you do that, all those guidelines they'll give. But they don't think of these, thing where, if you see in the East Asian, the list is very low. These are the 6 SNPs for the NATO enzyme. And if there are 3 of them are significant SNPs are there, they will, lead to the drug-induced liver injury, pancreatitis, psychosis, so many areas are there. So even in our patients also we found, around 42 DILI patients out of 250. So it's a very significant, and those people will stay longer. Hospitalization days increased to 2.5 times more because of the drug-induced liver injury. And they have to spend more money, and most of the TB patients are poor in our setup. They are very poor, unlike, I should not say in the cancer, it doesn't discriminate poor or rich. But in the case of TB patients, and then, this we also compared to the global data, all of us data around, we got 245,000 patient data. And there is a lot of similarities in the SNP data. So what I'm trying to say here is, now actually what we have asked ICMR, this is again ICMR funded grant. So we did a time series curve. So you need to screen these 3 SNPs in the patient when they come to the hospital in the first place. So they'll get benefited at least. If they are not there, it is fine. But if it is there and you take the drugs for a long time, they have to get a hospitalization. So that is what, ALT, LFT also you have to do. ALT and AST is very significant. And these are the 3 SNPs we are recommending ICMR to when you give these ATT drugs, and please take care of, these 3 genes to screen. And this is the future of medicine. What we are today is average patient giving a standard treatment, and you have no benefit and adverse effects, and you might improve outcome and reduce side effects. Remember, these are the 2 treatment benefit as well as ADR. Many a time we don't much think about ADR, and now they say majority of these, even mortality papers are there associated with the drug-drug interaction rather than the disease. So these are, this is my major, talk where I am going to emphasize that if you want to practice in the clinic, I think you have to do some kind of a research in your local setup. Is it feasible to do, practice? Now we are writing a non-randomized trial for the both projects where we want to take one arm taking the standard of care, in the other arm we are going to do the intervention. So what benefit will give to the patient? So this is about, my talk, and I think this you can see now around 594 drugs in precision medicine by US FDA data. If you go to that website, you can get out all the drugs are there. And Mayo Clinic, nearly 900 drugs they have listed. For example, now you all know that, you have a small leaflets in the drug box, but now they have added these mandatory. So like you have a pharmacology indication, side effect. Now what they are doing is pharmacogenomic labeling. For example, here you have a gefetinib. They say it is only for the EGFR mutant patient. They cannot give non-EGFR patient. And then they say if you are giving the gefetinib, you need to check for the CYP2D6 genetic mutation, because they are the 4 metabolizer. You get all the areas. It's a mandatory now. And also recently, US government reimbursing through the Medicare, and it was for longer time. They were doing most of them research, because they didn't want to pay, Medicare didn't want to pay to the patient. But now Medicare is paying, and I know there is a now billing code also, new billing code has been added so that patients get benefit. So that's about my talk. I think some couple of things, if you're all interested to pursue precision, there are a lot of grants are available. This is particularly one grant, where you can do a biobank. As I mentioned, sir, this morning, and this is the most important if you want to do any precision medicine. This is not only one area in the cancer, in general, infectious disease or maybe rheumatology, any department. I think this is the main thing you have to start, so that for this, you have to start biobank by yourself. Over the years, NCI is ready to fund. So there is a guy, he has nothing to do, that Rav is nothing to do with me. I don't know who is that Abhirav. I'm just telling that. But I know Dr. Lokesh Agarwal, he had come to India and he went to many institutes. They will fund some of the, research project if you have a very good biobank system. And these are the another, medical oncologists particularly interested to go for a precision oncology training in UK. So we have a network, someone is interested, all the, senior resident or PGs. If you want to go UK, they will train you how to practice this, trials or the oncology trial particularly. And there is a lot of, again, these are again to the clinicians, a lot of clinicians will get a, fellowship from the different part of the world. So if you are interested, you can go. And these are the other three places, some of our people, we have, those who are interested, we have asked them to apply. And one other thing, in 2020, I think the keynote speaker for this CME, Dr. Vivek Randekar, gave a talk another day. So I just want to put up more stuff into that. So I'm the co-founder, and Dr. Vivek and myself, and also Dr. Prasanna from Tata, and from Mayo Clinic, Dr. Mukhopadhyay, and 5 people, we have started this consortium. This is basically to give a educate, research and outreach program, and collaboration, grant, fellowships, network. So you can go through that website. And if you see on the left-hand side, we conduct the conference. Last year we conducted in the Brazil, and previous year we conducted in the Tata Memorial Hospital. I think Dr. Gupta is here, and we have done a very good conference there to interact with the different scientists from the different part of the world. And 5th one we are doing in the Amity University. If you are all interested, please come by there. And we have a precision immunotherapy. We have a precision oncology and immunotherapy. Some of the people are interested to understand that. You can, come there. And other 2 precision oncology related workshops we'll do. One of them is the precision medicine series. Dr. Sridhar Ganeshan is a clinician, physician scientist, and he is much interested to, I think, help Bhopal also. Other day I spoke to him. So we all can have a very good interaction. And there is a series is coming up, so you can, all of you, if you are interested, you can do that. And Dr. Surya Varamalli is a pathologist. His entire biobank is under him in the University of Alabama and Michigan. And some of them you are interested to go there, will help you to get the training over there. And these are all my team, within India and other parts of the world. And I think a lot of people who help to develop these programs in Manipal. It's not only my effort, and I think everyone is important for me. And thank you very much. And if any questions, I'm happy to. Or we can have after Gupta's talk. That's the way.
Any questions?
Yeah. Thank you.
Thank you, sir, for this excellent talk, putting the entire session into perspective. And actually, what is evident is that since 1895, when X-rays were discovered and nitrogen mustard has discovered, cancer treatment has evolved beyond a simple one-for-all treatment to a very highly specialized and highly personalized and therapy. And I think all the students and the people who are involved in the cancer treatment, whether it is diagnostician or in therapy, they need to be aware of this changing landscape. So to put these discussions forward, our next speaker is Professor Sanjay Gupta. Professor Gupta is the translational research, professor of translational research in epigenetics and chromatin biology lab group of Cancer Research Institute at TREC, Tata Memorial Hospital, Mumbai. Dr. Gupta actually specializes in the field of epigenetics, and following PhD, he had a short stint as a visiting research associate in Institute of Life Sciences, Bhubaneswar, followed by postdoctoral and DST Young Scientist Fellowship. He joined the Cancer Research Institute of Tata Memorial Center in 1999. He made significant contribution in the field of epigenetics, especially in cancer pathogenesis, resistance, cell cycle specific DNA repair mechanisms. And he is editor of many journals involved in the field of translational cancer research. His group exploits these epigenetic changes for biomarker development. And I think, as has been said in the previous, by the previous speaker, the biomarkers are very important for early diagnosis of the cancer. So it is my pleasure to invite Professor Gupta to deliver his talk on epigenetics potential, diagnostic applications in determining cancer patients' prognosis and predicting their response to treatment. Welcome, sir.
Thank you for Dr. Biswas, for your invitation here and sharing what we are almost doing. What I will be part today, I will be sharing is almost a work done by almost around 6 to 7 students in the last 15 years. I think Dr. Mahadev was one slide. If we have to think personalized medicine in 2030, what I will bring to your notice, we have reached that goal and we are in the phase 1 trial with some personalized medicine in the future. Drugs can be taken. Today, what I will be talking majorly about the emerging epigenomic landscape of gastrointestinal cancer. I'm not going to emphasize much on liver cancer, which we have worked a lot. Major emphasis will be on the gastric cancer today, biology, what we understood in depth, and then how we can utilize those biological knowledge into the clinical implication in the period of epigenomics. That's what I will be covering today. And because the field of epigenetics is basically we all talk about genome. We always say genotype defines our phenomenon. That's so simple phenomenon. So then if it is such a simple phenomenon, then why two monozygotic twins which generate from a single zygote are not similar in nature after 6 months of their birth? If the genome is dictating everything to be similar, then they should also be similar, but that doesn't hold true. And why it comes out to be. We talk about genomes of life. There are different phenomena involved into it. We talk about, if you look at the banners where the goals are put, if you look into the first is the DNA sequence, then comes the epigenetic and the gene regulatory mechanism, then comes your transcriptome, then computational remodeling, then comes metabolomics. So it's a multitude of phenomena which work together to give you something as a protein expression profile. So the genome of life we talk about is a multi-omics. Defining at a single part is not a similar, is not a right thing to approach it. The other concept which has come out, this is the Times magazine cover, which says why your DNA is not your destiny. Actually it says you can decide your own destiny, what you are. And what you take, what you eat. And the new concept has emerged in the last few years is called the exposome concept. Dr. Mahadev has nicely talked about it, touched upon. And we say about exposomes concept, these all factors which I'm talking about, like ecosystem, lifestyle, social, physiochemical, these everything affects us. Our own, the thing which we never consider is the social factors. A lot of diseases are associated with your household income, inequality within the families, within the religion, caste, everything, social capital, social network, cultural events, which we are slowly not want to do it or to other factors. And then you come into physiochemicals. So why your DNA is not destiny? Because the exposomes comes and interacts with the gene. Then only it decide what you are going to really do. And that's what happens when you talk about different internal exposures or environmental exposures. They affect the complete epigenome. They change the epigenome, and the major phenomena which works is the methylation of DNA. you talk about histone modification and non-coding RNAs. The things which has emerged now is not only the methylation of DNA, now we are also looking into the methylation of RNA, which decides how the different kinds of alternative splicing, the mRNA turnover can be dictated just by RNA methylation at the adenine residues. And that's what completely regulates your gene expression. By changing the epigenome, it can be either upregulated or downregulated, which is not seen in a normal scenario, and that can lead to different kinds of diseases. Here I am giving an example how a normal cell gets converted into a tumor cell. So what we are talking about? At genomics, we talk about the DNA, which is unlocked the information, is the unlocked DNA. Then we talk of an environment which determines the interaction with the unlocked DNA. And these two factors together will help us in deciding what will be your functional DNA. This is the DNA which will dictate how your transcriptome will be made. And this what is talks about the gene expression. Gene expression will talk about the proteins, and then comes finally the metabolites. So all these together will dictate how your cell is going to function at a physiological level. It is not the unlock or the naked DNA which will dictate how your cell is going to function. And therefore, in last year, 2022, the epigenetics, basically if you look for the non-mutational epigenetic reprogramming has been categorized as one of the key hallmarks of cancer. Because when we talk about different phenomena which helps in cell survival, resistance mechanisms is not because of the mutation, but because of the change in the gene expression which regulates different mechanisms. We talk about change in the metabolic pathways that also is happening because of a change in the epigenetic programming of all the metabolic genes. And if you look for, there are hundreds of steps of the phenomena which are altered at the DNA methylation level, RNA methylation, histone methylation, histone acetylation, and all these phenomena completely changes your epigenome and completely regulates the function of the cell. Today I will be just emphasizing on one of the key aspects which we have worked in few years is about histone modifications. We all know this DNA bonds with DNA being a phosphate backbone has a negative charge on them. And these histones are rich in basic amino acids like lysine and arginine. So they pair out tightly and always form a highly repressive chromatin which looks like this. So this is a structure which is formed because of the presence of the histone proteins. And if such structure is formed, this what we always refer as a repressive, and it cannot make RNA. And if a cell has to make RNA, the structure has to change to an open organization. And this phenomena to change from this is a highly regulated phenomena, regulated by different kinds of enzymes and mechanisms. And some of these histone modifications, the green stars are represent the active ones, and the red one shows that these levels have decreased. So you can see these have been defined now histone modifications as histone onco-modifications. I think I'm audible in the last also. So that will be better for me. So that's what we define them as a histone modification. And they have been associated with different functions. They associate with aberrant gene expression. So they associate with different gene expression, genomic instability, DNA repair, and cell cycle checkpoints. So these regulate the complete cellular phenomena, what is happening. So what I'm going to share is almost published. 90% of the work done by so many research scholars. Two are carrying forward the work on this project, is the Flavia and the Parol. Others are published and move ahead to different positions abroad and taking the permanent positions in NIH also. This was actually shown by Dr. Mahadev, how the cancer develops. We talked about initiation, promotion, and progression, a basic carcinogenesis model, which we always tend to forget with the advent of new technologies, which is emerging day by day. We talk of omics, we talk of genomics. But the basic phenomena is initiation, promotion, and progression. So if you see a normal cell, we all know they go under metaplasia, dysplasia, hypertrophy, hypertension. And these are quite reversible phenomena. You give a drug, patient comes back to a normal state and nothing happens. But generally irreversible if chronic irritant persists. If you are irritating your GI continuously, they may result into developing a lupus. They are what you are dictating what you want to do. And these phenomena, when you have a chronic irritants completely in your body, or you have a stress at a mental level, that increases cortisol. You all are the clinicians, I'm the basic scientist, but you know it increases the levels of cortisol. And if the cortisol increases, it affects the cell proliferation, and it causes faster cell proliferation will result into altering a G2 phase of a cell cycle. Errors are included, causing a further mutation and developing a cancer. So early phenomena or the early events, if you really want to target, is the epigenetic phenomenon. Just emphasizing, I think this audience, I'm not to introduce this. We say 5 to 10% of the genes associates with the cancer development. 90 to 95% are environmental factors. This is a very well-known fact. And if you look at the environmental factors, Helicobacter pylori, smoking, alcohol, salt intake, family history, vitamin C and nitrosamines. And the problem in the Indian context, if you look for the routine intake of Gelusil, Pandy and other medications, results in delay in presentation to the clinic. And therefore, your disease has generally, when it comes to TMH, at a Memorial Hospital, it is in T2 or ahead of. That causes poor surgery, post-surgery, 5-year survival, high local regional recurrence. That's a major concern in the GI tract. I will show you some data which has been translated at a clinical level about the local recurrence rate, which has significantly decreased in the last 6 to 7 years at TMH. High relapse rate and poor response to treatment. And all this together is linked to poor prognosis. So what we started to do, if you look for this, is a mechanism which has been recently published in Trends in Cancer. How it happens? The genome may have a mutation. We know about APC, we talked about today in the morning, BRCA1 and others. But every individual don't suffer with a disease. We may have a hepatitis B virus infection, but we may not suffer with the liver cancer. So that what the genetic alteration is already there. So what you need is a epigenetic priming of your cell under different stresses. So that priming results into further secondary mutations leading towards cancer. If you have a genetically acquired mutation within your body, or you may have a susceptible, we talked about SNPs and other factors, you have a susceptible error in your genome. Until there is a priming or the environmental factors, you will not acquire mutations. So that's where the role of a dietary factors. If you talk of an APC mutation in colon, if you are having a good fibrous diet, but not having a lot of red meat, if you know about the mutation, you can prevent the occurring of the big polyps. You may have a small polyps, but that polyps will not convert into a cancer. So knowing mutations are very, very important when it is genetically linked. So you can modulate what the Vinod was also talking about in the model. You can modulate your dietary habits and can prevent occurring of a disease. First, you may not have any mutation within your DNA, no sequence change, but the persistent environmental factors cause it to be. The best known example, the roadside chicken, and the roasted chicken given in a 5-star or the good hotels. In a good hotels, if you look for a chicken or any kind of a non-veg is served with onion, cabbage, carrot, and a lemon. On a roadside dhaba, he will give you only a roasted chicken, which is brown or black in color. Why they serve with all these green vegetables? Because what this blackening does to a chicken, to the youngsters, is rich in nitrosamines. And these nitrosamines produces nitrites and the nitrates, which causes a disease. Generation of lot of free radicals in your body and the mutations in at all the macromolecular levels. But when you are having carrot, onion, lemon, these are antioxidants. So whatever the ROS is generated in your body is immediately scavenged by these green leafy vegetables, and you have protected yourself. So it is not for the showcasing in the good hotels they serve with these vegetables. They serve with a purpose behind it, which we don't know today. But if you go to the old generation, whatever grandmothers, they are aware of these facts. So if you look for at the Tata Hospital, what we generally all the tumors are surgically removed. Cutting upper is the proximal, which is towards the esophagus, which is towards the duodenum, is a distal resection. And what the advantage of PMH is, we exactly know how far from the tumor there is a proximal or the surgical resection margin is there. They know in centimeters. So if you look for what we did profiling of lot of histone modification on two histones, H3 and H4, which are known to undergo different mutations, different post-translational modification. And what we realized, RM is a resection margin. We found there is acetylation. The first one is acetylation. There is a significant decrease in the level of global histone acetylation. The second one is a methylation, which doesn't change significantly. However, there is significant increase in the phosphorylation mark, H3-serine and H3K27. There are significant increases happening. So we asked the question, this is a nice observation. Let's look into what's the clinical significance. So what we looked into, these are the already I talked about histone onco modification. We compared by Western, we find an outcome. We did IHC, compared with an S-score. We find yes, this is happening, what we have observed earlier by Westerns. And then we look at the S-score, we find in tumor versus proximal, there's a significant, if you see in PRM and DRM, the ethicity and phosphorylation is pretty less. In the tumor, it is pretty high. So when we started going back to the clinics and looking into the clinical data, what we found out, it is closely related with the disease like WHO classification, tumor staging, as well as the TNM staging and the recurrence. So higher levels of ethicity likely correlated very well with all the parameters which are clinically relevant. We look into the survival benefit, overall or disease-free survival. If you are doing it without the ethicity and phosphor levels, they don't classify so nicely. As soon as you bring ethicity into picture, the low levels have a very good survival. Either you talk about proximal resection margin or you talk about distal resection margin in context of overall as well as the disease-free survival. So a significant negative correlation of ethnicity and phosphorylation levels in the tumor with OS and DFS. Being a basic scientist, always we look into fundamental mechanisms. What we came out with a mechanism, I will not go into the depth of it. Cell cycle independent increase of ethnicity and phosphorylation is mediated through P38 MAP kinase MSK pathway in gastric cancer that we worked on, so that we can use inhibitors and look how we can be utilizing it. Coming to the question, if you look, we have seen very nice correlation between the proximal resection margin, low level of ethicity, high in the tumor. Local recurrence is very high. So why, despite of a histopathologically confirmed R0 resection, rate of local recurrence in gastric cancer is high? That was the question one. It was an R0 resection by the histopathologist. So this is what the concept of field cancerization is. If you look for, if you look into the figure, you have a malignant tumor, histologically recognizable pre-malignant lesion, then you have a normal appearing field. Generally, the surgeons cut from it. And then you have a normal region. So that's what is the concept behind, and how the resection happens has been shown on the other side. What we did, I told you we have a data in centimeters to look into. We looked into the patients who are 0 to 5, 1, 1 to 2, till 14 centimeter. We looked into the levels of ethicity and phosphorylation and the site of proximal resection margin. And what we came out nicely, if the proximal resection margin is greater than 4 centimeter, the levels of CD10 is very low or comparable to the normal, but if it is less than 4, it is almost like Q. That's what we clearly observed at proximal as well as distal resection margin. At the time, if the GI doctors get the region 4 centimeter to cut, because if it is towards not a proximal region, you have a esophageal sphincter, and below you have a distal duodenum sphincter. You can't go below that. So if you see there's an in between in the basal body, they cut immediately from 4 centimeter. So this is what is happening at PMH now regularly. And when we look into the resection margin distance and prognostic, you will appreciate the low has a better survival. Again, what I have shown in classification earlier. Same with the distal. I'm not going to the depth and details of it. So what we came out from this story, I'm taking another story, P38 MAP kinase MSK pathway mediated high levels of ethicillin and phosphoid gastric cancer lead to poor prognosis. In resection margins, distant dependent levels of ethicillin and phosphorylation can help in deciding the true negative resections and indicate the involvement of histone PTMs in epigenetic field cancer. Other story I told you, if you look back, this was a figure I showed you, which is shown on the last side of that. Low level of histone acetylation. What we observed is a global hyperacetylation of histone with condensed chromatin in gastric cancer. We looked into IHC, we looked into an mRNA levels, and this what the key is. You all will agree, we all look for the data at RNA and protein levels. But when you talk about in enzymes, because histone modifications are done by histone acetyltransferase and histone deacetylase. These are enzymes. So enzyme levels are important. The transcription is important, but the more important is the activity of an enzyme. Whether really that enzyme is active to do the process. We did an activity assay and we found out the HDAC activity, histone deacetylase, which removes the acetyl group from the thing and converts into a highly condensed format. That's what you observe. And the HAT levels histone acetyltransferase activity almost remains. So what is happening between normal tissue samples versus the tumor tissue samples, the chromatin, not the DNA, the chromatin is getting condensed in the tumor samples. And if the chromatin is condensed, we looked at the other transcriptome and we looked into the, see if you look at the enzymes of different HDAC classes. There are 4 classes, I'm not included the search here. HDAC 1, 2, and 3, and 8, which is class 1 HDACs, are really important for histone deacetylation. So what they do, if an acetyl group is added, histone will become negative charge, so it will repel from the DNA and the DNA gets over. But if acetyl group is removed, again it will get condensed. And when you look into 2, 8, and 1 are significantly upregulated at the transcript levels also. Moreover, they correlate nicely with the survival also. We looked into, wanted to see what is happening. This is a TCJ data. Wanted to see what is happening in the context of metastasis and node positivity. We could not find any significant correlation. You see, the red one is the normal one, the cut margin. The yellow is the N0 positive. After N0, when the number increases for the nodes positivity, there's no significant changes happening. So the normal versus the N0 is a significant increase. Is observed in the levels of HDACs. So what we observe is what's happening. In a normal cell, balanced HAT and HDAC activity results in regulated gene expressions. It is nicely maintained acetylation and this. What we observed is an increased HDAC activity in the tumor cells, leading to imbalance in both the enzymes, favoring the highly condensed format. So what is happening from normal to tumor, this chromatin is observed. And this chromatin is transcriptionally inactive, that also we proved in the tumor sample. The amount of RNA synthesized in the tumor samples are less in comparison to the normal samples. We proved it by experiments called non-transcription. So this was the one story we showed chromatin is getting condensed about histone PT. There's another aspect, another student was working on the lab. If there are three types of histone H3, I was talking of all the modifications in context of H3, but there are three types of H3 in our genome. So if you look for H3, we have more than 10 different histones H3 in our human body. If you look into the yeast, we have one. So if from the origin, if you see the multicellular organism has become more amount of histone genes are. In yeast, there are only 5, but in humans, there are 52 genes. And when the number have increased exponentially with the evolution and the multicellularity of the organisms, it has some function to play, which we don't know today. Only today, the Nature paper has come, which talks about, just today in the Nature, I have a copy of that, how histone variants can contribute to altered nucleosomal organization and altered gene expression variants in cancer cells. So what it does, basically wherever H3.3 comes, it leads to the transcription of it. When 3.2 sits into, it inactivates the gene expression. And when it is 3.1, it is basically present in the genes which are called as present on the coil formula, which are always ready to express this. So we wanted to look into that. What is happening? So what we have shown and published, in a normal epithelia, it's a nicely open chromatin with low levels of H3.2, and this 3.2 slowly increases in the primary tumors. Histone H3.3 is high in the normal epithelium and it increases in the primary. These are some other factors which are required for the transportation of these histone to the chromatin, which are called histone channels. Moving ahead, our interest was revolving what is happening in metastasis. We were quite surprised with this data. What is happening in tumor is not observed in the metastasis. It is the reverse phenomenon. Again, 3.2 decreases, chromatin opens up, and 3.2 increases, suggesting the normal epithelia is more similar to the metastasis. And the tumor is totally different. And if we are going to target the metastatic tumors with the same drug, they are not going to function because their expression profiles in a different tissue is totally different. That's what we discovered. Moreover, we wanted to see what is happening in resistance mechanism. We went ahead and these tumors were given cisplatin drug. They develop resistance. And all the genes, what you will appreciate, again, which are expressed, are favoring an open chromatin organization in a resistant population. They also shows the pathway analysis and what observed. I have not gone into the depth of the data. Normal has a 2 point, there is another histone what we were working in depth on that. We have a higher HDAC, higher HAT, and a nice balance in the normals. So the three populations, what we say in cancer or oncology, normal, tumor, and the resistance have a complete different nucleosomal profiles. So their target needs to be different. So now I come back again to the thing what I showed you a little earlier. There is a global hyperacetylation and there's an imbalance happening. So chromatin modifier inhibitors in solid tumors. You will see Vernistat and rhodopsin is FDA approved drugs used in cutaneous T-cell lymphoma, CTCL, but as drug inhibitors in solid tumors have failed. That's what the reviews say. A lot of the journals talked about. There are, if you go to the clinical gov.in, where a lot of clinical trials are reported, it has been utilized in more than 50 clinical trials. But at the end of the day, that study has been told it has failed. But if you read the last 3 lines, epigenetic drugs and HDAC inhibitor in particular might be useful only in those tumors in which HDACs are directly involved in the pathogenesis. That's what the key concept to be. This is the latest clinical trial which is ongoing. This is called as the famous head and neck B-chance trial. And still what the errors are happening, If you look for HDAC1, it is only upregulated in 30 of the patient out of 415. So what HDAC level and the activity, we look at the transcriptome. I talked about transcriptome is not so important. So what this trial is an error, HDAC level and activity, there is no patient stratification happening. Patient with normal and less HDAC activity and toxicity assessment has not been done. Real-time monitoring of the histone modifiers and modification not been done. And when you look for the drug interactions, which interacts with DNA, they never bind within an in vivo context to DNA. They always bind in the context of the chromatin. And if the chromatin in the tumor is highly condensed like this, your binding will be significantly affected. Then this condition. So if your chromatin is highly condensed, the DNA, the drugs will not bind, which intercalates with the DNA. And the drugs you all know about, doxorubicin, epirubicin, cis, oxalote. So all these drugs interact with the DNA at the minor and the major groups. So what the hypothesis we proposed around 4 years before. So chemotherapy interacting drugs, epirubicin, cis, and oxalote. Why not use an HDAC inhibitors, valproic acid? All the clinicians are aware, used as an anti-epilepsy drug. It has not major side effects. People are giving this drug for 30 years without major side effects. Triclostatin A and verminstat is approved. So and whatever the trials have been done, they have been done with a concurrent. We decided 3 different regimes with a concept behind it. And the concept was, if I have a chromatin which is condensed in the tumor samples, the drug binding will be less, and a lot of drugs will remain in a systemic circulation causing higher toxicity. So why not take this condensed chromatin and treat with an HDAC inhibitors pre-treatment? And then you will open the chromatin, and this is acting as basically we thought of a sensitizer. We are giving a dose of IC10. I will show you some data. And then the binding of the drug will efficiently increase, causing a more of a cell. That's what we came out with an hypothesis. We looked into the binding of the drug in an in vitro assay. We treated these with that. You will see the red arrows wherever concurrent 3 and all, wherever the HDACs are given before the DNA binding drugs, the cell kill or the binding of the drugs is significantly. Suggesting if you open the chromatin, your drug binding will increase to the gene. So this is for the drug to tell the pathologists, we did fraction affected to define the best regime because they are a combination of 2 drugs. What we came out, HDAC inhibitor dependent sensitization decreases the dose of chemotherapeutic drug to attain maximum efficacy with pre-treatment. We used IC20 and IC50 of the cisplatin, and we could get a better kill than giving an IC20. We did combination regime to define it is synergistic, additive. All the effects we came out. BPA, the valproic acid, this is the cheap drug. Dr. Madhav was talking about looking at a drug which is cheaper for the Indian continent. BPA is hardly 10 molecules, 10 tablets cost you around 6. It's a damn cheap. Was found to be more synergistic in pre-treatment combination regime with cisplatin and oxygen. So what we did, we treated the cells and we could nicely see increased tumor suppressor gene expression, cell cycle arrest, differentiation in cell death. So the phenomena got reversed, cell death was observed. So this was the opening happening there nicely on the cell. We proved by different mechanisms, different methods. When we do the same experiment in a cell culture, the pre-treatment cisplatin with BPA was the maximum cell death. So this was all the in vitro done study. We went into the preclinical mode. We did a preclinical research here. We really showed, yes, there's a significant decrease in the tumor volume when you are using pre-treatment with valproic acid 24 hours before giving a cisplatin. So the question was always asked by one of the reviewers when we sent this paper out, what is happening to the normal cells? We did some of the experiment and convinced the reviewer. We did all this experiment and convinced the reviewer. But the paper was published. Suppose the hypothesis self-adapts to epigenomic disruption caused by HDAC inhibitors through coordinated chromatin transcriptional response to the normal cells. So this is again epigenetic because the normal cells will prove efficient clearance from the normal cells with the decreased levels of rhodopsin gene expression in the normal. So we could convince by 4 methods. The reviewer got convinced and accepted. But the issue pertained to us. There was no protocol existed to do the live screening of the patient. So the protocol need to be developed. It's taken a lot of time. So now we have a protocol established and published. A novel method for isolation of histones from serum and its implication in therapeutics and prognosis of solid tumors that you could do. And you could show that serum, you can look into chromatin. That gives us a patient stratification approach. So when a patient comes to a clinic, you can measure the levels of histone modification in the blood serum samples. You can measure the activity and can help in patient stratification easily. Then you have a nice concept of epidemic evaluation and further during prognosis also. With just a 1 ml blood, you can monitor whether the levels of the HDAC is changing in the patient. The serum-based detection made us life a little simpler. That's what we came up with the hypothesis. So we proved this all, low HDAC. So all the patients with a high HDAC activity, patients which are suited for combinatorial HDAC inhibitor and DNA interacting chemotherapy drugs. If I throw on the chromatin, it will begin, and this is what we observed, low binding of drug, high toxicity and less cell death. But you have an HDAC IP treatment, you give a chemo, increase binding drug, increase cell death, and less toxicity. So our results establish a strong rationale for exploring the pre-treatment. We went ahead, so this is a take home from here, an increase in the expression I talked about, global hyperpigmentation, and we could not do in solid tumors nicely with patient stratification. So what was the step ahead? So that's what we all ended in somewhere around 22. The patient stratification based on exact inhibitor. Then this translational activity started, taken almost a year to convince the IC that we go ahead with this trial. So we started on that, the project, histone acetylation and HDAC activity in cancer, a proof of principle study for exploring the potential of HDAC therapy in combination with standard chemotherapy. So now we are recruiting the patients, looking into the drug activity assay and see how this thing can be taken ahead further. So I'm just talking here, all the hard work comes from the collaborators at TNC, Dr. Vikas, who is a medical oncologist, Dr. Shraddha Bhatkar, she is a medical GI surgeon, Nitin Shetty, who is an intervention radiologist, Mahesh Goel, again a liver surgeon, Sailesh Rikhande, a GI surgeon, Savio, who has moved to Australia, but a key person in initiating these projects in around 2010. Then we have Mukta, Poonam, who are the pathologists on the projects, and other partners who did a lot of in silico analysis, stem cell population analysis in that. A lot of in silico work I do basically with CDAC Pune because I have zero expertise into it. In silico, I know only to ask questions. But when the question goes to CDAC, they give me a nice answer. And this is a histone database which has been created from the lab, which talks in detail about all the mechanisms of happening in cancer biology. What I believe in, epigenetics is important. It is not an alone function. They have a very important role in cell mechanisms and need to be built in tandem now with things. Because why epigenetics has gone behind, the first HDAC enzyme was discovered in 1980. It is hardly around 26-year-old story. The 26-year-old story, if you combine with the genome, will take time, but you have to move ahead onto the field. With all the pathways, you can answer some mechanism which can be taken to the system. Thank you all for patience. Thank you.
Thank you, sir. It was a very impressive talk. And I think for students and young researchers, it is important to note the benefits of clinical trial in different dimensions, how it is working out. this kind of predictive research actually has different dimensions. So it is very much appreciated, the previous speaker, how he has outlined the India specific cancers, like for example, head and neck cancer and gastric cancer, and how this molecular dimension is predictive of the nodal burden. Now, I do not know whether it is a coincidence, but you see in one part of India, the work is on predicting the nodal burden based on a molecular dimension. And actually, in other part of India, I was reminded of that paper where the group predicted in head and neck cancer the lymph node metastasis with a regression model with grade LVI, PNI, and tumor burden. And we are very privileged to have, madam, the Aditi Nusrat score. Actually, that paper is very landmark, and I think everybody should read that. And Professor Nusrat Hussain, it is my privilege to welcome you, ma'am, here. So she is the professor and head of pathology and officer in charge of State Referral Center for Lab Investigations at Ram Manohar Lohia Institute of Medical Sciences, Lucknow. She had been dean of that institute for many years. She has been awarded many awards, President of India Silver Medal for Best Women Student at the university, then followed by different awards from the Government of India, multiple projects, more than 28 research projects, and actually the research papers more than 300. So she has guided many PhD students. So she is really, her career reflects the physician, scientist, and how the research, translational research in India should be. So I welcome you, ma'am, here and to deliver the talk on genetic testing and application of precision medicine. Welcome.
So thank you so much for your warm introduction, and it's really a pleasure to be here at AIIMS Bhopal. Amazing hospitality since yesterday, and I really love being here. So we've had really two amazing talks in this session, and I am kind of naive compared to how much you have gone into details, and you guys are expert in the area of genomics and proteomics and epigenetics. What I am standing here today is as a pathologist and with an interest in molecular pathology. So we've set up molecular pathology in terms of diagnostics, and I will run you through the possibilities that are there in terms of precision medicine as we are discussing today, and what role and active role the pathologist or the lab can play in terms of precision diagnostics. So this is precisely the topic that was given to me. And I've actually put it down entirely there, and this is what I was required to do, was real life scenarios, clinical cases, illustrating how the genetic tools can be applied in practice. So this is what I'm going to look at. The roadmap of my talk is that we talk about diagnostics in precision medicine. I will apply this through cases. I will look at a case of colonic cancer, and those of you who've gone through medicine, you have a long case, so this is your long case for today. And then I will look at breast cancer, which is an old chip on the block. We have been looking at the ER/PR and treating them accordingly since a long time. Then we will look at lung cancer, which is an amazing success story and which has gone to the liquid biopsy and is actually very much there on the cards as far as precision medicine is concerned. Then we will look at soft tissue sarcomas, and we know today they are classified by the mutations that they have, and therefore there are some mandatory testings and therefore targets that are present out there. We will look at gliomas and endometrial cancers. Gliomas again have a very genetic based classification, and they are even looking at methylation subsets to say what type of glioma it is. And then hereditary cancers, the question arises, we are talking about gastric cancer, we had an amazing lecture. Are the hereditary subsets of that gastric cancer different in terms of precision medicine? And then Genomics applies much more, and we can even go in for genomic screening. As again, you said that you can look for liquid biopsies, look for the histones, and and see whether you can screen in liquid biopsies for specific cancers or for cancers as a whole. So just picking up this comment from Antonio Wolf on the Twitter, which is he says about precision medicine. He says precision medicine applies a degree of diagnostic therapeutic accuracy that we wished we had, but we don't. So at the start of this lecture, I wish to put a caveat out there that when we are doing all those diagnostics, and as Dr. Gupta very rightly pointed out, there are a lot of things that are playing a role. When you're looking at the gene, are you actually detecting the entire changes which are present there, number one? And the change that you're detecting, is it actually going to manifest in the patient and function? Those are questions that remain unanswered even when you go with this. So our goal in pathology today is precision, and the secondary goal therefore would be to achieve a precision in medicine. So we have limited knowledge when it comes to morphology. And in morphology, we have tried to look at parameters, we've tried to grade tumors, we've tried to look for stromal invasion, and we've tried to look for desmoplastic reaction. And as you referred to my paper, we've tried to look for, whether the lymph node is involved, whether tumor budding is present, how much extent of invasion is present. You're measuring multiple things. I told the students today that in pathology, now we have become big measurers. So we start measuring a lot of things, and we try to do those measures and say how much this is going to change. And the treatment also changes when we tell them that this stage is now stage 1C and now this is stage 2 and so forth. So that is the limited knowledge that we were working with. What more can we add here? So we can add the molecular components, which is now mandatory in situations. And then, as you said, you needed to know what are the methods that we can use. I'm not going to get into the methods. I'm not going to bore you with the details. I just need to tell you that we have low throughput methodology. We have high throughput methodology. The low throughput we are talking about is like a PCR based method where you're looking for a single mutation or maybe a cluster of mutations, like you are doing for the EGFR in lung cancer. I believe you're doing it here. And then you can have small insertions, deletions, large duplications. You can see here that there are certain methods that permit you to do certain things. So before you go for a test, you need to be sure that this method actually addresses the issue that you want to address. So what are we looking at? We are looking at morphology, and then we are further splitting up this morphology into a spectrum of molecular pathology. And what are the methods that we are going to apply is something that we need to decide when we are doing this. I prefer personally to use approved kits in my lab so that I'm not answerable for those subjectivities of a homegrown kit. So that, especially when I'm addressing a report to the patient, it has to be a kit which has been validated and approved for clinical use. So either IVD approved or FDA approved for clinical use is what's there. So what is there in our gamut when we are looking at the diagnostic thing? We have got the microscopy, we've got the histology, we've got the IHC then. Next step was IHC, like for breast cancer, you started doing ERPR, HER2 and so forth. We've got the genetics, and then we've got the microarrays and detailed expressions. We can walk the whole genome. I was just attending one of the lymphoma clinics in Dr. Borji's lab the other day when I was visiting Bombay, and I was actually like, it's very much there in clinical practice. They had a case of a child who had a plasmacytic proliferation which was looking monoclonal, but we know that neoplastic plasma cell proliferations are not so common in children, and they had they had done actually a complete genomic analysis of that kid and found out that it was a syndromic association where you have a monoclonal plasmacytosis which is not actually going to convert into neoplasia. So this is something that is now actually very much there, and as pathologists, as diagnosticians, as people in translational medicine, I guess we will need to get into this. So we are convinced omics technologies are necessary for precision medicine. Yes, definitely. In this age of personalized medicine, no single result is going to determine the patient's outcome. You will have to have multiple complex tests to be integrated, and you will have to have algorithms. And these algorithms can be built through AI, where you introduce your various factors and finally you come up with a treatment outcome or a prognostic outcome or a predictive outcome. So with that, as I promised, we are going through cases. So this is case number 1. And this is a 34-year-old female who presented with pain in the abdomen. She had bilateral ovarian masses, a mass in the right hemicolon, and along with that, multiple omental nodules. So obviously a stage 4 disease. And surgical clearance was done in this case in 2021, including a transabdominal hysterectomy, left salpingo-oophorectomy. So everything which was involved was taken out. And this was what the tumor looked like in the colon. And then you had those multiple colonic mental nodules. You had the bilateral ovaries, and this was the morphology. For those of us who are pathologists, this is a mucinous adenocarcinoma of the colon. Okay. So we looked for parameters here, to influence the treatment. One of which would be the LVI. We looked for the tumor budding. We looked for the lymph node involvement. We looked for the serosal breaks. So these are all part of this is the tumor budding. You can see very nicely. This tumor is a high budder. And to be definitely, defining that this is colonic, not coming from the ovaries who also have a mass, you go in for an IHC. So then see what I'm trying to illustrate through these cases is the stepwise evolution of how you become more and more precise. So you do an IHC to be very sure this is colonic, not ovarian. So this patient is now CK20, CDX2, SADB2 positive. So we know that this is now a tumor of colonic origin. And so the diagnosis is adenocarcinoma intestine with mucin production and signet ring cells. So signet ring cells, that word tells the surgeon, this is a poor prognosis tumor. Then large vessel LVI, again lower prognosis. High tumor budding, again lower prognosis. Serosal invasion becomes a T4 lesion. And then lymph node metastasis, omentum is clear. Then there is bilateral Krukenberg tumor of the ovary. There's bilateral fallopian tubes are clear and so forth. So that is the staging that we give as the pathological staging of the tumor. So what are now the next possibilities for this? What is the molecular screening for colonic cancers? In other words, the possibilities here can be either we can look for molecular studies for prognosis and subtypes. We can do biomarkers for prediction and drug selection. That's what you're interested in precision medicine. You can exclude Lynch syndrome and other hereditary disorders, which we do as a routine for all colonic cancer cases as per the Amsterdam criteria. So what can you do to exclude the Lynch syndrome, especially in mucinous cancers? And for the pathologists in the audience where you have a lot of lymphocytic infiltrate at the progressive margin of the tumor, you are likely looking at a case which is Lynch. So you must go in for your MSI studies. And so you do your MSIs. And this was the MSI study in this case, which had no MSI loss. Okay. So you have all 4 of these. So why do we do this? It's for screening for Lynch. This also predicts a response on the PD-1 axis inhibition. So if your tumor is MSI high, in that case, you are likely to have a PD-L1 positivity, and you're likely to put this patient on the immunotherapy group. And it also provides prognostic. So what is an MMR test? An MMR test is either done in IHC or by NGS. IHC, if you have the tissue available for the patient, so the patient tissue will have a loss. And usually these MSI, the dimers, they are kind of in sets. So you have an MLH1 and an MSH2, and they pair with these. So all these 4 markers, they are run. And, they have a nuclear activity, as I showed you here, a nuclear marker. And if there's a loss, then in that case, there is a loss that is present. You also sometimes look for MLH promoter methylation assays, and these promoter methylations are also targeted in terms of treatment. So this is, I'm showing you the MSI, which is preserved, lost, preserved, and equivocal. So again, for all testing, there will be some equivocal, and you must admit that it is equivocal, not try to kind of box it into a positive or a negative there. So Lynch syndrome, why do we need to test it? We need to test it because the family may come back with a colorectal cancer, and the patient himself or herself may come back with many more other tumors at other sites. So that's why we need to test this patient out for Lynch syndrome. Now, what happened to the patient that we were talking about? So this patient was followed up, and after like about 14 months, she came back with multiple omental nodules, and a guided aspiration from the omental nodule was done. This time they wanted to. So earlier she was given a standard chemotherapy of 5-FU and Flofox, I think, Folfox, and now they wanted to give her a targeted therapy. So we ran the NGS for the colonic panel, which we have from Iron Torrent, and these were the mutations that we found there. You can see here that the EGFR is mutated. Okay, so what are the possibilities? What are the targets you can use in colonic cancer? As you can see here, you've got the EGFR, you've got all these growth factor receptors, you've got the VEGF targets, you've got the HER2 target, you've got the PDL1 as an immunotherapy. So all these are possibilities that can happen in colonic cancer. I like to kind of so in this patient the anti-EGFR therapy could be given because we didn't have the KRAS mutations. And so the KRAS mutations, they confer kind of an unlikely benefit from anti-EGFR. So if the KRAS is present along with the EGFR, then again, this patient is not going to benefit. So this is what the workflow looks like. You can take your sample either from the tissue block, you can take it from even an FNA. So if you're planning to do the molecular upfront, you can collect your FNA as a flush, or you can scrape it even from the slides we've done after scraping from pleural slides, from fluids. We can scrape and do it, or you can even look at liquid biopsies if you do not have any material from the tumor directly. And then that's how the flow looks like. I'll not get into the details. So, and basic NGS getting done there. So you have a recommendation statement, as I've already said, and if the KRAS mutations are present, the sample we've discussed, you can use either the tissue blood, the cfDNA, and this is the way you can triage the sample. So there are methodologies where you can do a laser microdissection of the tissue. We do it manually. So what we match the slide with the block and we mark the tumor area as seen under the slide, and then we scratch that part from thick cut sections, and we use that too. So you can, the other thing that I want to point out here is in this case, with this case is that, your results may not always match. So like in this case, the omental nodule aspirate versus the FFPE block, and you can see here that the P10 mutation which was present there earlier is not identified here. So is this really a change or a loss, or whether this is a problem with the methodology, because now you're not using the FFPE sample per se. So this is another thing that I want to put into your mind here with this, with this whole process of using testing for precision medicine, is that your tests will always have a sensitivity issue. And we went into it, actually, the total number of reads, the coverage depth, everything was pretty good. So we couldn't really explain why the P10 was not there in the second one. And you could see the cellularity of the sample was also pretty good. So it wasn't as if we didn't have tumor tissue as to why this was happening. Okay. And then we looked into literature to see what the comparisons are. And unfortunately, the ascitic fluid, when tested, has a very poor concordance. But the pleural fluid, on the other hand, has a fairly good concordance. So for lung cancers, that's why if you don't have the biopsy sample left, people use the bronchoalveolar lavage, they use the pleural fluid, they use like a lot of samples that can, or even cell blocks made from. So just continuing with our long case, how would you kind of club these testing for colonic cancers? As we said, you have a ven in which you could put an MMR, okay? So your MMR is positive, it's kind of positive. In that case, the possibility of a PDL1 testing, and this PDL1, if positive, again in the PDL1, I want to point out that there are multiple clones by which you test. So for anybody who's doing a PDL1 testing, please make sure you're using a compatible clone for testing for that particular cancer. So, you can't just randomly use one clone. So one clone doesn't fit all cancers. You have to use the one that is specific. Also, there is a match between the drug and the clone. So if a particular drug has to be given, then that particular clone has to be tested on the tissues. Then additional to PD-L1, just looking in tumor cells, you can do an immune score, you can do a composite score, and you can also do certain things like immunoscores where you're looking at proportions of CD3 and CD8 positive cells to all the cells that are present there. And these again are known to have good prognostic value in classifications. Where do we look for PD-L1? In normal situations, we kind of do random fields and we do a percentage, but we make sure that the immune cells we are counting are within the 20x field of the tumor. Don't count immune cells away from the tumor. Okay, 20x field of the tumor is where the immune cells are the TILs to be counted. Or in certain like MMR deficient cases, sometimes the advancing edge of the tumor has a lot of PD-L1. So you might want to consider counting it there. But if you've done that, please mention that you've done it at that site. So this is one of our studies where we looked at PD-L1 expression in colorectal cancers, compared it with all the other mutations. And there was some sort of with the BRAF mutations. So our data actually supports the findings that an immune complex inhibitor along with a BRAF inhibitor might promote a more effective treatment. Of course, this needs to be validated. This is just a very preliminary analysis of the mutations that we found in 84 cases of colonic adenocarcinoma. This is the old data. So continuing with the MMR story, within that MMR Venn, what more can you do? You can do tumor mutation burden testing. Okay. So tumor mutation burden testing, again, very frequently now asked by medical oncologists. And again, this is a parameter where high mutation burden actually says that these patients may respond better to immunotherapy. And so within this kind of high tumor mutation burden, the MMR actually becomes a part of it. Because that high mutations can be because of the MMR, or they can be because of the pole mutations and other mutations that may be present there. So, and then within this same Venn, you have a small subset which we can have NTRK mutations. And so these NTRK fusions, again, they can be seen within this Venn. So do we function only inside this Venn when we are looking at colonic cancer? No. We also have a Venn which can be of proficient MMR. This was deficient MMR. We can have a proficient MMR, and within the proficient MMR, we start looking for HER2. Okay, so we start looking for HER2 amplifications, and the HER2 amplifications can be detected most commonly by immunohistochemistry, or you can also detect it by in situ hybridization. We know when HER2 IHC is ambiguous or intermediate to, then we go in for a FISH, or you can directly go in for a FISH, and you can also find out HER2 mutations by looking at an NGS panel. So why do we care about HER2 mutations in colonic cancer? Because all these studies, the Triumph study, the Mountaineer study, the Hercules study, they have said that, the HER2 it can kind of be a supportive therapy in cases of colonic cancer. So we've looked at two biomarkers, one within the deficient MMR, we have looked at another one within the proficient MMR. Do we have anything outside this? So outside this, we can look for BRAF. So you can look for BRAF in colonic cancers, and again, this BRAF can be targeted for therapies. So moving on to our next case, which is the breast cancer. As I said, this is an old chip on the block. We won't talk much about it. I think most of us are aware what all is going on in breast cancer. So when we look at the morphology, again, see all the parameters together. Morphology, IHC, molecular, and then the comprehensive, treatment. So in the morphology, we want to look at the size, we want to look at the focality, we want to look at the LVI, we want to look at the grade, the Nottingham grading as we do. So all these parameters, the size, extent, focality, LVI, the TILs, the TILs which are present in the tumor, the grading of even the DCIS, the TNM, all that will tell us the subtype of the tumor. You just showed the subtypes of breast cancer. So those subtypes also matter. the mucinous is going to have a worse prognosis as compared to others. So when our breast cancer is in, how does that happen? So you have overlaps. You have the ER/PR positive, you have the hormone receptor positive breast cancers, you have the HER2 positive breast cancers, you have the triple negative breast cancers, you have and in this nearby the triple negative, you can have the basal like, the claudin low, you can have the immune cell rich, the PDL1 positive, you can have the ones which are responding to the PARP therapy. So the therapeutic targets, as medoncs here would very well know, they would then target the hormone receptors. In the triple negative is the most difficult group to treat actually, because you're in HER2 you are targeting HER2 with trastuzumab or other drugs which have come up. Triple negative is the difficult group to treat, as well as the presence of other mutations may kind of problematize your treatment. So you need to look for maybe the ESR1, the PIK3CA, and so forth. You can sometimes have a truncated HER2 protein. So it may show up positive in IHC, but then it's truncated, so it's not going to, it's not, your therapy failure may happen because of that. The triple negatives, interestingly, are again classified. I love asking these questions when I go for faculty interviews, and I usually don't get a reply to it. So I say that in all my talks. So these triple negatives have a further categorization, and these are the immune modulatory ones. You have the basal-like, you have the mesenchymal, and you have again the luminal androgen type. So your triple negative can express androgen, in which case they might target it with androgen markers. Then these ones which are immunomodulatory ones are the ones on which the PDL1 is going to act, and the PDL1 therapy is going to act, the immunotherapy. And then you have the basal-like, where the PARP inhibitors are playing quite a role there. So again, with every case, I'm going to tell you some problems. The problem here is fixation. Okay, breast cancers, you send a true cut biopsy, you get back a beautiful result in your ERPR. You send us the full sample. You said last time, ma'am, you gave 80% ER positivity. Now you are saying it's only 10%. The reason is that tumor was now inside that huge breast with fat. The formalin did not get inside the tumor in time. So I always tell my surgeons that if you're going to send the specimen in late, please put a cut there, at the base, and let the formalin reach the tumor, or we ask them send it to us immediately. And then we like to paint the margin and cut our thin slices. And I usually like to section my 2 tumor pieces on day 1. So what happens is that those pieces run early also. There are no delays in my hormone receptor results, and those are well fixed samples because they have been fixed for 6 to 72 hours. That is your time period for fixing. So if there is a hartal going on these days, if your samples lie around for 5 days, again your ERPR is not going to work. Okay, so that's important. Then what next? You've done the IHCs, and they still want to categorize, and they want to be sure whether chemo can be given, cannot be given. There are certain scores like MAMA scores which you can put, or you can go for an oncotype DX or for a MAMA print. One of these, recognized molecular conundrums where multiple genes are tested, and they are able to categorize your tumor into the categories using these kit-based testing. So from primary tumors to metastasis, things can differ. Okay, so again, as we had discussed, the heterogeneity of the tumor. So certain areas of the tumor may get treated. Post-treatment also there will be changes. So we have done a study where we have compared the markers pre-treatment, at least pre-NACT and post-NACT when the breast was taken out. And there was a change, believe me, of almost 25% in the ER. And the least change we had was in the HER2, which was around 8%. So the question arises is that if that change is occurring, what do we treat this patient as? First she was ER positive, now she's ER negative, post NACT. What do we take the patient as? So I researched literature and our own recommendations. We feel that Either of the time, if she was ER positive at some point, she does have an ER positive subset. And so they would be considered positive until somebody else decides to do more studies and prove otherwise. There are no recommendations further on that. Lung cancer already targeted a lot. Okay, huge success stories. I encountered in literature. They tell you there is like a 50% survival gain. The patient was surviving for 4 months, now surviving for 8 months. Do you really think that 4 months is a 50% survival gain? But anyways, I leave that for you to think about it and ruminate. I'm here to tell you what's available. So what's available? In the 80s and 90s, unselected cytotoxic chemotherapy is given for lung cancer. In the 90s, histology-based cytotoxic therapies, we decided to say squamous cell carcinoma, adenocarcinoma. I remember when I was a resident, it was always squamous cell carcinoma. And now it's always almost like 80% adenocarcinomas. Why this change has happened, I really don't know, but that's there. And as the graph also shows you, adenos are way more. And then in 2005 onwards, genomics driven therapies, and then you have that whole array of therapies which is out there, from the EGFR to the KRAS targeted, to the ROS, to the MET, and to the immunotherapy. So everything is there. First it was for the metastatic cancer, then it moved on to a small recurrence, then it moved on to the primary line of treatment as well. So that's how the progress has been. The patients are followed up with genomic testing. The liquid biopsy is very much there for lung cancers, and the development of resistance. So with this particular example, I also need to tell you that that case must have fitted the scenario 1.5 years back, but today this patient has now become resistant to therapy. So part of the testing is also testing for resistance. And as you are already doing here, you'll have to look for the mutations which are resistance specific. And it's not just the EGFR therapy, several other targeted therapies have started developing these resistance mutations, and we need to know them and we need to look for them. The tools and tests that are available again, the IHC and the ICC in cases of lung cancer, you can use that for the PDL1, the ALK-ROS. FISH, we were doing earlier by ALK, now we just do it by IHC. It's good enough. The ALK and ROS and the MET. And then you can use the RT-PCR for the EGFR testing. And the NGS, we have an iron tolerant panel for the NGS, which for the rest of the markers. So if you need the entire panel, then that you can use for the testing, and that's the resistance mechanisms. And so that's the take home lesson from the lung cancer, is that resistance can develop. So it's not just a one-time testing, it is a progressive testing that you'll have to do in precision medicine. Liquid biopsy is just a small word. I'm sure all of you are pretty literate on them, so I will not spend too much time, but we've worked a lot with liquid biopsies. And you can look for either the circulating DNAs, you can look for the circulating tumor cells, and you can look for exosomes or exosomal DNAs, miRNAs, long non-coding RNAs, and so forth. So the advantages, you use different fluids, as I was talking to one of your research in translation medicine today, and she said she was using urine. So, I mean, you can use any fluid for the liquid biopsy. We have mostly used serum and plasma, but suppose you're looking for gliomas, literature says CSF is a better sample. If you're looking for mutations in urothelial cancers, obviously urine is the better sample. So some samples, how easily they are available it also depends on where the tumor is, how easy the sample is available. CSF is a sample that neurosurgeons don't like taking out, because you have issues of raised ICP in cases of gliomas. So you can't just pull out CSF and have a danger of herniation in those cases. So in our experience, we've looked at the gallbladder cancer. Majorly, we've looked at a fair amount in adult diffuse gliomas. In breast carcinomas, oral cancers, lung carcinomas, we were very happy initially when we started doing liquid biopsies way back in 2014, and we were able to measure the levels. So we started doing levels in every tumor that came to our lab. And so we got these pretty high levels, and we published that. But then finally, the question always arises is that the DNA can come from inflammation also. So if you have a large tuberculoma sitting somewhere, that's going to have necrosis and push DNA. How do you know that this DNA is actually tumor DNA and it's not? So you can look for methylation, maybe, you can look for epigenetic changes in that DNA, or you can look for specific mutations in that. Okay. So in these particular, I'll just run through this. I think most of us are aware. So you can look for specific mutations, like for lung cancer, you have an approved, FDA approved test by which you can look for your mutations there. And we ran these in the gallbladder cancer, creating our own set of primers by which we ran them. And we started looking for mutations. In what we did was we matched the tumor and the serum. So we ran the mutations in tumor, and then we ran them in the serum to see that the same set was present in the matching samples in the same patient. And so the cfDNA quantification values are here. This is also, they're fairly high as compared to the normal controls. And then we looked at the diagnostic value, looking at the global methylation status. This work was done by Swati, my PhD student, very bright girl. But now she's sitting at home with a baby. I hope she'll come back to work. And the limitations of cfDNA analysis, as I told you, is that, you might be quantifying other DNAs there. So we started looking at genomic profiling of gallbladder cancer, the targetable mutations and pathways involved. Gallbladder cancer somehow hasn't been worked on too much because the West doesn't have it. And we have this really intense belt along the Gangetic plain. So I felt that let's do it and let's find what the targets are there. And we found a fair number of targets which are there for colonic cancer, are also there in gallbladder. Apart from that, a few others. So then we kind of did these match sample assays, and we realized that our cfDNAs were working pretty well for gallbladder. And the data here is again now for the gliomas. Okay, so we did the same sort of a thing in gliomas. We did not collect the CSF, we did it in the serum, and we found pretty good, values. The other thing I was actually concerned was when we were doing these values was that, how does the cfDNA change over time? Can I, looking at the cfDNA, be able to say that this person is a responder or a non-responder? So, you have the CT scan, and the radiologists say that when there's a lot of necrosis, when there's all those radiation-induced changes that are going on, I cannot immediately say whether this person is responding. Sometimes, because of the necrosis, the size actually becomes bigger for a while, and then it goes down. So can we, by looking at this, so what we did was we did serial measurements of the cfDNA at 3 weeks, at 6 weeks, and then again at 12 weeks. I will tell you very honestly, the results were not like so perfect like a graph. Some cases had nice results. We matched them subsequently with the response status by RECIST criteria in the by the RANO criteria in the CT. But they didn't all show that, but definitely there was like an increase at the first 3 weeks, and then there was a decrease sort of a pattern that was going there in cases of the responders. The non-responders, some of them continued to have a peak, but not all of them. So that was, and then we went further to look at the IDH, the ATRX, and genes in there. The third gene mutations, we tried to look over there in the cfDNA, and yes, we were able to detect, not in all cases. For instance, if there were 10, 4 or 5 of them showed the mutations, others did not. So cfDNA in our hands does not have a complete sensitivity for detection. You can try if it's working well and good, but a negative does not mean a negative result. The circulating tumor cells we looked at only in gallbladder cancers, and they have been looked at by several people in several tumors. The disadvantage is that the number is very few. So if you want to further go and do some genetic testing in it, you have very little material on hand. Only the advantage is that this is definitely your tumor cell, right? So you've defined it, you've looked at the ABCAM, you've looked at the other markers. So this is definitely your tumor cell. And people may want to culture them, do things, but again, when you culture, you're going to cause changes. So I don't know how much, that's going to work. So CTC workflow was something like this. We concentrated the cells using the EPCAM, the CAD and the CD45 staining. And we used actually flow cytometry. You can actually try it. We used flow cytometry to separate our cells, the CTCs. And this is what we did. We've also looked at the microRNA, the non-coding RNA. What I thought was that since nothing is perfect, I mean, neither is the CTC, the CFDNA perfect for gallbladder diagnosis. So can we come up with like composite diagnostic tests where you have a set of miRNAs, you have a set of long non-coding RNAs, and then you have the circulating mutations. And then, you can use this as a pre-screen. Now, where will this pre-screen be required? In gallbladder cancers, patients come, they are diagnosed radiologically by looking at thickening of the wall. But the thickening of the wall can occur in cholecystitis as well. And we know there's a condition, xanthogranulomatous cholecystitis. So there is a major overlap in the two conditions when it comes to the radiology. And maybe those subset of cases can undergo this test before the operation to know whether they have the tumor or not. Why before? Because the line of treatment then varies. If you find an incidental GBC, the surgeon goes back in and does a complete resection afterwards. So you are actually saving one additional surgery by doing this. So that was what the ICMR funded us for this project, on which we came up with this test, where we came up with a cluster of microRNAs, a cluster of long non-coding RNAs and mutations which could possibly be used together to diagnose. Our test has not reached the bedside. We've published it though. But what are the tests which have reached the bedside? The question arises. So there are a lot of tests at the bedside. We talked about the lung cancer, but there are a lot of them if you start searching. So for single genes, for multiple genes, for even screening for whole cancers as a whole. So, just like a whole lot of tests out there. So for breast cancer, for colorectal, for NSCLCs, for in the lung, for urothelial. So you have multiple tests which can be used for, approved liquid biopsy technologies, which can be used in the clinics. So the bladder cancer detection one has become quite popular. The Eurovision also applied in urine is also by fish is also quite popular to confirm that the cells you are seeing are actually tumor cells. So, and then you can have cancer, multi-cancer indications where, 324 genes, 73 gene panels. I heard a gentleman who was presenting his data on this multi-gene panels, and I don't know if it's like the new ASCUS, like, you would say, the sensitivity of the test was somewhere around, the specificity was around 58%, which means you're over-diagnosing 42 out of 100 cases. So, you would actually cause this scare. I mean, I go for a screen and whether I have any cancer in my body, and then I come up with a positive test, and then I need to go for all the testing, which is the CT, the MRI, and the complete screen after that. So am I actually going to cause a huge load on the system, which is already overburdened by doing tests like these? So this is another thing I need to kind of put forth as one of the, the lessons from this talk is that, we need to analyze those tests, where and when to use them, because we don't want to go in the wrong direction when it comes to, just coming up with a test. That's not the right approach. And then selecting molecular tests this is for the pathologists in the audience. You can have a single thing you need to test, okay? You can have a small, medium size NGS, or you can work the whole genome as we talked about. So any of these, depending upon what you're looking for. You know the target, you do your single gene analysis. You want to do a cluster, multiple targets together, use the small NGS. You don't know what's going on in this patient, you use the comprehensive genomic analysis. So the molecular tests can be targeted or they can be comprehensive, or as you can say, they can be low throughput, they can be high throughput testing. You have translocation associated carcinomas, sarcomas, and these definitely need the fusions to diagnose them. Just one last case of a 2-year-old girl with a sacral mass. Yes, any guesses on this one? All the markers are right there. Come on, pathologist. AIIMS, right? That's what you would say. That's what you would say. That's what I would say. But something bothered me here, this is a nodule. How often in RMS do you get so much sclerosis and nodule formation? And it's a 2-year-old child. It's an abdominal mass, a sacral mass. It's inside the abdomen. So anything else you want to think of? Yeah, maybe you know a DSRCT, a desmoplastic small round cell tumor. So that will also show you muscle markers. And you need to think about that, and then the FOXO fish cases. So this is a DSRCT. So the treatment changes, the entity changes. So in terms of precision medicine, my last year, when is the testing required? So you have companion diagnostics and you have complementary diagnostics. Meaning thereby, you have mandatorily to do the test before you give the drug, or you may decide to have the test done and give the drug, or you may give the drug even without test. So for EJ, for instance, I'm just showing you this study, this GAIN consortium study, in which their aim was to look at, get these patients and do a matched targeted therapy of these patients identified by tumor profiling. Okay. So this was like one of the extraordinary responder cases. This was a case of neuroendocrine carcinoma, and you can see the extreme response that has occurred in this case in the pre and the post MRI. But this is the interesting part. When they analyzed their results, they had these 194 plus 46 cases, newly diagnosed relapse cases. In this, you have 2 subsets which received the treatment. The matched ones, you can see above in the newly diagnosed cases, there were 5 matched ones. In the refractory relapse cases, there were 26 matched ones. All right. So the 5 and the 26, they underwent treatment. And the extraordinary responders in these were only 6. So even when you match and do the therapy, I come back to the point that Dr. Gupta was putting up there, that genomics alone doesn't work. So you matched, you've done the therapy after matching, and you can see here that this is the result. This is like the interim result of that gain analysis. So that's it, Then I told you in the beginning that there is the classification is also now molecular, and as these, the WHO books is what we follow for the classification, and now finally this classification is all molecular. And for example, when you're looking at the pediatric diffuse gliomas, those good old histones come in, and you have to look for the histone mutations out there to actually diagnose and classify these gliomas. And the good part is that as these mutations come in, the complementary IHCs come in. So it becomes more accessible to us as diagnosticians that we can do the IHC. But somewhere along the line, you have to go for genetics. So I would really, recommend very strongly that most pathology departments who are coming up, especially in all big institutes, must have a molecular pathology subsection these days. So finishing with this case, this is I don't know when I'm going to finish. I keep saying that. So if we can finish here. If I'm going over time, I'm like okay with it. Yeah. So this is you can all say endometrial cancer, right? Very clearly, uterus showing irregular entire cavity involved. So endometrial cancer here, and pathologists in the audience, what type of cancer? This is a trick, okay? Endometrioid, agreed. One endometrioid. So this has got the squamous modules, etc. So this inside part is endometrioid. But see what's happened here. This is my P16. So when I go back here, this tumor out here, this is serous, and this is the endometrioid part. Okay? This is serous and this is the endometrioid part. And see the P16 highlighting the serous. Not so this is and then your P53 again the serous part, and your ER highlighting the endometrioid part. So this is a mixed carcinoma. This is a mixed carcinoma. Why I am showing this case? Again, this is giving you ambiguity. Now you got two types of cancer you need to cover. So what are you going to cover in the therapy is again an area where the guidelines are giving you nothing, right? So this is a job of the pathologist to say what is the major component that is present out there. So when you say mixed cancer, when 5%, at least 5% of any other type of cancer is present out there. And then you look at all these clinical pathological features and you kind of identify the actionable targets. And endometrial cancer is one which has undergone again a molecular classification. So this is another example. Like glioma, this is also molecular classification. Breast, you have a molecular classification. So you have molecular classifications now. These classifications are not just for the heck of it. These classifications are because they have certain targets in every group. They have a different prognosis in every group. So this is not a histological classification where I say, this is a mucinous tumor or this is like, it's not no longer that. They've eliminated even those morphological categories which did not have any prognosis and therapeutic meaning. Now only those subtypes remain which are prognostically different, and those subtypes are molecularly classified to have a meaning in terms of precision medicine. So very much pathology is there for precision medicine. That's the bottom line. The pathologists need to develop a capacity to do and to deliver so that there can be a comprehensive diagnosis. For the gastric cancer, as I mentioned, you have hereditary cancer syndromes. You have hereditary cancer syndromes at multiple sites. So are there any targeted markers that you can look at in these also? So you have certain landmark studies for the inherited cancers out here. And for gastric cancers, there are targets that you can use in terms of the ECAD mutations that are present in gastric cancers. You can use the HIF2 inhibitors for the von Hippel-Lindau syndrome. You can use the anti-PD-L1 for the mismatch repair genes and the PARP inhibitors in the breast cancer again for the mismatch repair gene types. So this is just to show you the evolution of therapies as they happen from December 14 to 23, and the colors are for the various cancers. Like the purple is the ovarian, the green is for the colorectal, and so you can see the changes, And if I actually just grossly analyze these changes, the changes are first they started the targeted therapy for recurrent and metastatic cancers. Then gradually they said, okay, fine, large cancer, bad stage. And then gradually they came to a primary point of treatment. So primary point of treatment is now there. The reports have to be comprehensive. They have to inculcate the presence of these mutations. So that's the hereditary gastric cancers where you can target. And screening also you can do by molecular methods. We all know that the HR-HPV is what is approved for screening for cervical cancers. We have done a study in our outreach program in Raniganj, Amethi. And here we had screened 10,000 cases using HR-HPV, but more importantly, we have used the self-collection model involving the CHCs, PHCs, and the ASHA workers. The ASHA workers delivered the vials at home. So what I want to bring forth with this is that, the molecular diagnosis can reach home as well. So this is what I'm trying to say. And you can just give the vial, have the collection, and you can test at your center. So you can have a hub spoke model for testing. You don't have to have every small lab doing molecular because there are issues of quality control. There are issues of expertise when you are doing these tests. So you can have hub spoke models, and you can have hubs at the periphery and spokes who are doing the diagnosis. And then you look at, so these are what our results look like. In these patients, you had almost a positivity of 4.4% positivity. And what is really interesting data here is that the other HR-HPV are very prevalent in our samples. So this was a test which was done at the site, a molecular test for only 16, 18 and two other HR-HPVs. And this was for the other HR-HPVs, and you can see that there are a lot of other HR-HPVs. This bothers me. So why is it important, this study? This bothers me because when you are addressing the vaccine program, you are only covering 16 and 18. You are not addressing the other HR-HPVs, which are so prevalent in our population. I think this study should, kind of be repeated at other places. And you should find out, because if this is happening, then your program needs to target both on the vaccine and the screening, and a continued screening beyond that 50 years in which they are saying that they need to screen. So these are the numbers at a glance as what we got. And in the future directions, as I already mentioned, the artificial intelligence will have to come in. You have so many parameters from gross, microscopic, molecular, IHC. They will have to be integrated into some equation where in the end of it, you know how these AI models can predict what is going to happen. So thank you very much for your patience. I finished at 5, I think, not over. Any questions?
Compliment, you brought the glory back to the founders.
Oh, thank you.
Any question?
But what is observed now, for example, this kind of AI and molecular diagnostics within a span of 2 to 3 or 4 years. So the challenge is also on the medical curriculum for the students, like how to adapt the training program with this changing landscape. So with this, I think we will move to the section of intramural projects. We have 2 intramural projects presentation in this section of precision oncology. So Dr. Neha Arya and Dr. Yogendra Yadav, they are the presenters. Are they here? So Dr. Neha.
Thank you, sir. So at the outset, I would like to thank the organizers, especially Devashishwa sir, for having this session of the intramural grants. Amidst the stalwarts who've presented in the last 3, and I think since yesterday, this is a very naive and pilot project, and we're just trying to dwell in this area, which is basically develop an in-house multiplex RT-PCR based biomarker panel for cancer, a precision oncology approach. And before we move on to actually what I have proposed in this direction, I would just give a glimpse of okay, so this is the outline of my talk: introduction, rationale, objectives, methodology, and expected outcomes. And before I dwell into the project, I'll be discussing about things related to the work that we've been doing in our lab. So research from our lab actually okay, so basically, although the project is about development of an in-house diagnostic kit for detection of EGFR mutation from for lung cancer, however, I would like to tell about few other projects that we've been doing in our lab, which also fall in the category of personalized medicine, in the sense that we are developing patient-derived organoids in the lab. And we've developed this device, which is this project was funded from BIRAC and patented it, wherein we can develop as many number of tumors from patient samples as we want, and this can be used for drug testing application. And we've shown that the tumors that are formed in these devices are quite similar to the the patient tumors. So
Then we've also developed some other scaffold-based tumor aggregates in our lab, and which we've used for drug testing application. Yet another project, we've developed oral cancer-based spheroids, which we've actually shown that exposing them to microRNA 155 inhibitor caused sensitivity to cisplatin. We've also developed few other multicellular spheroid based on hanging drop method. And yet another area in our lab is to, next slide please, is to work on the chemical, mechanical and topographical cues that influence breast cancer metastasis. So we are trying to develop different types of biomaterial based models, like trying to see how the chemical factors in the ECM, the mechanical factors, which is stiffness of the tumor, and the topographical factors, how all of these are responsible for breast cancer metastasis. So this is just the introduction to the work that we're doing, but now coming to the main project. Why we've choosing this is because this is all a very mundane slide which tells that cancer is the leading cause of deaths, especially in the high-income countries, and which surpasses even the CVDs. And lung cancer especially is the leading cause of, if you can see the incidence and mortality of lung cancer, it's very high in the world. And in the males, it is in the fourth, so it's the fourth, highest cause of incidence in Indian males. So therefore, we're trying to, depending on the discussion with the clinicians and based on the prevalence, we are moving ahead in development of diagnostic kit for mutations in lung cancer. So the disposition of lung cancer is basically because of many factors, which could be genetic or environmental factors, and it's divided into non-small cell and small cell lung cancer. But what is important in this slide is you look at the right part of the slide. The 5-year survival rates of the stage 1 lung cancer is very high as compared to the ones that are detected at a later stage. So the question also arises, maybe we should give the right treatment, or maybe it should be detected at an early stage, and that's why the previous speaker talked about liquid biopsy. So these are few areas that one can dwell into. So the reason why there is because of the in metastasis we see only 10% survival rates could be attributed to various factors and various types of heterogeneity. Could be spatial, interpatient, intrapatient, and temporal heterogeneity, extrinsic and extrinsic factors, and so on, because of which one drug fits all usually fail at the bedside. This we've been hearing since the last 2 days. And therefore accurate assessment of tumor heterogeneity at the molecular level is important, and it demonstrates potential for development of effective and precision therapies. So looking at the molecular testing standard of care for lung cancer, for the non-squamous histology and squamous histology, there are various standard molecular care tests already available, like EGFR, ALK-ROS, BRAF, PDL1, and so on. And while these are already available, and one can easily get these IVD approved kits and start doing the testing, but we wanted to have an in-house kit for various reasons. It's definitely cost effective, and even the turnaround time is quite in place. So because of which we have moved in this direction. So coming to EGFR, it's a epidermal growth factor receptor, member of the ERB receptor thyroid C kinase family, and is very, very important for the development and progression of non-small cell lung cancer. There are very few key mutations which which have a very important role in which can be actually targeted for non-small cell lung cancer, and fall in the category of sensitizing mutations and acquired resistance mutations. So these sensitizing mutations are the ones which are actually 90% of the EGFR mutations in non-small cell lung cancer, majorly falling in the category of deletions in exon 19 and the specific point mutation, go back please, specific point mutation in exon 21. And this demonstrates high sensitivity and prolonged progression-free survival when the treatment is given with the tyrosine kinase inhibitors. However, even though there are treatments given, the acquired resistance mutations have come into picture, and the major ones fall in the category of exon 20 T70M and C77S, which come into picture after the administration of first generation of TKIs. So if we are able to develop a panel that takes care of all these, most important mutations in EGFR, then probably we can help the clinicians at a good turnaround time at AIIMS Bhopal. So please go ahead. So these are the various drugs that are already FDA approved and given for, if someone is detected with lung cancer with these specific mutations in EGFR. And our focus is right now to look at exon 19, 20, and 21. Next slide, please. So the rationale of this work is to determine these, determination of these mutations using in-house multiplex approach that allows for simultaneous assessment of the previously mentioned genetic mutations. That's the need of the hour, we feel at AIIMS Bhopal, and this is crucial. That will identify various actionable mutations and tailor precise treatment plans. And the proposal aims to develop a multiplex PCR-based approach that will enable precise molecular characterization of key, EGFR mutations, those 6 mutations which I've mentioned previously, and could be utilized towards customized treatment based on individual molecular characteristics for patient's tumor. So with this rationale and introduction, the objectives, since it's a one-year project which we were supposed to write, so the objective one is to design and develop a multiplex RT-PCR assay to identify lung cancer specific mutations for EGFR and falling in the category of deletions in exon 19 and few mutations in exon 20 and 21. And the second objective is to validate the multiplex PCR assay in lung cancer patients and also corroborate the data with the commercially available kits. So the specimens will be obtained from FFP samples of lung cancer subjects who are visiting the Department of Surgical Oncology, Medical Oncology, Hematology at AIIMS Bhopal, following approval from IHEC and IBSC AIIMS Bhopal. And considering the frequency of 2 to 4 subjects who are fulfilling the inclusion criteria, a feasible sample size of 36 has been kept for this project. The inclusion criteria includes patients who are more than 18 years of age, who've undergone USG or CT guided biopsy from lung mass, and which have confirmed cases of lung cancer. And the exclusion criteria is the ones who have not undergone any treatment and the ones who do not wish to enroll. So it's a very simple slide wherein the FFP sections will be taken and DNA will be isolated from the sections, quantified, and then we will be developing in-house primer probes for those specific 6 mutations, and we will be carrying out real-time PCR using AIIMS PCR and TACMan-based chemistry. And once we've carried out the PCR, we will also validate the results of the commercially available kits, and we can try to find out the sensitivity and the specificity associated with the data. So the expected outcomes of this work, it's a very, it's a pilot study in which we will try to validate multiplex RT-PCR assay, which will be capable of detecting key mutations, exon 19 deletions, and exon 20 and 21 mutations. And it will also help in providing a quick turnaround time with the ability to tailor treatment strategies based on individual mutation profiles, leading to better patient outcomes. And developing this assay in-house will reduce reliance on expensive commercial tests, and it could reduce the cost per test, and can further be validated on larger cohorts, and it could also be commercialized. And most importantly, it be once we we are able to with confidence in developing this kit, we can move on to other mutations as well as other cancers, and as was mentioned previously, even liquid biopsy based detection could also be performed. So this is the team that is involved in this project, which includes myself and the members of Translational Medicine Department, faculty from clinical side as well, Surgical Oncology, Medical Oncology, and Hematology Department, as well as faculty from Pathology. With this, I would like to acknowledge the director of the institute, the organizers of the committee, and especially Professor Devashish Biswas, my collaborators who've been there for mentoring and for other kind of all the other projects that we've been doing at AIIMS Bhopal, and various funding agencies that have supported our work that I showed you in the first two slides. So with this, I would like to thank you, and I'm happy to answer questions if any.
Biopsies from bronchial biopsies, which are why do you want to leave them? You've written only CT guided biopsy and USG guided biopsy. Bronchial biopsy को छोड़ना है ना, patient CT guided patients are major chunk of bronchial biopsy when started.
So this was a pilot study, and definitely we can add that as well in the inclusion criteria. We're just looking at 36 samples to start with.
EGFR, we're looking at only EGFR3, not FGFR3, because that's very important coming up in Indian population now. Yeah. Yes. So why not FGFR3? That is a very important.
Right.
And
so
if you
I
link-
had a discussion with them. I mean, they're using commercial kits, and I mean, this is just the start. It's the first step for an individual.
Because you will have a DNA in hand,
Yeah.
and when you are putting up a PCR,
Right,
either you put for
right.
1, 3,
Right.
and the
So
second,
that's the good suggestion.
and the second is what is not available in the panel is P53 mutations, and that is also being observed in lung patients who are smokers. So that will also help if you have a epidemiology data of this. And then you link with P53 and EGFR, that will give a different treatment modalities completely. If you can add 2 of those mutations, that will be really beneficial to the society.
And more common KRAS. Yes, although they are targetable. We are not.
There are some drugs are there, but yeah.
So it's like to start somewhere. So this is the start point, and definitely we can, add on to all suggestions that you've been doing.
No, the primer she is designed. Backman based you are designing by yourself, right? FGF3 can add, I think.
No, we can
We had
look into
around
that.
20 or 19 out of 20 patients.
Okay.
Yeah. Yeah. And you have a digital PCRE? Not yet. No. If you have everything, you can in one well. One of the advantages.
I think multi-distinct kinase therapy targets EGFR, FGFR, and PDGFR. So, but multi-tyrosine kinase therapy does not require a tester, as it's a complementary test. So, but for the EGFR therapy, particularly in lung cancer, you require the test, and those particular genes that are actually enlisted there. So, but the idea is good that if you include the FGFR also, your test would be a little different from all the commercial tests that are available. And maybe you will find more FGFR mutations and more patients will be targetable from your test as compared to the conventional.
Makes sense.
EGFR and PDGFR are getting targeted by multi-tyrosine kinase.
Yeah.
So we Dr. Akant.
They are targetable.
The GFR3 is also targetable.
Okay. We can add that.
So TKIs are automatically they are non-specific. Talk about any line. So, but if you know about FGR, your treatments will be little different.
Thank you so much.
I will take only few minutes, 2 or 3 minutes. Actually, this proposal has been submitted for intramural funding. This is not was appropriate for this platform, but I will more happy to get some suggestion from expert. Actually, we are treating the pediatric cancer patient. We are using the methotrexate drug in most of the protocol. So we do not have the facility to monitor the drug level, methotrexate drug level. So we are only treating with the supportive therapy. We have no drug levels to monitor how to stop, how we can modify drug, or how we can prevent the complications. So monitoring of high dose methotrexate related toxicity and their levels in childhood leukemia in tertiary center. This is a prospective observational study. So basically this concept, due to the methotrexate toxicity, this is the common drug usually be used in high dose during the interim phase of the maintenance therapy. So interim phase we use the 3 gram to 5 gram per meter square in BALL and TALL. Normally high dose means more than 500 milligram per meter square. So these can cause the even life-threatening toxicity, including the CNS encephalopathy. So at present, most of centers do not have this facility due to the kits not availability or drug cost constant. So we have proposed this proposal as a pilot study to be started in our institute to start or to monitor some drug levels in our institute. Actually, if we will send this sample outside or through the any outsource lab, so it will take some time to get the report, more than 24 or 48 hours. But if we have methotrexate toxicity, we have to get report within few hours only. So we can plan this proposal in our institute to start the MTX level monitoring for the pediatric oncology patient and even in adult also. So basic rationale is to monitor the MTX level in high dose therapy and to modify the drug, because we follow the same drug level in every patient. If we will get the high levels of MTX level, we can modify this dose in next cycle of the therapy, because we give the 4 cycle of the high dose MTX in interim maintenance in every patient of the acute leukemia, B and ALL and lymphoma. So by this we plan to our object to estimate the MTX level at 24 hours and 42 hours from the start of infusion of the methotrexate, and to see the association between the MTX concentration with the toxicity and toxicity effect in patient. So this I have proposed for the only 6-month study as a pilot study. We will include all the diagnosed case of acute leukemia, and we see the effect of this high dose MTX and their levels during the interim maintenance phase. So we had included only 72 sample. If drop out, we will include 80 sample, or we usually give the 4 cycle in each patient. So around 20% we will include in this study, and we will exclude the patient like which have pre-renal existing chronic kidney disease more than grade 3, or patients who are undergoing the hemato stem cell transplantation, or if we are not getting the MTX level in blood. So this flow chart, as per the flow chart, we will include the all diagnosed case after the consent and the after ethical approval. The serum sample will send in the clinical biopsy, and we will see with the help of the enzyme immunoassay autoanalyzer by the kit at 24 and 42 hours of the 2 sample we will see, and we will monitor the toxicity level. First, we will see the baseline serum creatinine and the baseline CBC. So as per the ICL protocol, we usually follow ICL in childhood collaborative leukemia group protocol for our patient, and this AIIMS Bhopal is one of the site of multi-centric trial which already started under the ICMR. So with this timeline, we usually start the hydration before starting the MTX. 6 hours before. At 0 hours, we start the MTX. Initially, we give the within 30 minutes, and remaining drug we give next 23 hours and half hours, and then we follow the MTS level at 24 hours. But currently we are not following this level. We have no facility. So what we are doing, we extend our the hydration, and we monitor the baseline creatinine at 0, then at 24 hours, and we also see the next toxicity. If there is any baseline derangement, then we modify the drug, or we can even stop drug. And up to the 72 hours, we must admit the patient for extending, for giving the more hydration. So if we will have this level in our lab, we can stop the, we can start the rescue therapy like leucovorin, folinic acid. We usually the 3 dose if we have facility of MTS level at 42 hours. So if we will do the 6 hourly, we will add leucovorin, then we can discharge patient at 52 hours, means in almost around 2 days. If we have not this facility to check the drug level, so we have to give the more leucovorin rescue, like 6 or 10 cycle even. So patient, their admission remain prolonged, and we could not utilize that bed for other patient also. So after this is the last conclusion slide. If we will start this ballot level in our institute, then we can discharge patient as early at 52 hours, and we can further monitor their toxicity level, and we can even correlate with their side effect, and we modify the drug, how to this drug can be modified in next chemo cycle. So thank you for patience. This is some reference. Any suggestion, we are happy to include in our this from expert.
So you mentioned neurotoxicity. What you are going to measure? Neurotoxicity.
Usually we see the if there is any clinical sign like encephalopathy, patient having the headache, so we do the MRI brain. So in MRI brain, there will be encephalomyelitic change. So usually neurotoxicity is not common in MDX therapy, but other toxicity like mucositis is more common, febrile neutropenia, and a renal derangement. So we check these toxicity by simple the serum creatinine and baseline serum creatinine level. We maintain the hydration.
So image-based
yes,
neurotoxicity.
Yes, sir.
Any other questions?
Hello, I'm a medical oncologist, and I want to have one doubt. This is already standard that this has to be followed. The levels after 24 hours have to be less than 10, and after 48 hours less than 1 micromole per liter. So what is like, but what are you trying to?
Nothing novel or new in this proposal. We are not following, or we are not observing level in our institute, or usually in most of institute they have the only facility to check the level. So like our institute, in other institute also they are not following. In some Indian study, we have seen only single level they have monitored, like 36 hours, somewhere monitored at 42 hours. Standard we should do this level. So we just proposed this proposal for the intramural funding. This is only for just
Actually, it's well established that this much level has to be there. And
Yes.
if this facility is not available, then we give more of preventive measures, hydration, and more of leucovorin.
So to prevent the more hospital stay, we can
That is there, but
we
it's
can
not
reduce.
very much standard. And secondly, that facility is also like coming up. It will be coming soon in the institute. So
because it is not available in house. We can send through HLL,
yeah.
but that will again take time, 24 hours or 40 hours. So if we are monitoring drug, or we have to modify drug, or we should stop drug, so reports should be available within few hours or immediately. So I think this proposal was for starting in-house facility.
It's there in the but it's gonna come soon.
Okay, this is not.
Yeah, already in the house we have NCMs. Okay. So we could have tried we could have developed a method for just measuring, okay, for this methotrexate, and it can be used as a routine like for the therapeutic drug monitor. Others one question. And next question, so what is the sampling like time points that you want to measure and you would monitor the levels of methotrexate, and what is the therapeutic range for the extract?
Usually it should be below 0.1 micromole per liter. So if it is level is more than 0.1 micro or within 1.1 to 10 micro, then should give the rescue therapy more, or we can prolong the patient hospital stay. And leucovorin we can give 6
So for measuring the therapeutic drug range, what is the time point that you want to collect the sample? Sample whether you wanted to collect the trough level concentration, or you wanted to like measure like any peak concentration, at which point that you want to collect the sample?
I will send first at 24 hours during the just end of the method.
You want to know the off-life of this drug. What is off-life of this drug?
Sorry.
What is off-life of the method extract? Off-life.
It really will take time to from clearance from the body.
So that's okay. I'm not asking what is the off-life of this drug, okay? Whether it is having a short off-life or long off-life.
No, it will be persist for 24 hours or more in blood. But if we will do at 24 hours, there is cutoff, how we should monitor and how we can add the glucoverin.
So there is monitoring difference there, but just kinetics parameters are like what is the off-life, what is the clearance rate, and what is the mass of this drug. Okay? Based on that, you can like, okay, fix our which endpoints, whether it is a trough level concentration or the peak level concentration, okay, for the sampling. That we have to fix that time point, no.
So as per protocol, we have to take sample only at 24 and 52 hours to see the concentration.
Sir, Dr. Madhu, sir, you want to add on?
The reference number 3 they have mentioned when they have to 36 to 40.
Actually, they have taken
long half-life.
Yes, sir. They have taken only one sample to reduce the cost.
Yeah.
Ideally, we should send
But it
two
has a
samples.
long half-life.
Yes, it is more than 24 hours. Thank you.
Actually, point is that currently method is not available, testing is not available, and that analyzer based test could be developed. It's find some source that they can provide the result. With the autoanalyzer, after getting the samples, we can provide the result within 2 hours. So even with the LCMS, if we do that, it will not be. No, so he has mentioned 2 time points, 24 and
42 hours.
42.
Yes, it is prolonged now, more than 20 minutes. Thank you so much.
Thank you. Thank you. I think what I'd like to say is that this discussion is very interesting. But sometimes what happens is we have to weigh the risk and benefit ratio. The toxicity of methotrexate is quite much if it is not detected early. So clinical, that protocol requires early detection. And I think in that way, this project has a value. So I really appreciate the presentation. So, I mean, now we have come to the conclusion of this session. So I will briefly summarize what have been discussed. Because of a lack of time, I think all the speakers' talks were so clear and precise. There is not much to say. So only 3 or 4 sentences I would say. One point is that early detection is very important, as has been said in the multiple times. And from the first lecture, it's very clear that every cancer has a different latent period. So one part of this research has to go for the early detection, because in India we are having 80-20 ratio. 80% of the cancer patients present in late stage. So that is where one of the focus should be. Second is about the multiple steps that are involved in the carcinogenesis. One has to be observant that there is life within life. There is multiple dimensions of life. So the DNA is not the destiny, that has been said, and we actually now have come to a point where there is integration of the different levels, and that has been very clearly brought out in the third lecture, where the diagnostics as it is applied to clinics have been highlighted through several illustrations. And lastly, I would say that here we are not going to treat CT scan or slides. You know, we also has to be very much aware. Ultimately, there is a holistic medicine also.
So it's a very interesting period of time that we are subspecializing, specializing, and going to a precision medicine. And at the same time, there is an approach towards the holistic medicine. So the balance of that is quite challenging, and is something which we need to be aware of. So I think with this, we've come to the end of this session, and I would request Professor Debashish Biswas to say the.
We would now like to felicitate our distinguished speakers and presenters. May I please invite Professor Debashish Biswas, sir, to present the certificates and mementos. We are grateful to Dr. Mahadev Rao, sir, for his significant contribution today. Sir, please come forward to take a token of appreciation. A big thank you to Dr. Sanjay Gupta, sir, for his valuable contribution. So please come forward. Dr. Neha Arya, please come forward to receive a token of appreciation. Dr. Yogendra Singh Yadav, please come forward. Thank you so much, sir. Thank you so much, all. The tea is served outside. Thank you so much.